Good morning and welcome to Senate Health and Human Services. I'm going to ask Senator Long to lead us in a Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Let's see. Okay, we are going to open the hearing on Senate Bill 545, relative financial eligibility for the Medicare Savings Program. I asked Senator Rosenwald to introduce her bill. We're going to see a lot of you today, Senator.
You are. Thank you, Mr. Chair. For the record, I'm Cindy Rosenwald. I have the honor to represent Senate District 13. And I will note that this has been the Ways and Means Committee room. So typically I'd be here on Wednesday mornings anyway. But I'm very pleased to be here to introduce Senate Bill 545, the Help for Low-Income Seniors Act of 2026, which will help low-income Granite Staters pay for Medicare Parts A, B, and D. It does so by making one change and one clarification to our Medicare savings programs, MSPs, that serve low-income Medicare enrollees who are sometimes known as the QIMBYs, SLIMBYs, and SLIMBY 135s. Currently, we have about 20,000 residents in these programs. So Senate Bill 545 helps low-income seniors in two ways. It removes the asset ceiling of $9,600 for an individual and $14,400 for a married couple that's living together, thereby making several hundred more people eligible for assistance to pay for Medicare hospital and doctor deductibles and copays. This would also relieve the Department of Health and Human Services of the administrative burden of tracking down people's bank account balances. So applicants would still be subject to the income limits. Currently, there's both an income and an asset test. This removes solely the asset limit. Given the large reduction in Medicare Advantage plans that we've seen this year, which had covered nearly a quarter of New Hampshire's Medicare beneficiaries, the fact that MSPs include automatic enrollment in the federally funded low-income drug subsidy program will be extremely helpful to our lowest income Medicare enrollees. Some of them would not otherwise be able to afford the required Part D coverage. Second, the bill clarifies that New Hampshire will continue to facilitate eligible Medicare beneficiaries' enrollment in these federally funded low-income drug subsidies. Congress's H.R. 1 introduced some confusion as to whether states that were already doing this work had to stop doing it for 10 years. So Senate Bill 545 just clarifies that we will still do what we've been doing all along. Mr. Chairman and committee members, I really can't think of anything sadder than someone who turns 65, has paid Medicare taxes on every dollar they've ever earned, but are so low income they can't afford to pay their Medicare deductibles or copays. So they can't afford medical treatment just as they become more likely to need it. And believe me, I've I've met individuals in this situation in my district. I hope the committee will agree that the Help for Low-Income Seniors Act of 2026 is a reasonable approach to a serious problem. Thank you, and I'm happy to answer questions. But there are people who are experts in the room.
All right, thank you, Senator. And if I'm not mistaken, you had a similar bill last year, correct?
I think it was either last year or the year before. It was a little bit different. It removed both the asset limit and raised the income threshold. That was it had a pretty high fiscal note.
Okay.
This just removes one part of it, so the fiscal impact, which finance would consider, would be significantly reduced.
And you have not received any more, I mean, we didn't get a fiscal note with this, but I don't know if they've communicated with you.
So when I had introduced the previous bill, the department had told me that I don't have the fiscal note, but they had told me that removing the asset threshold they thought would cost $3 million. Then I believe they came back to me and said, no, it might be more like $1.5 million. So I think those numbers are up in the air, but probably LBA would get a better handle on it by the time the bill got to finance.
Thank you. And I think we have a question from Senator Avard.
Yes, thank you, Senator. Just a quick question. How long has this asset requirement been in place? How many years?
Well, that the department could answer, but I know that it's adjusted every year. So last time I introduced the bill, the asset limit for an individual was $9,400, so it's gone up $200. It gets adjusted every year, I think, along with the federal poverty limits.
Thank you. That's it.
I think it's probably been in place since the Medicare savings programs began.
Perfect. Thank you.
Are there any other questions for the senator? Thank you very much. Don't go
Thank
very
you.
far.
Well,
All right, thank you. Mary Roberge.
Good morning. My name is Mary Roberge, and I am here to testify on behalf of AARP New Hampshire to support SB 545. It seeks to remove the resource limits for the Medicare savings programs, known as MSPs, and with continued coordination with CMS, will ensure the availability of the low-income subsidy, which is also known as Extra Help, to New Hampshire residents to assist them in their prescription drug costs. AARP New Hampshire is dedicated to advocating for the well-being and the financial security of older adults. SB 545 aligns with our mission by addressing the critical issue of healthcare and prescription drug cost affordability for low-income seniors and disabled individuals. This bill has two significant changes. By removing the resource limit, SB 545 ensures that individuals who have a modest savings or assets and they are not disqualified from receiving the health care that they need. This change recognizes the importance of allowing older adults to maintain a small financial cushion without jeopardizing their access to health care benefits and their quality of life. It will allow more low-income seniors to qualify for assistance. After receiving approval from CMS, the low-income subsidy will be available to New Hampshire residents, and also it will be beneficial in reducing the costs that are associated with prescriptions and the monthly Medicare Part D premiums. They'll be able to afford their prescriptions. Many low-income adults and disabled individuals in New Hampshire are struggling to meet their monthly expenses, which include food, shelter, healthcare, and prescription drug coverage, just to name a few. These costs are continually rising, making their choices for those who are on a fixed income to how they can afford to maintain their quality of life as well as their health care. By providing a disregard for the resource limit, more low-income seniors will be eligible for medical assistance. The financial burden of covering costs that are associated with Medicare, such as the annual deductibles, the copays, and most importantly, the Part B premium, will provide much-needed relief to those who are most vulnerable. And those who are, and once approved, they will, upon receiving approval from CNS, this population will be able to afford the necessary prescriptions that they need to maintain their health. So I just want to conclude by saying that AARP New Hampshire strongly supports SB 545 because it does represent a significant step toward improving the financial security and the well-being of low-income older adults as well as disabled individuals in our state. It will help to ensure that older adults can access the healthcare services and the prescriptions that they need without having to make impossible choices about what it is that they're going to pay to maintain their quality of life. Thank you very much for your support and for listening to me, and I'm available to answer any questions.
Are there any questions of the committee? Thank you very much.
Thank you.
The chair calls Judith Jones.
Good morning. My name is Judith Jones. I'm here from New Futures, which is a nonprofit, nonpartisan organization that works to solve New Hampshire's problems through policy change, and the New Hampshire Alliance for Healthy Aging. I'm really grateful to be here to be able to talk about this bill this morning because it would help, you've heard, low-income older adults, but it literally will put dollars back in the pockets of those older adults. And when we say literally, we're talking about the cost of a Medicare Part B premium, which is $203 a month. So as we look at this bill and how it would help New Hampshire, one thing that would be important is to take a look at the interplay between the Medicare Savings Program and Medicare. So what I've done is, with my testimony, you'll find a chart that's going around. And what that chart does is lay out some specifics about Medicare. So the chart's helpful in that it shows you what is traditional Medicare. This is called original Medicare. And it also shows you how many costs are associated with traditional Medicare. Individuals who don't choose traditional Medicare can choose Medicare Advantage. The benefit you have with Medicare Advantage is you have lower premiums and lower costs. However, with Medicare Advantage, when I've looked at all the policies in New Hampshire that offer Medicare Advantage, what I found was all of them still required individuals to pay for their Part B premiums. The other important piece of Medicare you've heard about is the Part D, which is the prescription drug benefit. And the key piece in that benefit is thinking about a federal program called Low Income Subsidy, or LIS. And LIS is purely federal money. What it does is pay for the holes in prescription drug coverage under Part D. So you have this totally federal program. It has its own income and asset test, But in those regulations, what it also says is if you have someone eligible for MSP, they will automatically be eligible for LIS. So what's happening here is by increasing eligibility for the MSPs, you're letting more people get the benefit of federal dollars through the LIS program. If you look at the first page of the chart, you look at some of the costs under traditional Medicare. Those are laid out. And the biggest one usually that we hear people suffering about is the Part B premium that's now $103 a month. And then again, if someone's on an Advantage program, you're talking about lower premiums. But as far as I could research in New Hampshire, folks on the Advantage program are still paying the Medicare Part B premium. The second page of the handout just takes you through a walk through the MSP program so you could see those laid out. And you see the different types of MSP programs that are offered in New Hampshire. So what you find with those MSP programs is the lower your income, the more coverage you get under the MSP programs. And then again, for your reference, we have the resource limits on the MSP programs that are modest. And when we talk about older adults, usually what you're hoping is that these individuals have savings so that they can stay home and they avoid nursing home care. So while some programs have the limit of $2,500, I'm urging you to consider, we want older adults to stay home, to have money to pay property taxes, to pay for care, to pay for repairs. If we look at what this bill will do for New Hampshire, just quick in summary, 1, you get the benefit of federal dollars for LIS. 2, you're going to help folks on Medicare Advantage. If I'm on an Advantage program and I lose that program, I have to shift over to traditional Medicare. And now I have a lot of copays and deductibles. So the MSP program would help those individuals. And we've seen it shrink in New Hampshire from 35 to 19. We have a reduction in DHS burden. The other thing you might know in the fiscal note is that part of the MSPs have 100% federal match. So you have the benefit of more than the 50% federal match, so more contributing from the feds. And finally, you have the economic benefit to older adults. So this bill is a tangible way to help individuals in New Hampshire who are seeing financial difficulty. I hope you support the bill. I'm happy to take any questions.
Senator Ebert.
Thank you for your testimony, and I really appreciate it. So there's potential to gain federal dollars, but are we in jeopardy at any point if we get rid of the asset thing to jeopardize any kind of compliance?
The answer is no, that federal law allows states to have great flexibility in the income and the resource, so there's no jeopardy to that. And I was hoping I could sing an answer for you.
What's the singing answer?
I'm here. Let's go.
I'm
I'll harmonize with you.
So I'm usually just so relieved I can answer the question. That's the truth.
Thank you very much.
Thank you.
Any other questions from the committee? No, thank you very much.
Thank you.
And then the chair calls Lori Raymond.
Good morning, and my name is Lori Raymond, and I am here to represent the Partnership for Public Health. I also have family that has been on the Medicare Savings Program. So I'm here to support HB 545. I have experience as a SHIP counselor. If you don't know what SHIP is, it's State Health Assistance Program. And a SHIP counselor helps people enroll in Medicare programs and enroll them into insurance. As a SHIP counselor, I help people sign up for the Medicare Savings Program. So I have direct experience with the need for this bill. Currently, I am a senior Medicare patrol specialist in New Hampshire. Both of the jobs have given me important insight into the many challenges that seniors are facing in our state, especially now, and especially financial stress. This bill helps the older adults by strengthening the Medicare savings programs, which pay for some of the costs associated with Medicare. Part of the work I do takes me all over the state of New Hampshire, and I have heard countless stories from older individuals and families on how they cannot get any assistance because they have some modest savings, which we're all told we have to save for retirement. I have had many older adults say to me that the asset limit is like they are being punished for being proactive and having savings. They need the savings for housing taxes if they live in their own home, car registrations, if your car gets broken down, you got to fix it, upkeep, and other items that may be unexpected. People also tell me that they cannot afford the cost of Medicare as the costs, and especially the deductibles, continue to rise every single year. This bill would help those seniors tremendously. So I think about what it would be like to work hard, raise your kids, pay your bills, and then when it's finally time to retire, face financial stress. This bill will allow older adults to preserve modest savings and have the benefit to help with those high Medicare costs. So please support HB 545. And if you have any questions, I'm happy to answer.
Thank you very much. Are there any questions of the committee? Seeing none, thank you very much.
Thank you.
I'd like to call Cheryl Steinberg.
Okay. Hello, Chairman and members of the committee. My name is Cheryl Steinberg, and I'm here today to testify in support of Senate Bill 545. I am the director of the Justice and Aging Project at New Hampshire Legal Assistance. The Justice and Aging Project, which has been in existence for over 50 years now, serves people 60 years of age and older with civil legal needs, and we focus on issues that impact people's most basic needs. I would say in the last several years, we've seen an increase in our clients, our older clients, applying for local welfare assistance, being in very dire straits, being evicted from their apartments because they can't afford the rent, having their homes foreclosed on. So it's just been a marked increase in our perspective. A lot of it, some of it is due to people being financially exploited, which is an unfortunately ever-growing problem that isn't going away, but also the high cost of living. And I would say that's, that anecdotal information has been supported by a needs assessment that we did last year. It was a legal needs assessment where Suffolk University polled over 500 people on the telephone, and then we also had 10 focus groups. And the overwhelming response, other than legal needs, is of people being concerned about their financial situation and their inability to make ends meet. So it was really a cut across on all levels with that needs assessment. I would say from our perspective, the people we've served over the last 3 years, 2/3 of them would be income eligible for the Medicare Savings Program. And over 40% of the people actually are at or below the federal poverty line. There are some that, and then not an insignificant number of them would be otherwise eligible for the Medicare Savings Program, but are over the resource limit. So there is enough of a group there that it would make a difference for them. I would tell you, like I have, for example, a client I just spoke with yesterday who I'm helping her because she's been financially exploited by her daughter. She has no money left. She is struggling to, she's trying to find subsidized housing, but she doesn't have that yet. She's struggling to make her rent payment. The rent just went up. And she also she is on a Part D plan, right? But it doesn't cover one of her medications. So right now she's panic stricken about being able to her rent's going up, and she had to ask her brother for help because she can't afford to do all of that. So it's a real problem that we see all the time. And I think if she had that extra $200 a month, I mean, it could make all the difference in the world. So it's a big, even though it might not seem like a lot, I think it means a lot, particularly to the people we help. It could, again, be the difference between being able to stay in their home or getting their prescriptions filled. What I would also say, which has been, I think, pointed out, is that the administrative burden. So we, there could be potentially some increase in enrolling people in this program, but a lot of it is being paid 100% by the federal government anyway, right? So it isn't all on the state. But there's that administrative burden that the Department of Health and Human Services has to do by checking the resource of all these people, and that is not a small thing. And I know you've heard over and over again in different contexts how overwhelmed the department is in processing applications, how behind they are with long-term care and having to do all those lookbacks and their resources. And so this would be, by eliminating them having to do that, it would at least free them up. It would be a significant assistance in that way, and it would save money on the state. So for all those reasons, and for the fact that it would help people remain healthy and self-sufficient, I would strongly urge you to support Senate Bill 545. Thank you.
Thank you very much. Are there any questions from the committee? Senator Long?
Yeah.
Thank you, Mr. Chairman. Thank you for your testimony. Have you recognized an increase over the last couple of years in people seeking aid?
Yes. Yeah. I mean, like I said, we're as far as, when you say aid, you mean like what just in general public benefits or?
No, actually, with respect to this.
Oh, the Medicare Savings Program.
Correct.
Well, yeah, I mean, the thing is many people don't know about it. So when I talk to people that are really struggling, I say, are you enrolled in this? And they'll say, I didn't even know it existed. So then we tell them to do it. So I think that's another whole problem, is people not even being aware of it. So if they're not applying for some other assistance program, they might not even know that it's around.
Very good.
But
Thank you.
Yeah, you're welcome.
Any other questions? Thank you very much. At the end of the list here, is there anyone else, though, that would like to speak on 545 that has not signed up? All right.
Good morning, and sorry for not signing up. I just missed the sign-in sheet when I came in, but it's David Chorney, the state's Deputy Medicaid Director. But I just wanted to offer the opportunity to answer any questions the committee may have on this proposed legislation. And we agree in concept with what Senator Rosenwald proposed, her legislative testimony was. We estimate about 2,000 new Medicare savings enrollees would be enrolled by removing the acid test. There are a number of other states, Senator Avard, to your question about compliance, that have removed the acid test. I think there's 10 to 15. I know Alabama, Mississippi, Arizona, Connecticut, Massachusetts, Vermont have all done it. I think Washington, D.C. I can provide a list if that would be helpful as well.
Thank you. Senator, do you have a question?
I do. The fiscal note's about 2.3 million from the general funds, but now that we're going to be, if this goes through, we're going to have less burden on the administrative cost. Is there a number for that, or is that included in this 2.3 million? Meaning, so we're not going to have to do an asset test, so that saves the state how much?
I don't have an estimate for that. It does save on administrative burden. I think the other hypothetical cost to think about is, given the income level of these individuals, they would likely qualify for Medicaid for a long-term care eligibility when they both meet the level of care standard and once their resources are spent down to the long-term care resource level. And so by removing the asset test, the hypothesis is that they will have better access to their Medicare benefit they'll have timely access to services. And so when they're eligible for Medicaid, they're a healthier individual and not institutionalized in a home and community-based setting, which when you look at long-term costs, the Medicaid program to the state would help bend that curve. No problem.
Any other questions for the department? No, thank you very much.
Thank you.
So seeing no one else that would like to speak, I'm going to close the hearing on Senate Bill 545. All right, we're going to open the hearing on Senate Bill 546, Healthcare Carrier Network Access Monitoring. And the chair recognizes Senator Rosenwald.
Thank you, Mr. Chairman. For the record, I'm Cindy Rosenwald from Senate District 13. I'm pleased to offer you Senate Bill 546, a bill that will help make sure Granite Staters will have access to the medical care they're paying for through their health insurance. New Hampshire's network adequacy standards exist for a simple reason. When Granite Staters pay for health insurance, they should be able to get care within a reasonable time and distance. But too many patients still face long waits or must travel far just to see an in-network provider. Regulators at the insurance department don't have the tools to verify whether insurers are meeting their obligations in practice. Senate Bill 546 fixes that with a proven, straightforward solution: secret shopper surveys for commercial insurers. These surveys use independent callers posing as patients to test whether medical appointments are actually available. They produce unbiased, real-world data of what Granite Staters experience when they're trying to get an appointment for needed care. And this isn't new. Secret shopper audits are already required for Medicaid managed care plans and for commercial insurers selling ACA marketplace products. Major carriers like Anthem and Harvard Pilgrim already comply with these requirements for their marketplace plans. Senate Bill 546 simply brings the rest of the New Hampshire regulated commercial market up to the same standard. And the data shows why this matters. A 2023 KFF survey found that more than 1 in 4 insured adults nationwide tried to see an in-network provider who had no available appointments. 91% of insured adults support requiring insurers to provide accurate, up-to-date network availability information. And New Hampshire ranks among the worst states in the country for in-network behavioral health access. I think we're 17th lowest, 17th from the bottom, with some of the highest out-of-network utilization rates for psychiatric care. Granite Staters uphold their end of the deal. They're paying rising premiums, navigating prior authorizations, and following the rules. The very least they should expect is the ability to schedule an appointment with an in-network provider without waiting months or traveling long distances. So Senate Bill 546 gives the state the tools it needs to make sure insurers uphold their end of the deal too. And I respectfully urge you to support it. Thank you.
Thank you very,
Would add that I think the department might be working on rules on this that, and I'm sure someone's here from the department.
I'm going to call them next.
Okay,
Yeah.
so my understanding is that they're working on rules that should be available really soon. And so I'm hoping that the committee can just hold off on this bill to evaluate what their proposed rules are and see if you like it.
Thank you.
Thank you.
We've got a couple questions. Senator Birdsall?
Thank you, Mr. Chair. Thank you, Senator, for taking my question. You had stated, who are the carriers who already provide this?
My information is that Anthem and Harvard Pilgrim are already complying with their marketplace plans.
Okay, thank you.
Senator Avard?
Thank you, and thank you, Senator, for taking my question. Basically, in the methodology, it says that there could be a potential to increase premiums, which may result in insurance premiums tax revenues to the state. Does that reflect?
Yes, as you know, that the insurance department is self-funded. And insurers pay, I think it's a 3% on premiums. So, it might increase cost, but it would also increase revenue.
That's it.
Thank you very much, Senator.
Thank you.
As promised, we are going to ask the insurance department to step up, Michelle Heaton and Commissioner Betancourt.
Good morning. I think you just have me for this bill. So my name is Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. New Hampshire has actually been ahead of the game nationwide on network adequacy. We first put in network adequacy rules back in 2017, 2018. And at the time, those rules were much more stringent than anything else happening in the country and any of the requirements federally. Since then, the federal government has implemented more network adequacy standards over the years. However, New Hampshire has remained more stringent than the CMS standards. For that reason, CMS defers to New Hampshire to enforce all of our network adequacy standards rather than the federal standards for all of our QHP plans. So just to remind you, QHP plans are the on-exchange qualified health plans. The federal network adequacy requirements only apply to those QHP plans, not the entire market, whereas New Hampshire's network adequacy rules apply to the entire major medical managed care market. So a couple years ago, we had the opportunity to use some federal grant money, and we used part of that money to do a deep dive into our network adequacy. We felt that our approach was more stringent than the federal approach, but we wanted to double check that because it had been some years since we first put it into place our structure for how we review network adequacy. So I'll try to keep this high level and quick, but in New Hampshire, we look at a services level. So we use our claims data, our CHIS data to verify that people are able to access certain key services within the time and distance standards. Now, we had developed our own time and distance standards prior to the federal government implementing their time and distance standards. So we want to kind of crosswalk those and see if they aligned. Using that grant money, we did find some opportunities to improve our rules to better align with the federal standards. However, we feel that our approach is more stringent than the federal government's because the federal government is just looking at what types of providers do you have in your network and does the location of those providers meet those time and distance standards. The federal level is only looking at physicians. It does not consider other providers such as PAs and APRNs. And as you know, the scope of practice in New Hampshire is broader for those APRNs and PAs than in other states. And we thought they are a key component of our healthcare system. And to the extent they're providing services, that should be counted as well. So because of that, we have been in discussions with CMS. They agree that our approach is more stringent than the federal standards. And so we've been working to update our rules to better align with the federal so that there aren't two very separate standards. Those rules are drafted. We are actively working on getting those into rulemaking and hope that they will be entering rulemaking very soon. As part of, just to talk a little bit about Secret Shopper, Secret Shopper is a concept that's been around for a long time. New Hampshire has tried to use Secret Shopper type initiatives to check access and appointment wait time standards, and it is very difficult to do. And I'll just highlight a couple of the issues that we have uncovered ourselves. Especially in New Hampshire, there are a lot of solo providers that don't have much office staff. This is particularly evident in the mental health space. If you have an independent mental health provider who is available, a lot of them do not have staff to help out with scheduling and billing. So when you're doing a Secret Shopper study, oftentimes you have to call and try to get a hold of that provider. If you don't have much office staff, sometimes that requires you to leave a message. If that provider never calls you back, then you can't count that. And that's one of the problems we've found in trying to do the Secret Shopper, is trying to get a hold of someone to actually talk to. And then oftentimes, if it's outside of a primary care provider, if you're a specialist, sometimes even mental health, before they will even tell you if they will schedule an appointment, they want to know more about you. They want to verify your insurance information. They want to know what's the reason you're seeing, what's the acuity of the situation. And so it just adds a lot more complexity in doing these Secret Shopper studies. Initially, we were looking to incorporate the Secret Shopper concept into our new rules. However, after reviewing the federal guidance on how they're going about the Secret Shopper, we had a lot of concerns that it wouldn't actually be a good way of assessing appointment wait time standards in New Hampshire. So we've been trying to come up with other concepts to address those appointment wait time standards that don't involve a Secret Shopper. The Secret Shopper is also it's an administrative cost and burden on carriers because they have to find a third-party entity to do the Secret Shopper and pay them for that. And again, if you have problems in getting in touch with providers, that only extends the amount of time it's going to take to do the Secret Shopper to get enough data. And so we were a little bit hesitant and skeptical that this is the best way of assessing appointment wait time standards, but we are actively tracking what's happening at the federal level. And down the line, we would be happy to incorporate some of their experience into our rules in the future if it looks like this is a viable option. But I think they're still making a lot of tweaks at the federal level to see how to actually get the Secret Shopper protocol underway. So I'm happy to take any more questions if you have any.
Yeah, thank you. I've got a quick question, and then I'll call in Senator Abar. But so a couple questions. The rules are forthcoming. Do you feel the rules address the objectives that are trying to be achieved with the senator's bill here?
Yes.
Okay. And then the second question is maybe a discussion not for today, and if it is, we'll just make an appointment and we'll talk. But I'm looking at network adequacy and some of the things that you talk about, wait times, and I mean, we've got situations in this state that perhaps it's not the fault of the payer that a patient can't get in and see somebody. There's just not a physical person, that is there to provide services. How do you delineate that as far as network adequacy if there's nobody if we've got a desert, that's no fault of the payer?
Yes, and that's been one of the problems nationally in trying to implement network adequacy standards is that it can't create providers. If the providers don't exist there, then there's no way you're going to meet the network adequacy requirements. That's why we focus on services, understanding that there are certain services that could be provided by a number of different qualified clinicians, and we think that's the better way of focusing on it. However, if there are no providers, if it's a specialty that there aren't many in the state, and there's no way you're ever going to make that time and distance standard because the providers just don't exist, there is a mechanism in our new rules where the carrier would just have to ask for an exemption from that standard and explain certain things and provide evidence, such as there are no providers available. We've tried to do X, Y, and Z. And then at the end of the day, if that exemption is granted, that person still has access to that provider. The carrier would just have to cover any out-of-network care that's required at an in-network cost sharing.
Great, thank you. And when those draft rules are available, please send a copy.
Yes, we will definitely circulate that copy. It'll be posted on our website, and we're hoping to have a webinar coming up once those are public to talk about the new rules and just network adequacy generally to help inform stakeholders.
Great, thank you. Senator Abrams, all set? All right, any other questions of the committee? All right, thank you very much. The next, call Deborah Steinberg. And just a reminder, we have a fair number of speakers today for the rest of the day. So if you've got prepared statements that you're just going to read, by all means, just leave that with us and just summarize it. We can read it later. Thank you.
Thank you. Thank you, Chair Rochefort, Vice Chair Eppard, and committee members. My name is Deborah Steinberg, and I am a senior health policy attorney with the Legal Action Center. We're a national nonprofit, nonpartisan organization that provides technical assistance to advocates and to states to improve access to mental health and substance use disorder care. And I'm here in support of SB 546. So I won't summarize my testimony even because it's pretty consistent with what the senator has already spoken to. But I do want to speak to some of the issues that were raised in the previous testimony because we agree with a lot of the problems that the division has raised. So I should say New Hampshire has been a strong leader in setting network adequacy standards. And that is a tremendous testament to your state and how you've tried to make substance use disorder and mental health care in particular more accessible and more available. However, we're still seeing at least one person a day die from an overdose in this state and nearly that same rate for suicide. And what we're seeing in terms of network adequacy is that people are going out of network far more often for mental health and substance use disorder treatment than they are for medical care. And that speaks to an issue of parity. Parity is a federal law, it's a state law. It says health insurance plans have to cover mental health and substance use disorder care in a comparable way to how they cover medical surgical care. But what we're seeing is that people are going out of network 40 times as often for something like physician assistants compared to therapists. So we agree physician assistants are important, but why don't we have the same access to therapy? And when we think about these issues with secret shopper surveys where people might call, even if you have a third-party entity that calls and is trying to make an appointment, now imagine that same issue happening for the patient. They're calling, they're leaving a message, and they can't get that appointment either. So actually, the secret shopper is doing exactly what it says to do. It's mimicking the experience of a patient. So if they're not getting a call back, they're not making that appointment either. And yes, there is 100% a mental health professional shortage. That is undeniable. But there's also a primary care professional shortage, and yet people are still able to access those providers without having to go out of network nearly as often. So we still believe that the secret shopper survey is the industry standard. It's what's already happening in qualified health plans on the federal marketplace. It's what will soon go into effect for Medicaid managed care plans. The Department of Labor is using it to enforce the Mental Health Parity and Addiction Equity Act. It's not a perfect solution, but it gets the job done because it helps us ensure that these network adequacy standards are actually being enforced at a time when there aren't a lot of other ways to do that. So I'm happy to answer any questions, and thank you so much for your time.
Any questions of the committee? Thank you very much. Sam Burgess.
Good morning, members of the committee. My name is Sam Burgess. I am the Healthcare Policy Director at New Futures. We are a nonprofit, nonpartisan organization. You've already heard from the Senator and from Deb Steinberg why network adequacy standards alone are not enough. Without a real enforcement tool like secret shopper audits, patients and providers are left navigating ghost networks, inaccurate directories, and long wait times. I passed out a sign-on letter that contains signatures from 8 patient and provider groups that support SB 546. Because time is short, I want to briefly highlight the perspective of one provider group and one patient who couldn't be here today. First, the New Hampshire Psychological Association writes that persistent gaps in mental health access show our current standards are not working. Even licensed clinicians struggle to find in-network referrals, especially for youth, families, and specialized testing. Secret shopper audits will give NHID reliable consumer-level data on wait times and provider availability across all commercial networks. That improves transparency so consumers can compare networks while choosing coverage. Timely access to care prevents crises, reduces avoidable hospitalizations, and keeps costs down. NHPA writes that patients should no longer bear the cost of out-of-network bills or delayed treatments due to network inadequacy. Second, a patient story. Kristen Merritt, a Hollis resident and small business owner, faced an urgent medical issue just this last summer. Her plan listed many in-network providers, but everyone she called was either unreachable, out of network, or not accepting new patients. Her insurer ultimately confirmed to her that there were no in-network providers available. When she had the uncommon knowledge to request a single case agreement, not only was she denied, she was also told the only way to submit an urgent case appeal would be by mail through a P.O. box. After 2 days, 14 calls, and 6 hours on the phone, she ultimately paid entirely out of pocket because the network and appeals process simply didn't function. Members of the committee, a directory that collapses in upon itself when a patient relies on it is not a real network. SB 546 offers a practical, tested solution. As the previous speakers have noted, there's a reason why it's so widely used on the federal level. Secret shopper audits allow New Hampshire to ensure that network adequacy standards are real protections for patients and not just words on paper. I urge you to vote with Granite State patients and providers and vote ought to pass on SB 546. Thank you. I'll take any questions.
Great, thank you. Are there any questions? Thank you very much.
Thank you.
Next, we have Sam Hawkins.
Good morning, Chairman, members of the committee. Good to see you again. For the record, my name is Sam Hawkins. I'm here today representing NAMI New Hampshire, the National Alliance on Mental Illness. And on behalf of NAMI New Hampshire, I'm here today to speak in support of Senate Bill 546. And I really just want to share that through the course of our organization's work, we have countless conversations with individuals and families who are urgently seeking mental health and substance use disorder treatment, either for themselves or a family member, and they're unable to access it. From these folks, we hear that they may reach out to their insurer and receive a list of even up to 20 providers in their area, and they start making calls to these providers, start trying to schedule appointments, only to find out that that provider is not accepting new patients, they're at capacity, or they're no longer accepting that insurance plan, or that's assuming anyone even answers the phone, that they are still practicing. So for these folks, obviously, this means potential delays in care leading to negative outcomes or forcing them to go out of network, increasing the cost for that family, for that individual. I want to address comments you brought up previously, Chairman, regarding the workforce shortage. And I appreciate you bringing that up because it is a pervasive issue we've been facing for years here. However, I would make the point that I think network standards, it is essential that they exist separate from any existing workforce shortage for the fact that the practices of payers does impact our workforce and does impact the network. We've heard of countless providers here in New Hampshire that have made the decision to stop accepting insurance due to issues with contracting or billing or simply reimbursement rates that are so low that it's not valuable to them and they have enough cash paying patients that they can make a living reach capacity without needing to access insurance. So there is an impact in the practices of payers on our workforce here in New Hampshire. I think that's where I'll stop and see if I can answer any questions, if you have any questions. And really, I think I appreciate the work of the insurance department and the stakeholders who over the past several years have been working to increase access to mental health care here in New Hampshire. We would love to be involved in the conversations of how we can ensure this is not just rules and standards, but really have a practical understanding of what the experience of folks trying to access care here in New Hampshire is. So I thank you for your time, and we urge the committee to recommend ought to pass for Senate Bill 546.
Great, thank you. Are there any questions of the committee? No, thank you very much.
Thank you.
Sabrina Dunlap.
Good morning, Chair Rochford and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem Blue Cross Blue Shield in New Hampshire. Thank you very much for the opportunity to testify on SB 546, a bill we are opposed to. To begin, we are unsure what problem the bill is trying to solve. If there are issues with provider wait times, the bill does nothing to address those. Besides that, the bill is seeking to regulate an area that is already highly regulated under state law. In short, the bill is unnecessary and will add severe administrative costs to the healthcare system. The bill states the purpose is to assess and validate carrier compliance with appointment wait time standards and provider accessibility requirements, which already exist under New Hampshire law. And I don't want to echo what Michelle Heaton said, but I'll just mention we don't think there's a need for additional legislation because the insurance department already has the authority to assess and validate carrier compliance with existing laws. If you look at the existing requirements for network adequacy, which includes provider directories, the requirements are extensive. And our processes to maintain accurate and updated provider directories are extremely thorough. The New Hampshire Insurance Department also very clearly has enforcement authority related to network adequacy, including the upkeep of provider directories. This is all spelled out in 420J7 and related rules, which, as you heard, are going to be updated. On provider directories, it's important to note providers and providers alone control their wait times. All insurance companies can do is our best to make sure the information about their wait times is accurate and up to date for our members. I talked to our team that manages the provider directory, and they explained that providers are responsible for sharing updates to their demographic information and their accessibility and availability to our members. These requirements are spelled out in our provider manuals and contracts with providers. Despite this requirement, sometimes providers do not give us the most updated information, so we regularly remind them of their obligation to share timely updates and attest to their data accuracy on a regular basis. Because we do not always receive the information we need from providers, we also have a formal directory accuracy program that uses various internal and external sources of data to keep our provider directory updated. I think the bottom line is we have extensive processes in place to keep our provider directories updated and useful for members, but it seems the provider's role and responsibility is completely absent here. If the concern is about provider wait times, it seems we might be better served with discussing ways providers can improve the situation, both by keeping their information up to date and by working to improve their own wait times, which are within their control. And just quickly on the secret shopper program, because we are one of the carriers that already complies with our ACA plans, our experience with the existing federal requirements, which are very new, they just went into place last year, they are incredibly administratively burdensome. They impose significant costs and logistical complexity on carriers without a clear benefit to consumers. So we do have concerns with the program itself and about the efficacy of it. And I just think, at a time when we're all working to control healthcare costs, I would question why the legislature would pass a bill adopting federal requirements that add cost to the system with no apparent upside. In closing, we think this bill is unnecessary due to the existing far-reaching regulation on this matter. It does nothing to address wait times that may exist with providers, and it will add unnecessary administrative costs to the healthcare system, which we all pay for. So we hope the committee will vote this bill inexpedient to legislate. Thank you for the chance to speak. I'm happy to take any questions.
Are there any questions of the committee? Thank you very much.
Thank you.
Paula Rogers.
Good morning. Thank you for the opportunity to speak on Senator Rosenwald's bill. It's an important bill. I looked at it and I thought to myself, and I'm here on behalf of AHIP, America's Health Insurance Plans. I looked at the bill and found it interesting that a bill was drafted to simply tie New Hampshire to the standards within a letter from CMS to issuers for the 2025 plan year. So I pulled up the letter to issuers, which is very lengthy, to see what was in that document that would somehow inform what Michelle Heaton described to you as the format in New Hampshire that is applied when network adequacy is at issue. So there's a statute in New Hampshire, and in fact, the bill references that 420J7, which deals with network adequacy. It's a very short statute, but what is important in that statute is a rule-making authority grant to the Commissioner of Insurance. And so if you were to pull up the managed care regulation in New Hampshire, it's 38 pages long, small print rules. And the first 16 of those pages are what New Hampshire did, as Michelle Heaton referenced back in 2017 and 18, sat down, looked at geography, looked at county by county, mileage distances to providers, hospital systems, separated the regions into urban, middle, and rural. Then it looked at an array of procedure codes, clusters of procedure codes relating to treatment components that would be needed to have a viable, full-scale, good health coverage. And they separated those, which could take up pages and pages, into core, common, and specialty. And then they did the magic of melding the driving times, looking at core, common, and specialty, and they came up with standards. And from that day forward, that sort of imposition on what you look at to determine whether networks are adequate was laid upon the carriers to comply with and to report annually on. And I think those reports are available at the insurance department. Looking at the bill before you, it sort of imports secret shopper component, which has a catchy thing to it. And apparently it's being used effectively for CHIP and Medicaid managed care coverages. And it's also now been applied to ACA coverages. So that's why when you heard Anthem and Harvard Pilgrim in compliance, because they are complying with that 2024 letter that's referenced in the in the bill before you from CMS. Back to that letter from CMS. What does it really have in it? It has a small section about secret shoppers, and it has another small section about timeframes that they would like to make the secret shoppers look at to use as a diagnostic tool. And it's a very skimpy list. The New Hampshire requirements are much more stringent at the moment. Do they fit our present market? That's probably unclear. Do we need to do more to that regulation? That's probably right. Do we need to import a federal provision into that regulation? We'll certainly consider it because secret shoppers seem to be a tool. But the reality is, if you go online and look for some sort of study about the efficacy and the implication of the data that comes out of secret shopping, it's hard to find. So it's sort of an area that probably deserves fair consideration. So AHIP's concern is to bring in something from the federal level and lose track of what makes sense for New Hampshire, a small state. Now, the one thing that did disturb me in here in the testimony, and I'm not debating its accuracy, that New Hampshire fell very low on a state level for its mental health and SUD availability of providers. And that's concerning. And that's a regulatory concern. All I can say is health plans want to maintain adequate networks. without their networks, they have little to offer. And so it's a constant struggle, and not all of the network issues that you hear about are a result of anything but a market reality where, for example, there are too few primary care physicians. You have trouble in the mental health arena, and probably some small specialty areas. And actually, in today's union leader, there was a reference to a lack of psychiatrists in New Hampshire. It's very hard to address those things. I'm not sure a regulator can address them. Plans do their best to use what's available in the state of New Hampshire, do proper credentialing, and do it with speed. So our concern is more around, does this bill deliver anything that would expand the opportunity in New Hampshire to do a better job? Yes. Consider a secret shopper, but just not import it without real analysis as to whether it fits in the state. So I'd be happy to answer any questions.
Thank you very much. Any questions?
Just one real quick.
Senator Abar.
Yeah, so the prime sponsor asked us to basically hold on to it till the rules are produced. Would you agree with that?
Would I agree?
With us holding on to it, or should we just move this forward?
Well, I think the department has made a presentation that suggests that they're deep into it. I have no reason to doubt that. In fact, we're all kind of waiting to see it. And that's, up to you. Actually, I just would hope that you don't adopt the bill. Whatever you might want to do with it, I don't know what to say about that.
Follow.
Absolutely.
So I'm just a little confused. You like the bill, but you don't want us to adopt the bill?
No, I do not like the bill. I think that is importing a federal standard, which frankly doesn't offer more than we have in New Hampshire now. And in fact, the federal standard would import 90% compliance. We don't even have that 90% compliance. We sort of go for the whole thing knowing that you can never get to 100% in a system run by people. So no, I'm not in favor of the bill at all.
Oh, I misheard you.
Okay, I'm sorry.
Yeah, I misunderstood. So that
No, okay.
that clarifies. I thought I was hearing two different things. So
I may have confused you.
yeah.
Any other
That's not hard for
questions?
me.
Yeah.
Thank you.
Seeing none, thank you very much. And we have Peter Bragdon.
Good morning, members of the committee. Very short here for some reason. Let's see.
Good morning. I would ask you that you turn your microphone on.
I thought it wasn't on. Oh, there we go.
There you
Sorry.
go. Now we are.
Thank you, Mr. Chair, members of the committee. For the record, Peter Bragdon, Senior Policy Advisor at Pretty Strategies here in Concord, representing today Harvard Pilgrim Healthcare. As Senator Prentice likes to say, New Hampshire's not-for-profit health insurance carrier, providing coverage for over 50,000 of our fellow Granite Staters. Obviously, a robust provider network is very important to us. I won't repeat things that have been said by others. Certainly do support the fact that the insurance department has a very strong and robust system in place already that we work with. A couple of things that were brought up, and obviously, so we think this is just another layer that's not necessary, especially concerning about the 80% provision, penalties that kick in if you don't have 80% of the providers. And the issue, I guess, is we're concerned about being penalized for situations that are beyond our control. I think Senator Rochefort mentioned one potential situation where we could have every single provider in a geographic area in our network. But if there aren't enough providers in that geographic area, we obviously can't reach the 80% threshold. But if there's not providers there, there's not providers there. We shouldn't be penalized and punished for there not being enough providers in the area. Secondly, there's a state law that stipulates that our contracts with our providers require the providers to notify us if they stop taking new patients. So if they don't notify us, why should we be penalized for having them in our directory saying that they take new patients when they don't, when they never notified us that they stopped? So because a provider is violating the law, shouldn't be a reason why we get penalized for it. Overall, though, the robust situation structure that the department has I think is very effective and should use those rather than layer on some additional federal guidelines on top. And that's all I have to say. Happy to answer any questions.
All right, thank you. Are there any questions? Thank you very much. Is there anyone else that would like to speak on Senate Bill 546? With that, I thought there was somebody raising their hand. With that, I'm going to close the hearing. Are you coming back, Virginia? Okay. Two. Okay, I'm going to move to go into executive session. All those in favor?
Aye.
So we're in executive session. I move ought to pass on Senate Bill 610. And I would like to offer a committee amendment.
Your motion, so you can.
Okay, thank you.
You're welcome.
Are you ready, Sophie? I'm sorry. Okay. So on Senate Bill 610, I wanted to make two small changes in a committee amendment. Yes, Senator Prentice. Sophie, it's on page 2, line 12. It says the commissioner may. Yeah. Changing the may to a shall. Yeah. Senator Bertzel's looking for her copy, but she gave it to me yesterday. So page 2, line 12, changing the may to a shall. Page 2, line 28. Roman numeral 4 should read, after a comment period, the commissioner shall hold a public hearing. Yep, after Roman numeral 4, say after a comment period, the commissioner shall hold a public hearing.
After comment.
Public comment.
Yeah, after a public comment period, the commissioner shall. Just want to read that back to us so we.
And then on line 28, rule four, it's going to be after a public comment period, the commissioner shall.
Yes. Yep, that's correct. Any discussion? So with that, we'll take a vote. All those in favor say aye.
Aye.
Of the amendment, yes.
Aye.
Any opposed? So the amendment passes 5-0, and the motion is ought to pass as amended. All those in favor say aye.
Aye.
All those opposed say no. Senator Avard moves consent. All those in favor say aye. I'll second that. All those in favor say aye. Opposed? And let's see, I will take that one out. All right, and the next one, Senate Bill 543. We've got a motion from Senator Avard ought to pass. I'll second that.
Which one? I'm sorry.
543. And I'd like to offer a committee amendment to that. So on page 2, let me know when you're ready.
Well, yeah, we haven't discussed it.
Senator Avard seconds it. All right, so the committee amendment on page 2, line 1, appropriation. change the sum of $1.5 million to $1. $1. And then on page 2, line 9, strike, well, actually it starts on line 8. Onto line 9, strike the Crotched Mountain Rehabilitation Center. Yep, if you want to read that back. Yep.
On line 8, we're striking out, starting at the word the, and then probably not.
Perfect. Any discussion? So we'll vote on the amendment. All those in favor say aye.
Aye.
All those opposed?
Move on to pass as amended.
So the motion is ought to pass as amendment. Senator Avard moves that. Senator Birdsell seconds that. All those in favor say aye.
Aye.
All those opposed? So I'll move consent. Senator Avard seconds. All those in favor say aye.
Aye.
Any opposition? And I will take that one out. So I have a motion to come out of executive session.
Second.
Motion by Senator Avard to come out of, if I'm going too fast, you let me know. Senator Avard to come out, Senator Long second. All those in favor say aye.
Aye.
Any opposed? All right. So we're going to open the hearing on Senate Bill 547. Senator Rosenwald.
Thank you, Mr. Chairman. For the record, I'm Cindy Rosenwald, representing Senate District 13. I'm delighted to introduce to you Senate Bill 547, which will make changes to the regulation of pharmacy benefits managers, PBMs. This is a fast-growing, very concentrated industry with only 3 main players controlling 80% of the prescription drug benefit market. As you know, prescription drugs are growing quickly as a percentage of New Hampshire's total healthcare spend, rising from 19% to 23% of our total healthcare spend in just a few years. And the cost of prescription drugs is rising quickly too, and is a problem for the people of New Hampshire, with more than a quarter of our residents not taking medications as prescribed because of the cost. It's easy to blame the manufacturers for high prices, but the answer to unaffordable medicines, I think, is more complex and has to include PBMs as the middlemen along with the manufacturers. I would like to thank both the National Academy of State Health Policy, State Health Programs, and the New Hampshire Insurance Department for their help with drafting Senate Bill 547. This bill does 5 things. First, it updates definitions to align with current business practices, and the Insurance Department was incredibly helpful here, I have to say. Second, and I think this really might be the most important feature of the bill, it requires PBMs to have a fiduciary duty to the carriers or affiliates that hire them. This includes notifying them of any activity that prevents a conflict of interest, nor may they require any pharmacy standard stricter than federal or state regulation. Their work can only be in the best interest of their client. This issue about being a fiduciary was litigated based on a 2004 Maine law, and the First Circuit Court of Appeals upheld Maine, and the U.S. Supreme Court let the ruling stand. Since New Hampshire is also in the First Circuit, this ruling would also apply to us. And we can require PBMs to have a fiduciary duty to the entities that hire them. Third, the bill prohibits spread pricing, and Senator Brochford, I'm sure you're particularly interested in this aspect. So PBM can't charge its health carrier clients more than what they reimburse the pharmacy. They can't be making money on that transaction. They have to pass through the price. This will help our retail pharmacies, particularly the remaining independent pharmacies in New Hampshire. Fourth, neither a PBM nor a carrier can maintain business practices that steer customers to a pharmacy they own or that they are owned by. Rural residents, I think, will benefit particularly by being able to use any network pharmacy. And finally, the bill requires reporting about drug rebates and fees. There's much discussion that a lot of fees that PBMs charge are not called rebates, so they don't have to pass them back to the clients that hire them. All of this information would be in the aggregate, so no proprietary information would be revealed. And I think this is important because to the extent that healthcare can be a free market, which I think many of us would like to see and is often discussed, transparency is required so that buyers can make informed decisions. Mr. Chairman, the rapidly rising cost of prescription drugs presents a significant threat to the well-being of our residents. Solving it, as with all serious problems, will require bipartisan solutions. The bipartisan solutions in Senate Bill 547 are one approach. I know there's at least one other bill on the same subject, and I am confident this committee will put in the work to diligently to find the right path forward. The problem is simply just too big for us to ignore. Thank you, and I'm happy to answer questions.
Great, thank you, Senator. And as you stated, I am a pharmacist, and there was a time when I signed these contracts. That's no longer my role these days. And you're right, there is another bill this year. I think that we will probably see a combination of the two. We'll take aspects of both things as we move forward, and hopefully come up with something that we can work with.
I'm confident in this committee's brains and work ethic.
Well, thank you. Thank you. Is there any questions for Senator Rosenwald? No, thank you.
Thank you.
Okay, we've got Michelle Heaton and DJ Betancourt.
Good morning, Mr. Chairman, members of the committee. For the record, my name is DJ Betancourt, and I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department. I'm joined here at the table by Dr. Jason Azes, who is the Director of our Data Analytics Unit at the department. But for me, he is the PBM guru. So all the good technical
and not
stuff.
Michelle Heaton.
No.
God bless you.
So thank you, Mr. Chairman. I appreciate the opportunity to share some thoughts with the committee this morning. I think that a number of provisions within the particular piece of legislation that we're talking about this morning are solid. But what I wanted to do was to offer some directional guidance because, Mr. Chairman, as you just mentioned, there are a number of bills related to PBMs that are under consideration both here in the Senate and in the House. We're going to be spending, I think, a good amount of time this year talking about PBMs, and given their importance within our healthcare system, that's appropriate. But as I said, I wanted to share some thoughts with regard to things to bear in mind as you approach reform, and to bear in mind some principles that you want to proceed in an effective, durable, and consistent manner with market principles while avoiding the unintended consequences of things like having premiums increase and litigation. We have seen states go to one extreme or the other and encounter those consequences that have not obviously been the consequences that they wanted when they pursued their reform. So the first bit of directional guidance to share is to be clear about the problem that you are trying to solve. PBM reform should begin with precision. Different policy goals call for different tools. So if the objective is basic oversight and visibility, universal PBM registration may be appropriate. If the objective is consumer cost relief, then reform should focus on incentives that affect net drug costs. If the objective is market conduct, the focus should be on anti-competitive behavior, not on attempting to dictate particular business models. Expanding statutory definitions or imposing mandates without clarity of purpose risks overregulation without measurable consumer benefit. So that's directional guidance number one. Number two, respect market structure and contractual relationships. Prohibiting entire categories of reimbursement models rather than policing abuses risks eliminating tools that can reduce overall drug costs. And mandating duties to multiple parties with competing interests can create legal confusion and undermine accountability. A market approach focuses on transparency and alignment of incentives and avoids rigid price controls or one-size-fits-all contracting rules. Number three, be cautious when expanding the scope beyond the fully insured market, because in New Hampshire, the PBM laws are largely embedded in RSA 420J, and they apply to the fully insured market. So that's the authority that we have today. And by expanding, or as you look to potentially expand PBM regulation to self-funded or government plans, you have to do so very thoughtfully and very, very carefully so that you avoid potential ERISA preemption, which is to say federal preemption in this area. That's evolving. States are beginning to get a better idea of what the contours of that authority are, but it is something that I want to flag with you so that you can be aware of that. Dr. Azis and his team have done a very good job of exploring some of those ERISA constraints and figuring out how we can operate within them for particularly things around data reporting and for benefit design. But broad definitions without tailored obligations increases that litigation risk and, again, that regulatory uncertainty. So if the legislature chooses to broaden the scope, it should do so incrementally and intentionally with clear differentiation by product type. Number four, focus transparency on what matters most, which is net cost transparency, but it has to be targeted. Overly broad definitions of rebates or price concessions risk obscuring rather than clarifying true net costs. Data collection should be designed to inform policymakers about system-level outcomes and not try to micromanage contractual terms. Existing proposals already contain more workable transparency language that could be refined rather than replaced. And again, I think the objective should be to provide information for oversight, and I think that that's an important principle that we've talked about in the past, but I think remains relevant here today. And so finally, to avoid consumer protections that undermine cost control, several well-intentioned proposals, you want to assure that while well-intentioned, they do not drive costs higher. So you want to be aware of that. I don't think that you want to duplicate or conflict with existing law, so be aware of that. And again, you want to target the abuses in the system and not potentially take business models off the table. So I'm trying to go a little bit quickly here. So in conclusion, just to wrap this up, I think PBM reform is an area where precision really does matter. Thoughtful, market-aware legislation can improve transparency and accountability without raising costs or destabilizing coverage. But overbroad mandates, however well-intentioned, risk doing the opposite. A disciplined market approach is one that respects contracts, preserves flexibility, and targets demonstrable problems, and offers the best pathway forward for New Hampshire consumers. So again, I think that a number of provisions within Senate Bill 547 meet a number of the directional guidance posts that I provided you with. I think, as you pointed out, Mr. Chairman, there'll probably be some work to do to bring together a number of concepts that are going to come forward in PBM-related bills that you're going to see this session. We stand, as we always are, ready to be a resource and to assist the committee with that work. But as I said at the outset here, because this is the first of a proposal that you've had this year for PBM reform, I wanted to provide, again, some of those broad thoughts that I have on the topic. And with that said, I'll turn it over to Dr. Aziz for any additional thoughts.
I don't have much to add. I did want to say something. I mean, I'm enthusiastic about the transparency measures in this bill. And I think federally, there's some dampened enthusiasm about transparency in of itself, that it's going to have much of an impact on downward price pressure and affordability of drugs. But I think it's useful, and would appreciate the opportunity to cite one contemporary example, and you see it on the news every day, the GLP-1 drug market. Now there's an oral GLP-1 drug that's about 10% of the cost of the other injectable GLP-1 drugs. In less than 1 year, that downward price pressure has been achieved largely through transparency and enabling market forces to work. So for those who are critics of the power of transparency whilst preserving free markets for New Hampshire citizens, we have a really fresh example of its utility right there. So thank you, and I'm happy to answer any questions.
Thank you. I do have a few questions. Let's just pick up where you left off on the transparency. The bill sets a cadence of reporting. Is that a cadence that is adequate, or do you feel that that's the proper cadence?
The existing statute is annual reporting to the insurance department. We're happy to do whatever the legislature decides is best for the citizens. I think quarterly is too frequent, given the nature of rebates and how they're estimated and reported. Generally, a plan year is an appropriate amount of time. The concern is that within a plan year, those contractual relationships between PBMs and manufacturers can change. But in terms of amenable oversight, I think annually is the right tempo for us.
So just to go back to that, just so I understand that you feel the quarterly is too frequent, more for accuracy of data and less for administrative burden?
Both.
Okay, all right. Let me just make a note of that. And then the other thing that I wanted to ask you about is this would define PBMs as having a fiduciary duty. And, I've heard some feedback on that's overreach, but as I understand, there are 7 states that do that already. And in fact, there's a bipartisan bill in Congress that was introduced a couple weeks ago that would do the same thing. Do you have any comments on that aspect?
Pursuant to interpretation from Attorney Heaton, who knows much about this topic, it's implicit in the TPA contractual relationship that they are already fiduciaries. So I think that, we've not initially agreed on that. I see eye to eye with Attorney Heaton on that, so she's here to opine on that.
So the way we've always interpreted under our law is that PBMs are an agent of the health carrier. The health carrier contracts with them to delegate certain activities. And what those activities are can vary. But since they are acting as an agent of the health carrier, there are duties that already exists there. I think some of the other bills that are pending right now are looking to expand those duties to entities outside of the health carrier, and I think there could be some legal concerns about that because then you have conflicts of interest and how that would actually work. I think needs a little bit more work on it.
So, just so I understand, I didn't hear the first part, but so this bill needs work on the description of fiduciary, or the other bills that we're going to be
I think
considering?
the other bills, I think the language in this particular bill is really just codifying what the law already is and how
Okay.
we've interpreted it.
All right, and then my last question is, I know the commissioner talked about ERISA preemption and the sticky wick that we have with there. I know the Rutledge decision clarified that a little more. Are you confident that this would fall within the Rutledge decision from the Supreme Court?
I think that's where you need to be very careful. Rutledge is narrow, and there has been more case law developing since then that is, you really have to be looking at what exactly are you trying to achieve. If
Sure.
it's simply just a registration requirement, I think that would fall within Rutledge. But if along with that registration requirement, you have to look at what are the other requirements in 402N. If you're trying to apply those other requirements to things that are on the periphery of our jurisdiction, I think that's where you have to be a little bit more careful and thoughtful. And some of, I think all of the bills that are pending need a little bit of technical assistance in making sure the terminology being used throughout the chapter aligns with what you're trying to achieve. And things like data reporting is one of those areas that you're more likely to be preempted because ERISA has data reporting requirements. Federal plans have data reporting requirements, so you're more apt to get preempted on those areas. But I think if you're just looking at a pure registration, we're probably safe within the Rutledge decision.
Okay, very good. Any questions for the department? Senator Prentice.
Thank you, Chair Rocheford. And a follow up on your question about reporting, and I appreciate you both taking the time to be here today. Dr. Aziz, you talked about quarterly being too much, just doing it annually. Is there a middle ground on this? Because a year can go by pretty quickly, but a lot can happen in a year. And if we're focusing on transparency and there's anything in the middle that needs to be, in the course of a year, we could take a correction on. Would, 2 times a year be better than just once and better than quarterly?
Definitively, the middle ground would be every 6 months, but it still will necessitate estimation approaches versus empirical approaches, meaning they have to estimate what the rebates are oftentimes derived based on utilization. And you don't have a way to know what the true utilization would be by the end of the plan year. So you use estimation functions, the slope of the line in the first 3 months or 6 months, and then you extrapolate that outward. Those are maybe sufficient, reliable based on the utilization of the data. It's just descriptive reporting. But I don't necessarily see the benefit in doing that. There's not a lot of, these are passive transparency measures that we report out and say, this is what the spend was, and this is what the value of the total aggregated value of the rebates. So it isn't as if there's any operational function that under this proposal of the existing statute would say at 6 months, if you see something, you can you can imply something or you can act on it. It's really just descriptive to tell policymakers what the market looks like, what's the total drug spend, and what is the total aggregated amount of rebates. We can see what the rebate value is by drug therapeutic class, but we can't report out on that. So I think that when you think about the operationalizing of these data, I feel like 12 months is sufficient, but we're happy to do whatever this legislation directs us to.
Okay.
It's probably more a product of what the utility of getting the data that frequently is, because we always try to balance there's a lot of opportunity costs with data reporting. And if it's meaningful and we can act on it, then, transparency, you can probably feel how valuable I think it is, and I'm certain it is. But if we want to be reasonable with the demand for that among private firms, if it's not going to be acted upon, then I think we also have the responsibility to communicate that to policymakers too.
So just a quick follow-up. I think what I hear you saying in summary is that over the course of a year is a better view. Mid-year is not going to give you anything of or give us anything of utility based on the way that reporting is done, or, you know, the way that you're looking at the data and these estimations. Is that, it's not a position, but that's fair?
Yeah,
To say
as a-
it's just not going to be
Right.
of any value.
As a point, this is a product of NASHP, National Academy for State Health Policy, model PBM legislation. And across the 50 states, I'm really proud to say that New Hampshire has very vigorous and robust PBM oversight and healthcare oversight. So because of that, we have lots of insights that may not be reflected in the language here. And so that's what has us. We work with these data and have for 4 or 5 years. And I'd be remiss to not point that out to this commission.
Thanks,
Yeah.
point well taken. Thank you, Dr. Aziz.
Thank you.
Any
Jason?
other questions? All right, then we'll be in touch, I'm sure.
Thank
you. Cam, I have you down here twice. Are you speaking twice on it? All right, we'll call you and Margaret first.
Good morning, Mr. Chairman, members of the committee. For the record, I'm Cam Lapine, happy to be here with my friends in Senate HHS. I'm here representing Cigna. With me today, the commissioner introduced Dr. Aziz as his PBM guru. Margaret is my PBM guru. Margaret Reynolds is the Government Affairs Senior Director with Cigna. She lives in Amherst. She was kind enough to come up and testify today. I will briefly put on my legislative aid hat for a minute. There are two technical drafting errors in the bill that I want to point out to you. The first is on, let me see here, page 2, line 5, that Roman 1A should be 1B, just in the numbering there. And then the second is that on page 4, line 16, the enacting clause says RSA 402N6 Roman 1 is repealed. And then it inserts a Roman 1 and a Roman 2. There's already a Roman 2 in statute. So you would just want to say in the enacting clause, Roman 1 and 2 are both repealed. So with those two housekeeping technical changes, I'll hand it over to Margaret to speak to the content of the bill.
Thanks, Cam. Senator Rochefort, members of the committee, as Cam said, my name is Margaret Reynolds. I'm with Cigna. I'm here today representing Express Scripts, which is a PBM under the Cigna group. We did submit written testimony, so my references and amendment language are in there. But I just wanted to highlight a few key issues that we see. As mentioned previously, the definitions, we think both affiliate and pharmacy benefit manager are overly broad. My colleague Sam Hallemeyer will get more into the ERISA issues that we see in including self-insurance plans in the definition of PBM. But I also wanted to highlight other third-party payer. Specifically, we think this could pull in PBMs affiliated with workers' comp coverage and other property and casualty carriers. So we see that as a concern. We think it should be limited to health carriers since that's the subject matter we're looking at. So just want to put that on your radar for consideration. As to fiduciary duty in Section 3, we see a PBM is fundamentally not a fiduciary. A fiduciary has agency to make management decisions independently. PBMs don't have that independence. We are contracted with a health plan or an employer-sponsored plan, which dictates the terms that we handle. We do find fiduciary duty to be incongruous with the definition of a fiduciary, since we don't have that control or authority over management or assets for our clients. We would recommend duty of good faith and fair dealing, and we have that language in there for your consideration. As to the prohibition on spread pricing, we would suggest, since that is a contract term, our clients may choose leaving it as an option. And if you'd like to dictate that we must also offer a pass-through, we think that's certainly reasonable and something that clients would then have the option to look at both in their contract setting. The last point, that was my last point then. I'll kick it over to Cam, and certainly if you have questions, I'm here to answer them, and then, let Cam do all the drafting.
That's all we have for Cigna. I have other clients that I'll represent if you don't have any questions for Cigna.
Any questions for Cigna? All right, very good. Thank you. Cam, you can stay right there.
Absolutely. So I also, taking off my Cigna hat, I also represent both the American Property Casualty Insurance Association and the New Hampshire Association of Domestic Insurance Companies, which are the property and casualty insurers in the state. Normally, I don't appear before you representing them. They also represent workers' compensation carriers on the issue that Margaret raised. Again, I have written testimony. I will hand that to Sophie in 2 seconds. On the definitions issue, again, we don't feel that it is appropriate to include workers' compensation in this bill, especially if your intent is to, as Senator Rosenwald mentioned, get to the cost that consumers pay. In workers' compensation, consumers don't pay anything. Those of you on the committee who may have known me for a couple of years may know my mom has been involved in workers' compensation for like 20 plus years. She received workers' compensation benefits. She has never paid anything. The workers' comp covered the entire thing. So if your intent is consumers, we don't really see the benefit of bringing workers' compensation into this regulatory scheme. So I will give Sophie my testimony here, and thank you. And there's draft language in there. Happy to answer any questions.
Great, thank you. Any questions for Cam? Thank you very much.
Thank you.
Peter Bragdon.
Thank you, Mr. Chairman, members of the committee. Again, Peter Bragdon here representing Harvard Pilgrim Healthcare, who you may have heard is New Hampshire's not-for-profit health insurance company.
Sounds familiar.
Good.
You even got a company issued computer, I see, HP, right?
Oh, yeah. Good one. Good. Here today in opposition to Senate Bill 547, at least as it's currently written. And I will say, typically you don't see me up here talking about PBM bills, but there's a particular piece of this bill that is of great concern to Harvard Pilgrim, and that would be on page 4, line 15, which essentially bans so-called spread pricing. We feel that eliminating spread pricing will have the unintended consequence of raising insurance premiums for our members. As you know, spread pricing is when a PBM charges the insurance plan more for the drug than what it pays to the pharmacy. So why would an insurance plan choose spread pricing where the PBM charges them more? And the reason is under spread pricing, at least the key factor is under spread pricing, the PBM and the insurance carrier negotiate a fixed cost to the plan for the drug in advance. What that provides us is a level of certainty. Basically, spread pricing transfers the pricing risk from us to the PBM. In the insurance world, greater risk means greater uncertainty. Greater uncertainty means higher premiums because you have to build in more contingencies. If we can transfer that risk to the PBMs, there's less upward pressure on premiums for us. I would also note that the alternative to spread pricing, the pass-through pricing, the administrative charges are higher for the pass-through pricing. I mean, it's like the balloon that's been used before for various discussions about health costs. You can squeeze one of the balloon and squeeze out the spread pricing, but that just means the administrative fees are going to increase. So our big concern is with the spread pricing. I can tell you my first experience to the intricacies of PBMs came, as many of you know, I was executive director at Health Trust, which is our risk pool for town and school employees. And I'd be happy to chat with you about risk pools all day long, but let's not go there. I can't say the process Harvard Pilgrim uses is the same as what we did at Health Trust, but I think you'll find it illustrative, and it's probably not much different, that our contract with our PBM was nearing expiration. First of all, drug policy issues are very complex, and so health plans don't do that. So it's so complex, they need someone to do it, which is where the PBMs come into play. The PBM world is so complex that we would hire consultants to help us choose the PBMs, to evaluate the proposals and give us the pluses and minuses and do the deep dive in the finances, tell us what has to happen. So we hired the consultant and helped us to shop. I compare it to what individuals have to do for their own health insurance. What I just had to do last month for the open enrollment for the ACA, go to the exchange, find 16 different bronze levels plans, 4 or 5 from each of the different carriers, another 15 or 16 silver level plans, 4 or 5 from the different carriers. There's lots of options out there because one size does not fit all. And so that's why you have the comparison tools online, you have the Navigator program to help people make those decisions, because people make their decisions for their health insurance based on what providers they're currently using, the drugs that they take, the financial risks they're willing to accept. And so all those things factor in. Not everything is it's not one size fits all. And similarly, when selecting a PBM, insurance plans also have many options and parameters to evaluate, and they do go out and get options for that, and they need help advising them on evaluating those to get the best price, really the best net price for their members. So again, one size does not fit all, and we'd like to avoid that here because, especially this, my opinion, personal opinion, the smaller the plan, the smaller health insurance plan, the more likely it is spread pricing is a better fit, because that transfer of risk is far more important the smaller that you are. I think it's also important to note that when we hired a consultant to help us select a PBM at Health Trust, that consultant also helped us design reporting and auditing provisions for the contract. It's not like you just hire a PBM and they just go off and do their own thing. Their auditing and reporting provisions that the carriers can put in there to make sure we're able to look under the hood and see what's going on. Like I said, we believe the unintended consequences of getting rid of spread pricing would be increased premiums due to the greater risk that we have to hold. And then I guess the other piece would be the duplication of administrative costs. This bill does not apply to self-insured companies. As you know, this only applies to about 25% of the commercial market, of the insurance market. It doesn't apply to, for instance, self-insured companies. We are the third-party administrator or the administrative services organization for a number of self-insured companies. Typically, self-insured companies prefer spread pricing. Why is that? Because the risk is transferred. The pricing risk is transferred to the PBM. The smaller the company, the more important that is to them. So if this bill were to pass, we'd be maintaining one set of PBMs for one group of our members, and we'd have to maintain a separate set of PBMs for the other one. So it's just duplicative costs. So, and I think finally, my final point would be eliminating spread pricing would potentially put Harvard Pilgrim Healthcare at a competitive disadvantage. We're a regional insurance company. We're not a national insurance company. We're a not-for-profit insurance company. We're not a for-profit insurance company. We do not own our own PBM. Some of the other people, some of the other carriers own their own PBMs. The dynamics are a lot different. So in short, not all insurance plans are the same. So that's in conclusion. Please do not adopt this one-size-fits-all approach to prescription meds and preserve the option for spread pricing for the carriers that want to use it for the advantage of them and for their members. Thank you. I'd be happy to answer any questions.
Any questions from the committee? Thank you very much.
Thank you.
Got Sam Hallmeyer and Curtis Berry, both from PCMA. Are you going to come together? All right. Good morning and welcome. I think things have changed a little bit since the last time we saw each other. So welcome to Senate HHS.
Thank you, Chair Rochefort, members of the committee. My name is Sam Hollemeyer. I'm with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers, and I'm here today to oppose Senate Bill 547. I did submit written testimony, which will be handed out shortly, so I will keep my comments today brief. But before I dive into my specific
I'm going
testimony,
to interrupt you real quick. I got that testimony last night. Did that go to the committee, Curtis? Okay,
We have-
thank you.
yeah.
All right, very good. Thank you.
So before I discuss our concerns with the Senate Bill 547, I want to remind this committee that there is no state or federal law that requires a plan sponsor to contract with the PBM. And I'll use the state employee plan for example. The state employee plan can contract directly with drug manufacturers on drug prices, or they could contract with pharmacies to create a network. However, due to the cost and burden of doing all that, they hire a PBM instead. And again, no one is required to use us. Additionally, PBMs have no say in the price of a drug. That is all done by drug manufacturers. PBMs have no say. So we have 5 main concerns with the bill. The first is the changing of the definition of PBM, which we think includes self-funded plans, and it's PBMs acting as fiduciaries towards health plans, a ban on spread pricing, restricting preferred pharmacy networks, and burdensome reporting. All of which the state are considering policies that involve private contracts between 2 parties and interfering, we think, with the free market. So we think that this bill, if this bill were to pass, over the next 10 years, we estimate the cost will be $100 million per year in New Hampshire alone, so totaling $1 billion over the next 10 years. So first in section 1, the changing of definition to PBM, it includes the word self-funded plans, and we interpret that to apply to self-funded plans. And we think that this would change anywhere that the PBM definition is in statute, all those laws would now apply to self-funded plans. And due to federal ERISA law, we think that the state cannot regulate those self-funded plans when it comes to plan design. Next, and there's been discussion on this, I want to discuss fiduciary, which is in section 3 of the bill. And the language would require PBMs to act as a fiduciary to the health carrier. So PCMA, along with the Department of Labor and federal courts, state that PBMs are not fiduciaries because PBMs do not exercise discretion in setting prices when prices are set according to contractual terms. In other words, PBMs have no control or say over a plan's assets. The plan decides how their benefit's going to be built, and the PBM will administer that. PCMA has filed litigation in California on this specific issue when it comes to fiduciary and self-funded plans, and that litigation is ongoing. Next, I want to talk about the ban on spread pricing, which was previously discussed as well. Spread pricing is a risk mitigation contract for plan sponsors to choose, and it just offers more predictability for plans when deciding to build their benefit. A plan can choose to do a spread pricing, or they can choose to do a pass-through model. And we think that this bill would take away the option for a plan to design their benefit. Next, I want to discuss the ability of plans to develop preferred networks. This is also in section 3. We think that this bill would take away the ability of a plan to design preferred networks and would undermine this ability, and it would be a cost for New Hampshire patients. Finally, section 4 of the bill imposes additional reporting requirements on a quarterly basis. We think that is burdensome, and we also agree with the department on suggesting changing that to yearly. And then some of the data that's being requested raises confidentiality and proprietary concerns specific to plans that we think that some PBM clients would object to. So to close this all out, I do appreciate the opportunity to testify before you today on Senate Bill 547 in opposition. We think that this proposed bill does nothing to lower the costs that's set by drug manufacturers, and we think that many of these policies contained in the bill will raise costs at the expense of New Hampshire patients and plan sponsors. And additionally, we're not aware of plan sponsors that are asking for these policies. It is special interests who gain to benefit from these policies that we think are suggesting these. What plan sponsors are asking for is drug manufacturers to lower their price. So I thank you for allowing me to speak today, and I'm happy to take any questions, but I think Curtis has a few comments.
Yeah, Mr. Chair, if I may make some very brief, sort of broader comments, including one I just wanted to emphasize the last point that Sam was making. The bill has several elements that seem to be aimed at protecting the carriers, but the carriers are not asking for this. In fact, they're testifying in opposition. The second point I'd like to make is in the intent section of the bill speaks to competition and points out 3 major PBMs have a large share of the business. First of all, my view is
we don't think that there's a competition problem in the cheeseburger business because McDonald's, Wendy's, and Burger King have a large share of the business. Three robust businesses can compete very vigorously for business, which is good for the plans and good for the people that hire the PBMs. Second, there are over 60 PBMs doing business in the United States right now. And I think that gets into another issue with the bill. If you're concerned about competition, why would you limit the number of options a PBM can offer to a carrier or somebody that's sponsoring a health benefit? This bill does just that. It limits the options that you can choose from. And lastly, there was a comment about healthcare and to the extent it can participate in the free market. What this bill does is have the government dictate terms and conditions of contracts between two very sophisticated private entities that are players in the market. I think those are at odds with each other. And lastly, I just wanted to point out, in the packet you have is Sam's testimony, which is longer than his verbal comments, plus some documents that speak to each of the subject areas or policy areas that Sam went over.
Thank you very much. I know you dropped off some information to my office. I will make sure the rest of the committee gets that. Oh, it is. It includes that. Okay. Very good. Any questions from the committee? Senator Prentice.
Thank you, Chair Rochford. Gentlemen, thank you for taking my question. I'm thinking I had stepped out and I came back in. So my question is for Sam, and I did not catch your last name, so I apologize. And but you talked about $110 million, I think it was, in cost to New Hampshire.
$100 million per year. So over the next 10 years, we anticipate.
$100 million over 10 years.
No, $100 million per year. So over 10 years, it would total $1 billion with a B over 10 years.
And again, I might have missed this, but can you just take me through what makes up this $100 million?
Yeah, I'd be happy to. So in the handout, it will somewhat outline some of those aspects, but it focuses on the fiduciary duty. So PBMs will take on this additional responsibility, and there's legal fees and concerns with that. So that's built into a contract when it comes to if this fiduciary duty were to pass. Additionally, the pharmacy networks. So this would essentially ban pharmacy networks, and PBMs design pharmacy networks along with their plan sponsors to make sure that those pharmacies are offering lower costs and that they don't include high-cost pharmacies in there. So it's a combination of fiduciary as well as pharmacy networks. And I can follow up with this specifically more.
Yes, go ahead.
Thank you very much for that clarification. So you're saying with the requirements that are in here, the PBMs will be basically spreading the costs of those over,
Over all plan types in New Hampshire, yes.
Okay, and that's for the $100 million per year.
Right.
Okay, thank you very much.
And if I may have a little bit narrower example, one thing that I think is in Sam's testimony, but I wanted to highlight just in response to the question, 2019, the state of Ohio passed a provision eliminating spread pricing in its Medicaid managed care program. They had a horrible experience. I think you should look into what their experience, the figure I have, you should confirm. The figure I have is it cost them an increase of $38 million in the first quarter alone, due to higher ingredient costs, higher dispensing fees, and the $38 million was a total cost. So happy to see if we can provide more detail on that, but that's an example, a solid example of what happens when spread pricing is banned.
Any further questions? I'm just going to add something. I know that there's a lot of finger pointing at drug manufacturers, but I want to share a story with you. I'm the chairman. I think I can have that privilege to do so. A career ago, I was hired to do some consulting for a drug company. And they had a drug come on the market, and it was a relatively old drug, new delivery system. They'd spent about $300 million bringing the drug to market. The drug cost 20 cents per month to make, $1.20 or $1.50 for the packaging to put it in. So I was involved in focus groups and consulting with focus groups on what the best price would be for this drug to hit the market. Obviously, they had to cover their investment. They had to make sure there was a profit. So they settled on a monthly price of $90 a month. That was agreeable to the focus groups that they shop that to. And then they started shopping it to the plans. What would it cost to bring this drug to market? And the amount of fees that they were going to be charged by the middlemen. It wasn't just PBMs, it was the wholesalers, it was a number of, the final price of that drug came out to be $365 a month. So to say it's all the drug manufacturers, you know, I'm gonna call you out on that one because I don't believe that's true. So that wasn't a question, that was a statement. I get the opportunity to do that, but I just wanted to make sure that the other side, and you know, there's no, everyone has a role. Everyone has a role in drug pricing. Everyone does, whether it's the pharmacy on Main Street, to the drug manufacturer, to the wholesaler, to the PBM. But to just want to make sure we're not pointing the finger completely at one area. So that was my comment. I get to do that, and there we go. So thank you very much. I don't see any further questions from the committee. We do have your comments. I've got your comments, Curtis, and we'll take all of that back to the committee. Appreciate that. Is there anyone else that would like to speak on Senate Bill 547? Senator Rosenwald. Absolutely.
I'd like to thank you again for the record. Cindy Rosenwald from Senate District 13. Just want to mention 3 things. It was great to see Mr. Lapine back here. He mentioned that he was representing Cigna, but I think he forgot to say that Cigna owns one of the largest PBMs, Express Scripts. So I just want to make sure that is part of the record. Secondly,
I think Margaret mentioned that.
Okay,
Yes, thank you.
then I didn't hear that. There was a lot of discussion about how a fiduciary, they shouldn't have a fiduciary responsibility because they don't set prices. However, they do send rebates back to the entities that hire them, but they also generate fees from the drug manufacturers to put drugs in certain places on a formulary. So I think fiduciary has a lot more in it than setting prices. And just the third thing I would say is that my initial draft of this bill did allow for a plan sponsor to have spread pricing if they desired it. And in some of the work from the insurance department, they removed that. So I'd ask the committee to talk about that with the insurance department.
Great, thank you very much. And like I said, we've got other bills with this. We're not going to, we'll work on this and appreciate the testimony. And I'm going to close the hearing. The last bill standing between us and lunch, so
I'll be quick.
we'll
I'll try to
hopefully.
be quick. Thank you, Mr. Chairman. For the record, Cindy Rosenwald, Senate District 13. I'm here to introduce Senate Bill 548, a bill that provides increased consumer protection through more transparency. Senate Bill 548 requires notice to patients from sudden loss of access to care when an insurer and provider terminate a contract and a large number of patients are affected. It reduces confusion about potential network changes by increasing visibility of the impact in a change in a carrier-provider relationship. The bill establishes a common sense safeguard. When 1,000 or more covered lives are affected, the insurance commissioner will convene a public hearing. This bill does not interfere with negotiations or dictate contract terms. It only adds transparency when the public impact is really significant. Patients deserve notice, clarity, and a voice when changes could disrupt ongoing treatment that may emanate from a network change. Continuity of care is especially critical for seniors, patients with chronic illness, and individuals receiving mental health or substance use disorder treatment. Abrupt network changes can delay care, disrupt treatment plans and medication regimens, increase more costly emergency department use, and worsen health outcomes. Public hearings allow for patients to be heard, providers to share real-world impact, regulators to make informed decisions, and communities to understand what is changing and why. This bill strengthens accountability without adding unnecessary bureaucracy. The bill supports stability in local healthcare systems while preserving market-based negotiations. Transparency builds trust between patients, providers, insurance, and the state. This is a practical, balanced approach that puts patients first while respecting the dynamics of the healthcare marketplace. And finally, having looked at the fiscal note, which says the insurance department needs to add a person solely to work on these public hearings, I would say they would be expecting a lot of significant provider carrier network changes and a lot of public hearings to have to take place, not just a few. Thank you.
Thank you, Senator. I just have a question. I know there's only one hospital that signed in on this, and I'm assuming this may or may not affect other hospital systems, or is this just an issue with one hospital system?
I think if you looked at the fiscal note, the insurance department thinks it would be broad in its application, and that's why they need a member, a new position. It did come to me from one hospital, but I think you'd have to ask the hospitals.
We'll make sure we do
The
that.
insurance
Yes,
department.
you know I will, yes.
I mean, I have to say I was surprised by the fiscal note because
Yeah.
it makes me think they're expecting a lot of hearings.
Yeah. All right, well, thank you. Is there any
Thank you.
questions for Senator Rosenwald? You made it, we did it. We got through Senator Rosenwald Day.
I might be back.
All right, all right. Speaking of the department, Michelle Heaton and Commissioner Betancourt.
Good morning, Michelle Heaton. I'm Director of Life and Health at the New Hampshire Insurance Department. Unfortunately, Commissioner Betancourt got pulled away to another hearing, so he's not going to be able to attend today. But he did want me to convey that the department is broadly supportive of public hearings on large provider contract terminations and notice of affected persons. There are already certain protections in place in our statute to require notice when contracts are terminated. We think that there's just some technical work that maybe needs to be done with this bill to further define what the expectations are so that we're able to better implement what is being proposed here. So I'll leave it at that, but I'm happy to answer questions.
Thank you. And I know we heard from the sponsor what the goal was there. Is there an opportunity to do some of this in rulemaking to achieve our objectives, or?
I think in order for us to better implement this, we need a better idea of what exactly we're looking to achieve here. I think the way it's written now, it implies that there's supposed to be a public hearing if there's concerns that a contract is heading towards termination. Right now, the consumer protections regarding continuation of care and notice to consumers comes into effect once the contract is actually terminated. And I think that there's a little bit of a discrepancy there with the way things are operating now and with what is being proposed here. And so I'm sure carriers can talk a lot more about this, but some of these contract negotiations can get very contentious and there can be threats of termination, but that never actually comes to fruition. So if the department is expected to hold public hearings when there's a threat of termination, that could be a much larger group of hearings than if we're talking about when the contract is actually terminated. But then at the same point, if we're having a public hearing once the contract's terminated, is that too late? What exactly are we trying to achieve with the public hearing? I think getting a better understanding of those things, we can help the sponsors tweak some of this language to make it a little bit more workable to ensure that there are consumer protections in place and appropriate transparency.
Thank you. Any questions for the department? Senator Prentice.
Thank you, Chair Rochford. Thank you, Attorney Heaton, for joining us. You talked about that this would need some technical changes, but I did, unless you just spelled that out and talking about like when a hearing was and what, and what the purpose would be. Is there anything else that we're missing? And then I have a question about the hearings or more of a statement.
I think getting a better idea of the real specifics about what's trying to be achieved here, we can work on some language to address those. But I think anytime we use the term public hearing, then that we have a statute about public hearings, 400A, about what we need to do. There's certain notice requirements, there's different like legal procedure issues that we just want better guidance on what the expectation is so that we can appropriately craft the language to achieve what we're looking for. Because it doesn't sound like this would be an adjudicatory hearing. It sounds like it's a little bit something different. Adjudicatory hearings would fall under 541A. There's certain requirements there. So we would just want to button up some of this language to make it clear what laws would apply to this public hearing, what rights are, and what kind of the takeaway is at the end of the hearing. What's the expectation coming in from the department following that public hearing?
Yeah.
Follow-up?
So
Yes.
thank you very much. So I was actually going to ask you about, well, you took me to 541A and that, so if a plan respectfully were to terminate a contract, it could constitute I know the 541A is used in emergencies and it requires a pretty quick turnaround for a hearing. And I think ending a contract could present an emergency for a community. It's just a matter of how much time is going to be.
Yeah.
Is it 5 days or is it more? So 541A takes you into that emergency loop where you can a decision can be made about whether this does constitute a threat or not. But I mean, I do feel that there's some middle ground here because there at least within the last year, I don't want Siri to follow me around. At least within the last year, a plan terminated a contract, and there was in that area there was a lot of concern about like where would we go and get our health care now. So Medicare D.
So yeah, there's been disruptions in the Medicare Advantage market. We don't have any authority over Medicare Advantage. We try to assist consumers the best we can, but we have no regulatory authority there. I think when we're talking about contract negotiations and contract terminations, there's different things happening. So when we're talking about emergencies under 541A, that's when the state agency or regulatory body is taking some kind of administrative action.
Right.
In this type of context, the department doesn't take any action. We don't have any role in contract negotiations or terminations. We just make sure that certain consumer protections are being enforced. Like once the contract terminates, there's a period of continuation of continuing care where people can continue to access that care for a period of 60 days in order to help transition that care to other in-network providers. There's certain notice requirements that need to go out to consumers. So currently that's where we focus our regulatory efforts. However, there are other similar things that come into play, like network adequacy, which we were talking about earlier. There are certain triggers in network adequacy. If there are significant disruptions, such as like a hospital leaving the network or certain triggers under our network adequacy requirements, then there is a mandatory report to the department. We would run our network adequacy to ensure that consumers still have access to an adequate network. And there could be more actions taken in the context of network adequacy. But that's not necessarily, we don't have the ability to force two entities to contract.
Just quickly, so you're looking for a home for this because it's not necessarily an emergency where the department would be taking an action, but it could be constituted in the midst of, if a contract ends, even 60 days might be a hard loop. And I think what one of the pieces that's trying to be achieved here overall is an opportunity for public comment about that happening in a more formal setting. So I do understand what you're saying. I think just trying to figure out where it goes, and
I think there's
be careful,
definitely
seriously.
opportunity here to, we just need to tighten up some of the language to make sure we're addressing, what the legislature wants us to do. And so we're happy to work with the sponsors on this.
The distinction between 541A and other rulemaking and public hearings has been helpful.
Any further questions from the department? No, thank you very much. Let's hear from the hospitals. St. Joe's, I've got you signed up for 3 folks. You guys all want to come up together or separately? I'll let you do whatever you want to do, but you choose. I got 2 chairs.
Well, good morning, Mr. Chairman, members of the committee. My name is John Jurczyk. I have been president of St. Joseph Hospital in Nashua for over 7 years, a resident of Hollis, and I am here to voice my support for Senate Bill 548, which is looking at insurance standards and notification. This bill is very simple. It allows for public comment with certain triggers, triggering that type of event. It helps to level the playing field in terms of reducing the noise that comes with the narratives when both parties are having difficulty reaching agreement. It allows people to ask questions, to understand where resources may be. And so the whole focus of the bill is about really transparency to the public. Often contract terminations do not sync up with open enrollment. So then that presents a unique problem for those enrolled, and that can be tens of thousands of individuals in a particular network. And so it allows, people to ask questions, understand what is going on. It does not breach the contract terms. There's no way that it compels either party to disclose those terms. It just really gives a good opportunity to ask questions and be transparent. And again, it continues to allow the free market negotiation process between carrier and provider. So I urge your support with me. I have our Chief Financial Officer, Jerry Hadley, and the Medical Director of our Employed Medical Group, Dr. Donald Reap, and they can offer their perspective as well. And we'll take questions however you'd like.
Thank you.
Good morning, Chairman, members of the committee. My name is Jerry Hadley. I'm the Vice President of Finance at St. Joe's Hospital in Nashua. When provider contracts are terminated, it causes many significant consequences for both hospitals, but more importantly, it causes issues for the patients that we care for. Patients have relationship with their providers. They have relationship with the hospitals, and those relationships goes on for many years. They will now have to make the decision of, do I change the provider that I've seen for all these years, would have my care, that have my relationship with, or stay and pay out-of-pocket costs for being out of network. And those, in some cases, could be significant, what the cost will be. It also disrupts care in terms of chronic patients. They have behavioral health issues, maternity care, complex coordinated care. Sure, sorry about that. It's my low voice, I'm told all the time. It also disrupts care for patients with chronic issues, mental health issues, behavioral health, maternity, and complex care that needs really a coordinated effort between providers and hospitals. For the hospitals, it could impact increase in workforces. We may have to look at what expenses we're paying, how we're paying our salaries, what programs that we have, and do we have to limit some of the programs that are available for the patients that need them? That's not something that we want to do or need to do. What it does also is really promotes transparency, a public hearing when a provider, and it's only providers with 1,000 covered lives, terminates a program. It does require the public hearing, opens up transparency with the insurance commissioner, and accordingly also strengthens it with the joint correspondence with the commissioner, with the insurance carrier and the hospitals. But also doing this, it still maintains the insurer's right to negotiate a contract. It doesn't change any of the negotiating powers that they have or who is in or out of their network. It just relates to more transparency in the program. So for that, I do support the bill and hope that you'll recommend it for approval. Thank you.
Thank you.
Good morning. Thank you, Chairman Reichel, and members of the committee. I just wanted to introduce myself. My name is Donald Reep. I'm a practicing internist at St. Joseph Hospital. I'm board certified in internal medicine. I'm the medical director for our employed physician group and past president of our medical staff. So I've been practicing in New Hampshire. I'm a resident of Hollis as well, and I've been practicing in New Hampshire for over 20 years. And what I wanted to tell you is, on patient side, a patient-physician relationship strengthens over time. And I've had patients that I've been taking care of for that 20 years that I've been here. And it is, they find me their navigator through the health system. We have long-standing relationships, and I will walk into an exam room, and this happened to me earlier this year or last year, the end of last year, where I find a patient in tears, clutching a letter that they've received from their insurance company saying that they would no longer be able to see me for their care, that I'm now going to be out of their network. And I have to spend time reassuring them that maybe that's not really the case. Maybe this is something that will, sort itself out, that there are negotiations that are ongoing, and that they, shouldn't panic over it. But they do. They're worried. They're in the middle of treatment for a serious medical condition. They're wondering whether or not they can continue to get the care that they've been getting if I'm no longer part of the network. Will that jeopardize the care that they're receiving? So they know that, as a new patient, that they're going to have to scramble to find someone else. It may take weeks or months before they can establish themselves with another provider. And I think that that unilateral communication that comes from an insurance company during this dispute is unnecessary. It just causes unnecessary anxiety for that patient. This bill says that there'll be a joint communication, that'll be outlining all the rights that the patient would have in terms of, ongoing care, the fact there'll be a hearing. So I don't think that when they receive that first letter that they are aware of all their rights, and I think that this would allow them to really spell out the rights that they have in terms of ongoing care, and it would certainly make it much better for the patient. And that's what I do every day, is take care of patients, and I hope that you will support this bill, and I thank you for your time and your service to the people of the state of New Hampshire.
Thank you. Now, I just had a question about the unilateral communication. And I've received one of these letters before, and I know what that's like, Is there anything stopping you from communicating as a provider on your own about this? I mean, if they're going to get a letter, if they're getting letters from the provider, and you know where in the provider, they're getting a letter from the insurance carrier saying, negotiations are breaking down, we're anticipating a drop in coverage. The legislation as we have presented requires a joint written notice. Is there anything stopping you from sending out communications now on your own?
There wouldn't be anything stopping us, but, I don't think that it serves them well to receive, two different correspondents, one from the insurance company and one from the provider. I don't think that it's in their best interest. I think it'd be nice if we could just come up with, a joint communication that allows for the patient to understand their rights and allay their anxiety that is certainly provoked by receiving that letter.
Okay, thank you. Any questions from the committee? None? Thank you very much.
Thank you.
Sabrina. Welcome back.
Thank you. Good morning, Chair Rochford and members of the committee. Thank you for the opportunity to speak on this bill. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem Blue Cross Blue Shield. I'll try to be very brief. We are opposed to SB 548. I think we have concerns about some of the technical issues that the department raised. I will just start by adding that the notice that was just mentioned is required by carriers currently under law. We have to give the notice once a contract is terminated. I have an example of what that notice looks like. It does spell out for our members what next steps might be. There are continuity of care laws in place currently, so people don't immediately lose care. We obviously don't want disruption for our members either. So I just wanted to point that out. I also think it's worth mentioning the way the bill is drafted. It currently says carriers have to give a notice if there's an intent to terminate, but I'm curious, what if a provider intends to terminate? And on that point, I just want to note, it's generally our intent to reach an agreement with providers in order to maintain our networks and have quality providers. Most contracts are not intended for termination. They do have renewal dates, so there's dates by which we do have to reach agreement. And the parties generally work in good faith to achieve mutually agreeable terms of the agreement. And so I don't know how you would determine what the intent to terminate would be, because we would say we basically don't ever intend to terminate. We're trying to negotiate and get a contract done. So I think there's a big question there. Also, the way the bill is drafted, the timing is kind of unclear because I would say, both sides are pouring enormous amounts of energy, time and energy in trying to get a contract finalized. And I do think, depending on the timing of the hearing, it could potentially shift energy away from actually trying to get that contract finalized and be a distraction. So I'm curious to know how the timing would work out, because the way it's currently drafted, it says carriers would have to give notice to the insurance department, and then after 5 business days, there would be 15 days from the intent to term. They don't seem to line up. So I think there needs to be clarity around what the point of the public hearing is and when it would actually be. So thank you for the opportunity to speak, and happy to take any questions.
Senator Abard.
Yes, thank you. And thank you, Sabrina, for your testimony. So when you say the timing is unclear, am I understanding that this could be a leveraging tool or in negotiations?
I don't know. I mean, I wouldn't want it to be. I don't think that's good for anyone. I think if the idea is that after termination, there's a public hearing, that needs to be more clearly spelled out. But then I'm curious, what is the goal of that public hearing if the contract has actually already been terminated? If it's prior to actual termination of the contract, then I think you really get into sort of interfering with the negotiations themselves.
That's it. Thank you. No.
Any other questions? Senator Prentice.
Thank you, Sabrina. I understand what you're saying about timing and prior versus after. I just want to ask you, if these situations happen now, do people call most likely the carrier? Like, do you get an influx of calls about this? I mean, now we've heard that they go to, their doctors or their care providers, but, just thinking about the outlet and the timing, where do they go?
Well, we do send a notice, which the timing is prescribed by law, but in it, it does spell out resources and next steps. And so they do contact the insurance company. Well, in my experience, they contact us.
Okay, thank you.
Any other questions? Thank you very much.
Thank you.
Peter Bragdon. One more time.
Thank you, Mr. Chairman, members of the committee. Again, Peter Bragdon representing, depending on your viewpoint, Harvard Pilgrim Healthcare or Hewlett Packard. Just a couple of things. I think I would agree with what the department said, and notice I didn't sign up for as either opposed or in support, but some clarity would certainly be good. When I first looked at this bill, and most of the time I was looking at it, I was under the impression it was designed for a hearing in the midst of the negotiation process, which is problematic in itself. As I thought about it more last night and heard some of the testimony, it seems the goal may be to have some kind of a public thing once the contract is terminated, so people have a better understanding of what's going on. So those are two different things, and I think the language could probably be a lot clearer. I know that when Harvard Pilgrim, at least when contracts are terminated, either by providers or by Harvard Pilgrim, obviously we send a letter. We put information on our webpage for people and obviously make them aware of the member services line that they can call. And yes, we do get calls, and I'm sure the providers get calls as well. So one thing I would point out that as I listened just now, the whole issue of the joint letter could be problematic because basically the joint letter says both sides have to agree on what the letter says. And if both sides don't agree on what the letter says, the letter doesn't go out. The Department of Insurance regulates us, the carriers. If the letter doesn't go out, we're in violation of the statute. The department doesn't regulate providers. So if there's no agreement reached on what the letter should say, it becomes a problem. So I would certainly think a joint letter is not a bad idea, and certainly nothing prohibits the providers from sending a letter as well as the carrier sending a letter. But I think a joint letter has some potential problems if things are really bad in terms of the communication between the two parties. Happy to answer any questions.
Are there any questions?
Thank you all.
No, thank you very much. Is there anyone else that'd like to speak on Senate Bill 548? With that, I will close the hearing, and we will be back here at 1 p.m.
Somebody fanning and somebody shivering, so what do we do? You have the floor, Senator.
Thank you. And I'm Senator Tara Reardon, representing District 15, Concord, Bow, and Hopkinton. This bill relative to the licensing of international physicians, I brought on behalf of Bi-State Primary Care, and they're here to talk about it. Like a lot of bills, you learn a lot after you file the bill. This is one modeled on Tennessee law. Some of the verbiage is different than what we use in the state of New Hampshire. I've had a very productive conversation with Dee Jurius from OPLC, and they are here also. The bill before you covers everything we would hope it would cover, that people would be qualified, they would have plenty of experience, that if they're disciplined or a license is revoked, there's an appeal process. All of that's in there, and that's our goal, to be comprehensive. But particularly OPLC believes we can do it in a much neater, shorter, cleaner fashion. This provides for a provisional license that we don't recognize here in New Hampshire. So I will introduce it that far and defer to the experts that know a lot more about this and we'll obviously have an amendment.
All right, thank you, Senator. And
Thank
with
you.
No further questions. We'll hear from our next speaker, Christine Stoddard.
Good afternoon. Christine Stoddard from Bi-State Primary Care Association. I'm the Senior Director of Public Policy there for our New Hampshire business. And I also work with the New Hampshire Healthcare Workforce Coalition that has been working with over 80 organizations since 2018 on healthcare workforce issues. And I know you've heard me say a million times, so I'm not going to belabor it, that we have a healthcare workforce shortage in New Hampshire. And I did give the language to Senator Reardon, knowing that it would be amended, but I do want to apologize to the medical community if I gave you a heart attack by letting this get into bill form and not explaining that this is just the beginning of the legislative process, and please don't panic. So I did want to apologize for that. I have a colleague here from Bi-State who has been working with our recruitment center for over 30 years, trying to fill the gaps in our healthcare workforce shortage. But the bottom line is there are not enough humans in this state to fill physician slots. There are not enough people in the country to fill physician slots. And so we need to make it the path to licensure clearer. We are not changing statute in that people who are trained and educated in other countries can already be licensed in the state of New Hampshire. That is not new. We are just trying to make the path more clear, easy to understand, and a shorter timeline of practice. And I'd be happy to answer any questions, but I know there are other people here too to speak. And I forgot to mention, we know it needs an amendment, so we're going to work together as a group to fix it.
Wonderful, thank you. And seeing no further questions, appreciate it. Ken Gordon.
Thank you, members of the committee. My name is Ken Gordon. I serve as the CEO of Coos County Family Health Services. We're an FQHC serving northern New Hampshire. I'm pleased to offer our support for Senate Bill 457, a bill that clarifies the path to licensure for physicians educated and trained abroad. Our federally qualified health center serves more than 13,000 patients, and we've been in business for about almost 50 years at this point. The services that we offer include outpatient primary care, medical care for patients in nursing homes, mental health counseling, substance abuse treatment, and dental care. We're the sole provider of primary care in the Berlin-Gorham region and recently established a primary care clinic and dental clinic in the Colebrook area. As you know, North Country residents face a multitude of challenges that include economic disadvantage, an aging population, and higher rates of chronic disease. Substance abuse and mental health conditions are also more occurring than in other regions of the state. And there's a real shortage of medical providers in our region that we're working hard to address. One of my responsibilities as the CEO of the organization is to recruit new physicians. It's a challenging role that has become increasingly difficult as many in the current workforce are moving towards retirement. The supply of new providers has not kept up with demand, and competition between provider organizations has increased. I wanted to tell you about an example with the podiatrist who works for us. We were unable to fill this position for several years and finally settled upon an individual who was originally trained in England and came to the United States. He had to restart his education and training in the United States. So went to school, podiatry school in New York, did a residency in New York, and then eventually was able to practice in the US. Most people are not in a position to be able to do that, and so we really need help trying to put every tool that we can in front of us to be able to fill these vacant positions, particularly in areas that are difficult to recruit. We do need to expand the tools to recruit and retain qualified physicians, not only in the North Country, but in every region of the state, as the competition for qualified physicians is both regional and national in scope. Senate Bill 457 is a good step in that direction. It offers a reasonable and clearly defined path towards physician licensure and appropriate safeguards and oversights to ensure the safety and well-being of New Hampshire residents. Thank you for your consideration. Happy to answer any questions.
Any questions from the committee? I apologize for my late arrival. Senator Reardon and I were switching committees there for a minute. I do have a question, and maybe this has already been answered, and I apologize if it has not already. One of the things I looked at, and I know Senator Avard said that somebody's already said that this is needs possibly an amendment, but page 1, line 13, and maybe this isn't a question for you. We could ask the prime sponsor on this. Possesses basic fluency in English language. I mean, I know other programs have the TOEFL test, which is essentially does that same thing. Do you see there'd be any problematic with putting that as a standard of English proficiency?
I don't. There are others probably in a better position to answer the question though.
And you may, again, I'm coming into this late, so the other question I had on for the provisional licenses, they're practicing at facilities that are have a residency program in place. I mean, obviously, we're working on one right now in Coos County, which I believe would satisfy those qualifications. But to my knowledge, there aren't many in New Hampshire. And previously in the bill, it said the candidates would already have had to complete a residency in another country. Do you feel that the residency requirements as far as practicing in a place that has a residency, is there areas where maybe that could be loosened up and still provide adequate oversight?
I believe so. I think the language related to residencies is something that needs to be looked at in the bill. It's a little vague in my opinion. And I'm not sure of its relevance necessarily to the quality of the physician who's.
Because I know you and I share a lot of the same concerns. Where we come from, we have a major shortage of providers. And I want to make sure we're getting some of these providers. There's certainly a need, and I want to make sure that we are protecting public health and public safety, but at the same time, not putting too many obstacles and roadblocks into a program like that. Very good.
Thank you.
Thank you very much. Ben Bradley.
Thank you, Mr. Chairman and members of the committee. I don't have written testimony. I do want to start off by complimenting Senator Avard's tie today. I brought my own, the same, so I feel in good company. I just wanted to provide some perspective from hospitals that we do generally support the concept of international physicians being able to be licensed in New Hampshire so long as they satisfy the qualifications that we expect of traditionally licensed physicians in the state of New Hampshire. I would echo the workforce challenges and the need for making New Hampshire competitive in recruiting qualified physicians to New Hampshire to provide services across the state. Happy to work with stakeholders on the amendment if necessary, certainly with the executive director of OPLC to ensure that this moves forward appropriately if necessary.
Great, thank you. Any questions? Thank you very much. And I see the director of OPLC here. Let's see what she has to say.
Good afternoon. Just for the record, Deanna Juris, Executive Director, OPLC. I have sent a few copies of a relevant Board of Medicine rule that I think would be applicable to this down the corner making its way. So that's not my written testimony, but just relevant in part. Office is not taking a position on this bill, just working through operational concerns. The bill as drafted, again, we acknowledge is probably going to need amendment. It does create a new license type, this provisional license. I'm not sure if that's the intent of the sponsor or the desire of this committee, but want to point that out. Medicine 30201 specifically calls out the educational requirements. So this is existing rule within the Board of Medicine. It is nearly identical in the PLC 313 rules, which are the reciprocity based on the endorsement of reciprocity. That's 31017 that this legislature signed by the governor 2.5 years ago. So it already contemplates the scenario where somebody would have done postgraduate medical training outside of the U.S. in addition to their education. And it lays out the possible equivalents that could be if it's not an accredited postdoc. So this is an existing pathway, already can happen. I think the biggest substantive difference is that the current rule says it's completion of 10 or more years of practice combined with proof of 2 years of postgraduate training. The bill as contemplated right now would say 5 years. So I would say that's the most substantial change. I will note for an individual, either highly qualified or there's a critical need, rules, unlike laws, can be waived for individual circumstances through a process, whether that's board or office rules. So if there was an extenuating circumstance, they could request a waiver of that specific provision of the 10 years, either in the Board of Medicine or perhaps through the OPLC through endorsement or reciprocity. So we think that this is already covered entirely by the current process. Would be happy to work with you to make sure that any further legislation or language that is operational and doesn't disrupt the existing pathways or potentially make it more challenging. So happy to take any questions on or offline.
Are there any questions for the commissioner, the director? No, thank you very much.
Just got promoted to commissioner.
I know, huh?
If it comes with a pay raise, I'll take it.
We can't guarantee that. This is a policy committee. Let's see. This is Louis Harding, Commission on Primary Care.
Mr. Chairman and members of the committee, my name is Lori. Sorry that you couldn't read my writing. My husband talks about that all the time.
Well, I'm a pharmacist. I should probably be able to read it.
Oh, okay. So I am a member of the Commission on the Interdisciplinary Primary Care Workforce. I served for 10 years in the House. Senator Long, it's nice to see you. And during that time, in the last 2 years of my tenure in the House, I was appointed by the governor to the commission. And before I knew it, I was chair of the commission, which I actually served in that capacity for about 10 years. But I'm delighted to be part of the commission because I'm a nurse and really have tremendous concerns for the workforce shortages that we're having here in New Hampshire, particularly in the area of primary care. And while we started off calling the commission the primary care workforce, we realized very quickly that it was more than physicians that were necessary to make things work in some of the rural areas of our state and in most of the healthcare facilities in our state. We're very supportive of this initiative, but certainly along with everybody else recognize that we need to do a little bit more work on this. And I've identified some of the areas that we might be concerned about and need to work on in the letter that I just gave you. And we have several members of the commission, one ahead of the chair of a residency down in Cheshire, our newest family physician recipe. And then the other person is certainly associated with Kreisel Medical School. So we've got people that are really willing to put some elbow grease into this and work with Bi-State to really perhaps develop something that's going to be very useful and efficient. So I'm certainly willing to answer any questions that you might have.
Thank you. Are there any questions from the committee? Thank you very much.
Thank you.
Is there anyone else that would like to speak on Senate Bill 457? I'm going to close the hearing. I'm going to open the hearing on Senate Bill 645 relative to income eligibility for the New Hampshire Child Scholarship Program and reallocating certain revenue to fund the program. I call Senator Tara Reardon.
Good afternoon, committee members. My name is Tara Reardon. I'm the senator for District 15, including Concord, Bow, and Hopkinton. And I am here to present, maybe I should have this already, Senate Bill 648, which is a, I'm sorry, 645.
645.
Got it,
Yes.
sorry. 645 relative to income eligibility for the New Hampshire Child Scholarship Program and reallocating certain revenue. And I will say in the subject matter of childcare, as a mother of three and a grandmother of three, childcare, the availability and the affordable childcare has not only influenced so many decisions that I've made in my life, I know it's true of my children and for many of my constituents that I speak with. Childcare is the difference between going to work or not, between getting a certain job or not, seizing opportunities, going to school. And today, childcare even impacts your housing choices. And I'll say a little bit more about that in a minute, because it includes the ability to actually afford that childcare. I have a family member, a husband and wife, 2 children in their family, and their childcare expenses are $32,800 a year for those 2 children. Eligibility for childcare scholarships at the current time right now are available up to 85% of area median income. And that makes about 61,000 kids eligible, but the utilization rate in New Hampshire is only 8% right now. There's 8% of the population that's taking advantage of that or know about it and are applying for it. My proposal here is to increase that to 95% for a household. And I will tell you, a household of 4, the income level for 95% of area median income is about $95,000. So think about the figures that we've just talked about. The gross income for that family is $95,000, and the child care expenses are as high as $32,000, and that's in after-tax income. So with the total expenditure for child care, the Child Care Scholarship Fund is $41.5 right now. We're underfunded for it this year. 29 million of that has come in a block grant. This proposal, as it's written right now, would add $5 or $6 million of revenue to that. But I do have an amendment, and the amendment would encompass more lottery funding, another 2%, so it would be closer to $10 million that would be added to that. So again, that family of four with $95,000 of gross income, that means we would save that family $16,800 a year, which is a remarkable budget impact for our constituents that are doing this. And they're clamoring for real relief in budgets. We do lots of things here that we expect will make some changes in their property tax rate, maybe, but this is an opportunity to make a real impact and lots of young families in our state who are just trying to afford housing and childcare and afford to have the second person in that home be able to go to work. Again, the amendment that I'll pass around uses 2% of other lottery funds, not just the video lottery terminals. And that's a fund. I brought the amendment because that fund is steadily increasing. It's a very healthy fund. It's steadily increasing. And I'll say that childcare is one of the most important things, along with housing. Childcare is one of the most important things that we are doing right now. We know what the domino effect of that is. If you can go to work, you get to spend more money in your community. You get a job that you'll have Social Security and retirement savings in the years to come. It has a great ripple effect in our communities if people can afford to go to work. And I've got to say, in a $95,000 household budget, gross income, $16,000 would be a game changer between somebody being able to afford to buy a house or not. And I'll give Sophie the amendments here.
Thank you, Senator. We did get one amendment, 104.
They've already got it. That's not the right one you've got there. Let's see. Yeah. Appreciate it.
So that's the amendment that we're considering, 104.
Correct. It
Okay.
expands on the number of buckets of lottery funds.
Sure.
beyond
And just so
beginning.
I can clarify, my initial calculations had this at about 3.39 million, and you're saying with this amendment, it would bring it up to about 10 million?
So my initial calculation had it around 5 million.
Okay.
And with this, it would bring it to.
I'm not good at math, so, yeah.
Right there with you. Right
Yeah.
there with you.
All right. Are there any questions from the committee? Thank you, Senator.
Thank you, Senator. Appreciate it.
So I would just ask that we don't have standing in the back of the room. If there are I see there are plenty of open seats here, but if you can't find a seat, wait in the hall and we will come get you. But we don't have standing in the back of the room here. Thank you. Karen Hebert and Brian Clark.
Good afternoon. My name is Karen Hebert. I'm the Director for the Division of Economic Stability at DHHS.
Excuse me. Good afternoon. I'm Brian Clark, Counsel for the Division of Economic Stability. So we're here today to talk about SB 645 and what it would mean for the department. So currently there is a child care scholarship program which utilizes Child Care Development Fund federal dollars to provide child care for families who are working, enrolled in a participating facility or license exempt provider, and have a household income less than or equal to 85% of the state median income. What this proposed legislation would do is create a new expanded eligibility for childcare scholarship. There's a hard limit on what we can do with CCDF dollars in terms of income eligibility. So we wouldn't be able to use CCDF dollars for this particular income group between 85% and 95% of the state median income. So we would need to make system changes to ensure that these individuals, households that fall in this income bracket are kept separate from CCDF cases so that we would be able to assure to the feds that no federal dollars were used for individuals with household incomes greater than 85% of the state median income. Based on census information, if every household with children in the childcare age bracket, we estimate it could be as high as 6,000 children that could be eligible, and this funding would only cover about 25% of the group. The proposed legislation does let us put limits based on financial availability. So what would happen is we would start accepting applications for individuals who are over 85%, opening them for childcare, monitoring the funding, and when the funding gets too low, we would have to implement a wait list. I'm available for any questions.
Senator Ybarra.
Yes, so you said there would be possibly 6,000 children, only 25% of them would be eligible, and the $10 million would go to the 25%, correct?
Yes, that's correct.
And do you follow up? You're good. Okay. So, and I may have missed that with Senator Reardon's testimony, but how much money does this scholarship fund currently have in it annually or biennially?
So the current budget per fiscal year right now is about $53 million. That includes a transfer of TANF funding that up to the maximum amount allowable into that for the purposes of avoiding a wait list for childcare for that particular scholarship that we had anticipated we were going to need to put into place. So with the transfer of TANF funds, it includes that amount.
And that's 53 annually?
Approximately, yes.
Right. And then what do you anticipate being the administrative cost, FTEs? Is there going to be any change in administration to do something like this?
Yes, our fiscal note worksheet will be on the way. It was not added to the legislation, but we did need a business administrator and a system analyst, as well as additional staff to handle the caseload. So I can go into detail, but the business administrator would be in charge of monitoring the financial health of the fund and doing a wait list if that is necessary.
And how many FTEs total would you?
9.
9?
Yes.
Okay. Additional to what we have now?
Yes.
Oh, great. If you can send that to us, your timing is impeccable. Are there any further questions of the committee? All right, with that, thank you very much.
Thank you.
All right, Mackenzie Nicholson.
They feel low. Can you? Do I really want to be the person giving testimony who sits here raising my chair up and down? I don't know. All good. I just feel low. Thank you so much. Thank you, Chairman Rochefort and members of the Senate Health and Human Services Committee. For the record, my name is Mackenzie Nicholson. I'm the co-senior director of Moms Rising in New Hampshire, an organization that represents thousands of moms and their families across the Granite State. And I'm here today because we are in support of the goals of Senate Bill 645 and the conversation that it opens around a dedicated source of revenue to support our struggling childcare sector. New Hampshire families are doing everything right and still coming up short. The New Hampshire Fiscal Policy Institute found that the median household income in New Hampshire did not cover the basic cost for a family of four, and they still fell about $2,000 short. And that gap is driven by rising costs with housing, childcare, healthcare. It's all outpacing what families earn. And childcare costs are no joke. In 2024, it cost the average family over $30,000 a year to have an infant and a toddler in a childcare center in New Hampshire. The federal government says that childcare is only deemed affordable at a maximum 7% of a family's income. That same family of four would need to earn almost $429,000 a year before their childcare is considered affordable by that standard here. And yet, parents are told that the childcare crisis they're experiencing is about individual choices. But there's no amount of budgeting or couponing that can fix a rigged system where the cost of care is reaching a quarter of or more of the average family's income, and there's hardly any shared investment. Families are not failing at budgeting. Our state is failing to build a system that actually supports modern working families. Senate Bill 645 would increase eligibility for our state's child care scholarship program from 85 to 95% of state median income. We love the idea of making our child care scholarship available to more families because we so often hear from our moms that they're just on the edge of qualifying for help and they turn down pay raises because the impact of the raise often means that they lose some of their help. And when a small raise means losing all of your childcare help, it's not a reward for working harder, it's a penalty. No parent should have to choose between moving up at work and keeping safe, stable care for their kids. Childcare is a public good, like schools, roads, and bridges. It's something we can all rely on, whether we have young children at home or not. When families have access to childcare that meets their needs, they can work. Employers can fill jobs, and children can get the stable early learning they need to thrive. A recent New Hampshire Fiscal Policy Institute study found that New Hampshire businesses may lose out on up to $56 million a year because parents aren't in the workforce due to childcare. And when families sit down to do the math and realize it doesn't make sense to go back to work after having a baby, it's often mom who's left with an impossible decision about leaving the workforce. Lost time, lost wages, and lost retirement contributions all add up and deepen inequities for caregivers over a lifetime, and grandparents get pulled in too. Some are happy to help, but many are still working themselves and are not physically able to provide the full-time care. We are asking so much from our families and giving so very little in return. Whether you go back to work after having a baby or stay home, it should be a real choice. But right now, our childcare system offers very little choice because the cost is so high and the supply is so limited. And that's why this revenue conversation that Senate Bill 645 brings to the table is so important. This bill recognizes that we can't solve the childcare crisis without a dedicated revenue source. Basic economics tells us that when demand is high, supply is constrained, and there is no public investment, prices go up and families get pushed out of the market. If we want parents to stay in the workforce and providers to keep their doors open, we have to move beyond hopes, dreams, and one-time federal grants. We hear from our moms every day about these childcare challenges. They talk about challenges with affordability, long drives to the only program that lives near them, or that is near them rather. And we know that recent research shows strong support for asking the wealthiest households to pay more in taxes when that revenue is used to expand access to affordable childcare and early education. Families are hungry for solutions. They're tired of being told it is their fault that the system doesn't work. They know that revenue is a key part of the solution, and they are expecting their elected officials who represent them in Concord to do. They're expecting their elected officials to represent them in Concord while they work to make solutions meet. While they work to make ends meet. Y'all, it's been a long day. I'm sorry. For me, as the representative of thousands of moms in the Granite State, my ask is this: use Senate Bill 645 as a launching point to commit to dedicated revenues for childcare. Keep family access and the care that they want and their needs at the center of this conversation, but also listen closely to the providers about what it will take to make this work on the ground so that it's effective and that the expansion is real. Our members want to work to care for their kids and to stay in the communities they love, but they can't do that without affordable, reliable childcare. And dedicated funding isn't nice extra bonus money. It's the crux of the issue. So thank you for your time. I'm happy to take any questions you have.
Thank you. Are there any questions of the committee? No, thank you very much. David Trumbull.
Good afternoon, Mr. Chairman and committee members. My name is David Trumbull. I'm from the town of Ware. I'm personally interested in this. My wife and I have 2 children, and my wife's a school teacher. She stayed in school, and I became a stay-at-home dad, which I loved. It was the best job ever. It gave me an insight into being a caretaker for young children and how those folks who do this are treated by the broader society. So I support this bill for a couple reasons. First is that at the time in life when most people have their young children, their earnings and their net wealth are at their lowest, and that's when they need help from society. By the time their children reach the age of 16, most these folks will have 3 times as much wealth as they had when their children are young. And this is from a tremendous report by the U.S. Department of Treasury called The Economics of Child Care Supply in the United States, September of 21. It's a long report with numerous citations. The report also talks about what was just mentioned, the federal benchmark of 7%. They recommend that with all the other expenses you have, child care should represent 7% of your budget. But for those families who don't qualify for existing federal programs, they have to spend on average 30% of their income for childcare. So that means something else has to give. Whatever it is, that's a huge gap. The result is that families don't use childcare. Somebody stays home. That means it's longer before that person can return to the workforce. That means missed opportunities, less chances for advancement, lower salaries when they come back, and lower lifetime earnings. For example, even if you have a graduate school degree, an 18-month break to stay home with your child will lead to a 40% decrease in wages for people with an MBA and a 29% decrease for people with a law degree or a PhD. Passing this bill would be an investment in our families and in our society. The New Hampshire Fiscal Policy Institute report that was cited indicated that 17,000 people in New Hampshire are out of the labor force every month because they cannot get childcare. 13% of employed parents leave their job, another 7% lose their job, and almost half reduce their hours. The impact is that families have less wages. The Fiscal Policy Institute says that in total for the state of New Hampshire, the lack of childcare that's affordable leads to lower wages on the tune of $180 million per year that we have less. That means less state and local tax revenue, and they estimate it is as high as $14 million a year. So you're being asked to spend $10 million a year, but by not spending that $10 million, the state is losing $14 million a year, plus all the other benefits to society. So clearly this would be a net plus. In fact, this very report that I cited to you says that $1 invested in preschool programs pays off more than $9 back to society. For one simple example, a child who goes to early education will get a head start when they get into school. The school will need less additional resources to help that child if they need additional help. Spend $1 now, you save $9 down the road. You save more than $1 this year, but in the long run, you save $9. And look at the OECD countries around the world. These are democracies with market economies. The United States only spends $2,400 per child on early childhood education. The EU average is $4,700. In other words, for every dollar we're willing to spend on early childhood, the EU spends $2. We're almost last in the whole world when it comes to marketplace democracies in our economies. So again, I speak as somebody who was a stay-at-home dad, most wonderful job ever. I was fortunately able to make it work, but a lot of people need to get back to work. They want to get back to work. They want to contribute to their society economically and keep their wages up. I urge you to pass this bill. Thank you very much.
Thank you very much. Are there any questions of the committee? Thank you very much. Cora Hoppy.
Now it's on, okay. That was confusing, it's red. Hi, my name is Corlin Hoppy. I'm the Executive Director at Rochester Child Care. I appreciate your guys' time and effort into listening to our needs. I'm coming to you because as a child care provider of almost 300 kids, we're still struggling. Even with the increase in eligibility, with the enrollment base and the presumptive eligibility, December is the first month I have not worried about cash flow. As an agency, we're not like a normal nonprofit. We're a $3.5 million company that lives paycheck to paycheck. I'm severely underpaid and my staff are not quite paid enough in order to provide the care that we're providing. And we often subsidize our care by my salary. I now work weekends and will cover inside the classroom, stealing time away from my family and my own children I'm trying to raise. So as an agency, we're going to hit our 50-year mark. We've been around since 1976, and we have helped the Rochester community grow to the beautiful community that it is today. But unfortunately, because we're living paycheck to paycheck, because within our district we're seeing budget shortfalls, our programming might have to be cut. And that includes our after-school programs, our AM care that we offer right on site with our school district. And on top of it, we no longer have any kind of cushion if something bad were to happen. A heating system, based on licensing, I'm required to keep a building that was built in 1954 at a minimum temperature of 65 degrees. While we're trying to replace our heat, while we pray that something else doesn't blow up, or we wait for our life safety inspection to come through and we'll have to do repairs, we have nowhere to pull from and no one likes to finance child care centers, especially nonprofit ones, when they have seen funding cliffs and deficits of over $600,000. So this is an opportunity for us to get another revenue stream that, as a parent, I don't qualify for scholarship because my husband is an electrician and makes more money than the eligibility allows for, but I don't get to send my kids to camp during the summer because it's unaffordable. The very same job that I have with a 50% tuition reimbursement will not cover the cost of my 2 kids going to summer camp this summer, leaving another way for me to subsidize is them to come and hang out at work with me or me work from home, which isn't doing them any good for their development and does not give them the social skills and the enrichment that they deserve, that our children deserve. So we really need another dedicated revenue source. This might not be the best one for a long period of time, but at least it's a conversation. At least it's another stepping point to secure funding streams because we feed children with CACFP food programs that no longer subsidizes the cost of our food. So if we're going to continue to thrive and work for another 50 years, we need this other revenue stream. And as a parent who really would love her kids to go to summer care and enjoy the quality care that I offer, I would dream to be eligible for scholarship with my center. So I appreciate your guys' time and listening to my stories. You have any questions?
Great, thank you. Is there any questions from the committee? No, thank you for coming in.
Thank you.
That is the last name I had on the list. Is there anyone else that would like to speak on Senate Bill 645? I'm closing the hearing. Okay, I'm going to open the hearing on Senate Bill 608 relative to family caregiver support in certain programs and child care support for kinship caregivers. I would ask Senator Waters to introduce his bill.
Well, thank you, Mr. Chairman, members of the committee, on your busy day in HH.
Busy day.
Yes, it is. I am Senator David Waters, District 4, here to introduce Senate Bill 608 relative to family caregiver support in certain programs and child care support for kinship caregivers. You'll see in the bill, and I'll go through it in detail in a moment, that it is going to seek permission for HHS to include some services for caregivers under a couple of programs. It's going to extend that family caregiver support services to those people qualifying in that program, and then it's going to take some actions on child care support for kinship caregivers. Just by way of preface, I just want to note how important this issue of caregivers has been to the Senate over the last few years. Senator Birdsell knows well in finance, in the budget, we were able to add some funding for Alzheimer's caregiver respite care. And there are just so many, not just HHS, but so many good people around the state who are helping out for caregiver support, because it is such a growing need in our state. And I mean, in fact, in the United States, 1 out of 4 adults is a family caregiver, and that's about 170,000 people in New Hampshire, and it, in a sense, is uncompensated care that they're offering, valued at about $2.8 billion. And, having been in this role and before with family members, and now in this role again, as people, when you get to my age, tend to find that their family situations require, I really understand the support that caregivers may need. And, particularly the family caregivers who are providing long-term support services, LTSS in New Hampshire, and that the benefits of providing some assistance to them can really help their caregivers' mental, physical, and financial well-being, but of course for the people they're taking care of as well. And then also, of course, we know the growing need for kinship caregivers. These are, grandparents or other kin, because of parents of children for one reason or another can't take care of their children. And so these folks are stepping in as loving family members to try to take care of children, but they really do need some help when it comes to being able to enable child care for the children that they're caring for. So just to look to the bill, you can see that on the first section of the bill is looking at these 2 programs and requesting that New Hampshire and its 4 HCBS waiver programs, these are folks disabled and older adults served by Choices for Independence program, individuals with certain brain disorders served by the Acquired Brain Disorder, ABD, developmentally disabled people served by the Developmental Disabilities Waiver, or DD, and children with developmental disabilities, significant medical behavior challenges in the in-home support waiver. So what this part of the bill will do is ask the Commissioner of Health and Human Services to be able to contact CMS and be able to include family caregiver support under those specific programs. And you see described then in section 3, or what that they will create these caregiver support services, might include counseling, education, training, peer support, caregiver assessment, or other supports consistent with the purposes of the section. So we have broad discretion in our waiver program to address the needs of the waiver's target population. I will note that 26 other states are already doing this, so there's a good model out there that really works, and so this would be a chance for New Hampshire to join in this as well. The next part of the bill deals with child care support for kinship caregivers, and if you'll turn onto the second page here, you see the essential changes there, what will be offered. And I'll note here too that the Federal Child Care Development Block Grant allows the state to exempt kinship caregivers over retirement age from child care scholarship work requirements. So you'll see there on the second page, section 3, under Q, where it says, the things that we now recognize as exemptions from the work requirements, adding to that to include retirement for individuals reach retirement age as defined by Social Security Administration. So let's say you've been retired for a while, suddenly you're taking care of the grandkids. Guess what? You're going to go back to work. I don't think so. But let's notice as well that we do extend this already in a couple of programs that we do this for SNAP and for Medicare already at the age requirement. So I think this makes a whole lot of sense with that as well. And then the second part here is related to the child care scholarship cost share. Let me note that up above in that section there that, the federal government is providing half the funding for that. And then so too in this new subparagraph 4, the elimination of the child care scholarship cost share for children in kinship care. If they are in the care of a child caretaker relative, then there would be this adjustment to the child care scholarship cost, and a little provision there relating to the fact that you might have, some family members who wouldn't appropriately qualify under this, but then there's some children for whom that would. One other small piece of the bill, if I go up to the back to the top of page 2, there to offer training for child care providers so that they can have evidence-based trauma-informed care, good training to have, and at no cost to the provider. I would like to call your attention to the amendment that you have, 0089, and this is important to add a contingency there so that you'll see that in sections 3 and 4, here's a contingency provision that they'll take effect when HHS can certify that CMS is good with these changes. And so that is important to have that contingency there, and that affects the effective dates for parts of the bill as well. Mr. Chairman, let me close by saying that I am extremely appreciative in working with the advocates. We're going to hear from New Futures and from people who are in these roles, how much of an education it has given to me in understanding how things can work, but it also has really reinforced, in my mind, what terrific work HHS is doing, and all kinds of providers around the state and family members as well. God bless them. So thank you, Mr. Chairman.
Thank you very much. Is there any? Senator Avard.
Thank you, and thank you, Senator, for bringing forth the bill. You said there was matching funds from the feds on this, on the
Yeah,
childcare?
let me just specify, let me find my little thing here. Again, there it is in my notes. Yeah, the federal government provides half of the funding in these programs.
Thank you.
So we don't have a fiscal note yet, as I'm aware of, so I think that, that can be worked out, but I don't think these are budget breakers. I really do not in these changes here.
Great. Thank you. Are there any other questions for the senator? Thank you very much. All right. So I'm going to call the Department of Health and Human Services up because I think we've got some questions. I do see, Brian, I've got your name down here twice, and I've got you once with Karen and once with Wendy. So I don't know if you all want to come up together or, okay. All right, perfect.
Hi. My name is Wendy Altman. I'm the Bureau Chief for the Bureau of Adult and Aging Services.
Brian Clark, I'm General Counsel for the Bureau of Adult and Aging Services.
And I We see this bill as two parts, and the administration for our home and community-based service waivers is the piece that I'll speak to, and then I'll switch out with our Director of Division of Economic Stability to speak to the child care piece. Part 1 of the Bill 608 directs the department to seek federal approval to include family caregiver support and services as it's allowable under the Choices for Independence waiver program and the acquired brain disorder home and community-based services waivers. And this section of the bill, as stated before, doesn't create an immediate or automatic new benefit for individuals. It gives us the authority and the ability to create those guardrails when we renew our home and community-based service waivers to add those services. It establishes a structured process that requires the department to seek that approval from CMS, implement any of those approved services through any necessary rulemaking, and would define the eligibility criteria, the caps on any spending as it relates to those services, what those provider qualifications need to be, as well as any of those service limits and safeguards that are required when we add services to our CMS waivers. This is also consistent with the department's draft to implement what would be phased in, as well as noting that it's contingent upon CMS approval, which would, Senator Waters had mentioned related to the effective date in the amendment. And this bill also identifies some of the examples of caregiver support services. So we've outlined that as part of the fiscal note worksheet in our process for identifying what the costs may be. These supports are intended to assist caregivers of CFI or acquired brain disorder waiver participants and sustain the care that helps them stay in a home and community-based setting. From a systems perspective, family caregivers are already providing a significant share of that support that allows individuals to remain at home. So some of these targeted caregiver supports may help reduce the caregiver strain, prevent avoidable crises, and support the continuity of care for those who are participating in the waiver. And I think that the bill also helps with providing those guardrails around the controlled framework that is needed to allow for caregiver supports. And as stated before, there are many other states who implement this as part of their Medicaid home and community-based service waivers. So we looked at several of those states that have implemented that. We looked at their utilization of those different services and supports as compared to the total population that participates in those waivers. So we have a sense of what that utilization might be within both of those waivers to estimate, what the impact may be as it relates to that for people here in New Hampshire.
Senator Abard.
Hate to be a pest.
No.
So thank you very much for your testimony. So in layman's terms, this allows individuals, it might be family members, to be able to stay home and take care of a family member and not really be financially burdened by it, but be able to stay home with them and not have a financial burden on top of that. Am I understanding that correctly?
What we see when we are providing either caregiver supports and services outside of a Medicaid waiver, but even within the Medicaid waiver, it would allow for those caregivers to get counseling, additional training for some of the hands-on care they may be providing, and an ability to get respite and education and have, peers and access to supports in order for them to, especially when they're looking at making some of those decisions about how long can I do this, And can I get any relief? It's really to target the ability to create a space for providing that for caregivers so they can continue to be on the waiver and not need institutional level of care.
Yes, and one follow-up. And thank you. And so there is probably a fiscal note along with this, but in the long term, there must be a cost benefit as well.
Well, I think that when we looked at what the other states had for utilization and the types of services they were offering within their waiver, it's helpful to know that as part of the waiver, we can get that federal match to provide those services. And when you're looking at folks who, family caregivers who may be in that decision spot to determine whether or not they can continue to do this at home, it is going to be a cost benefit to the state in order to keep them at home longer.
Would county as also be a benefit?
Yeah, in terms of how our waivers are funded, the CFI waiver, sure, it's the county and general funds are both part of that mix.
Thank you.
And when do we anticipate a fiscal note?
So a fiscal note was submitted, but the LBA hasn't finalized it. So we expect it to be done soon.
All right, thank you. Very good. Thank you very
All right.
much.
I'll ask Karen to come up to
Yes,
speak to
Karen.
the other piece.
Good afternoon again. Karen Hebert, Division of Economic Stability for DHHS.
Brian Clark, counsel for the Division of Economic Stability.
So the scholarship program, as we've talked about, does provide a subsidy for families who have less than 85% state median income. And it does require them to participate in a work activity. So the proposed legislation would require that the child care program include retirement as a work activity so that individuals or caregivers, relatives who are taking care of young children could qualify for the scholarship program. The proposed legislation is subject to approval of the federal government for the Administration for Children and Families. We would like to be able to see an amendment to the bill that would state that, just to ensure that we do get approval from the federal government to allow that. Otherwise, it does put the funding stream, the federal funding stream at risk, which is approximately $16 million per fiscal year. Also, adding retirement as a qualifying activity for childcare will cost $298,000 to make system changes in the eligibility system, and about $20,000 for the cost of the staff that maintain and would be making those changes in the system. It also requires, the bill also requires that the cost share for this that families would pay would be eliminated. And this actually would result in very little fiscal impact. At this time, the average cost share is about $105. And the number of children receiving the respective benefit in childcare is currently 4.
Senator asked $4 or $400
Oh, for children.
for children. All right, thank you.
Anything else?
No, that's it.
All right, thank you. Are there any questions of the committee? Thank you very much.
Thank you.
So we're gonna, now our departments have spoken, our elected officials have spoken. We're gonna open this up to the public, according to the list here. I'm not gonna limit this discussion, but we do have a lot of people on the list. So I would ask that you keep your comments brief If you're coming up here and reading testimony, you don't need to read testimony, just leave it with us, we'll get it. You can summarize your testimony, and if someone has made a point already, I would ask that you'd skip over that point. We've got a busy rest of the day here, and I want to make sure everybody gets a chance to talk. So with that, Jeffrey Santer.
Honorable Chair and members of the Health and Human Service Committee, I do have written testimony, but if you'd rather, I keep it
You can
brief.
give us the bullet points and leave that testimony. She'll make copies for us.
Sure.
All right, very good.
Okay. So I'm 65, I'm retired. I am raising my grandson, who I have guardianship over. It's very challenging, not just the cost of childcare, but finding good childcare, holding on to it. There's a lot of options at this stage of my life that I don't have, like dropping my grandson off at my parents like I did before. And, you know, when I heard about this bill, I was pretty excited that, if nothing more, our group that I'm a representative of is getting recognized. And I would just urge you to support this bill. And if you have any questions for me, I'd be happy to answer them.
Thank you very much. Are there any questions from the committee? Thank you very much.
You're welcome.
Susan Labrie.
Hello, my name is Susan Labrie. Thank you for the opportunity to speak on SB 608 and to explain how profoundly this bill affects my families and other families. March 24th, 2022, our 5-month-old great nephew came to live with us, TJ. He's now 4 years old. 10 months after TJ started daycare, we received a letter from the state telling us that they would no longer pay for his daycare unless my husband or I worked, volunteered, did job search, something. I'm 78 years old. My husband's 79 years old. Working was not an option. My husband's not well, very ill. So we were able to obtain a doctor's note for my husband stating that he could stay home. That left me. I enrolled in college. That was a disaster. It was a nightmare. Try enrolling in college at 78 years old, believe me. Okay, so because I did, the state said, oh, okay, we'll pay $113 a week. They were paying $325. So we picked up the other $212. Okay, barriers kept coming. They wanted my husband's military records from 1971, despite I proved he had an honorable discharge. They wanted transcripts from the 3 high schools I attended in 1960. That was really interesting. We still don't have them all. Okay, unfortunately, I did not pass my courses. So now we're going to have to pick up the whole $325 a week out of our 401k. We have no choice. He's been in daycare. I'm not pulling him out. He's thriving in daycare. He's doing excellent. And he wouldn't understand how all of a sudden he's gone, his friends are gone, everything's missing. He just wouldn't. There is, however, 2 things I would like to leave you with. Cutting this real short. Okay, for people who say to us all the time how lucky that little boy is, I tell them, no, we're the lucky ones to have this little boy. His curiosity, his laughters, his love. Every day, I love you, Auntie. I love you, Uncle. Every single day we hear this. The gifts are beyond measure. The second one is, when Rick and I retired, we had a bucket list. Okay? TJ came to live with us. Bucket list gone. Now we have a new bucket list. And on that bucket list, TJ. That's all that's on it. That's it. You can read it. Any questions?
Thank you very much. Are there any
I know I
questions
look
of the
wonderful
committee?
for 78. Thank you.
Good job. Thank you.
Okay. That was my redacted version.
Roger DeRozier.
Good afternoon. My name is Roger DeRozier, and I'm from Concord, New Hampshire. I'm here today to testify not just on behalf of myself, but also AARP, New Hampshire. We are here today in strong support of Senate Bill 608. The bill is essential for strengthening family caregiver support and providing child care assistance for kinship caregivers in New Hampshire. And I'll make this brief and go to my own personal experience, as this testimony has been submitted. My wife and I were caregivers for my dad for approximately 18 years, beginning in 2001. At that time, caregivers did not have resources for meeting the needs of family members. We were challenged with working full-time and trying to meet my dad's needs for multiple medical appointments, management of heart medications, in-home medical testing, transportation, and later his Alzheimer's disease. Our own needs for caregiver support services were not available or very expensive. In addition, resources for managing his medical care was inadequate or not available. So that, in essence, is my testimony today. Thank you for your time and consideration.
Thank you very much. Are there any questions? Thank you. Deb Cronin.
Good afternoon. It's such an honor for me to have the privilege to share the experience of caregivers supporting people living with dementia. My name is Deb Croner. I'm the founder and owner of Monarch Care Partners, a dementia consulting service. I have educated, supported, and journeyed along with caregivers who are supporting people living with dementia. My understanding of the plights of a caregiver is both personal as well as professional. My training and expertise comes from an international program called Positive Approach to Care. Their mission is to educate, empower, and support caregivers and people living with dementia. Our motto is, until there's a cure, there's care. For the next few minutes, or maybe two, who knows, I will be summarizing about the complex experience of caregivers for people living with dementia and how Senate Bill 608 can help them. There are three primary ways that I would like to illustrate that. First, Senate Bill 608 could address the social isolation and ambiguous grief that caregivers of people living with dementia experience. Medicaid waiver programs could provide peer support programs and counseling. Two, Senate Bill 608 could make sure that caregivers have the necessary education regarding dementia as well as skill building to help the caregivers cope with the brain changes that happen with dementia. Senate Bill 608 gives us the opportunity to keep our caregivers supported, healthy, and safe. I'm hopeful that Senate Bill 608 is passed because caregivers of people living with dementia are on a very difficult journey. Thank you for your consideration, and I'm available for questions.
Thank you. Are there any questions of the committee? Thank you very much.
Thanks.
Let's see, Anne Marie Serene.
Does that work? Oh, there we go. Wonderful.
Thank you very much for letting me talk today. My name is Anne-Marie Sarine. I'm from Dover. I'm a licensed clinical social worker and the director for the Referral Education Assistance and Prevention Program, otherwise known as REAP, in the state of New Hampshire, which supports older adults and their caregivers across the state. And I'm here in support of Senate Bill 608. REAP provides short-term counseling, education, and support addressing mental health, substance use, and cognitive concerns. So I've been a licensed clinical social worker for 21 years in the Seacoast, in the inpatient, outpatient, and over the last 6 years, community settings. And I've seen how inadequate support harms families, emotionally, physically, socially, and financially. A lot of them experience depression, chronic stress, and increased risk of alcohol and medication misuse. So I don't have my fiscal year 25 data yet. In my fiscal year 24 data, 50% of our care partners that we supported reported moderate to severe depression. 29% reported suicidal ideation in the last 2 weeks. And 25% screen positive for at-risk drinking. And that number starts to move around a little bit depending on gender. So if it's a male care partner, those numbers tend to go up versus a female care partner. We talked a little bit about some of the supports, and I've worked in a hospital for over 10 years. We worked as part of a team. We got training, we got pay, we got raises, we got vacations. We had a difficult patient, someone would step in and take care of everything for us. If I was sick, I could call in, someone would cover for me. There was still a lot of burnout, but we are asking our care partners to do the exact same thing, and only 11% get training. In fact, when I work with care partners now, I'll ask them, what information have you received? And majority of the time, they say nothing. It's really hard to do a job when you don't even know what your skills are that you need to bring to the table. And you never get a break from that. So this bill would start to really impact that. And what I see in my practice and in my counselors when they're working with individuals, if we just give them a little bit of information, we connect them to a little bit of support, the impact is significant. Those numbers start to go down, and it doesn't take very long. The other piece that you talked a little bit about cost benefit. So again, worked in the emergency department for a long time. When care partners get that support, when they get that education and the training, they're less likely to show up in the emergency department. Hospital stays are shorter. The likelihood that they can put off putting their individual into an institution is delayed, if that is what they choose to do. Usually when I saw people in the emergency department and we had that crisis at 4 o'clock in the afternoon, like what's gonna happen with this person, it wasn't because of the person receiving care, it was because the care partner had hit their limit. They couldn't do any more. In fact, I had when I was at Jarrow Psych, I had a family come in because their mom had passed away. They realized that mom had been caring for dad who had dementia. Mom wasn't taking care of herself because there was no respite. There were 6 kids, lived all across the country. They show up and, they didn't know what was going on with dad. And if they had known, they would have made sure mom had got the resources. But because she was caring for him, she didn't take care of herself. So she showed up in the emergency department and she passed away within a couple days. She had stage 4 lung cancer. So that happens over and over and over again, where people are putting their needs aside in order to care for their loved one. So the last point I'd like to make is, again, I've worked in the Seacoast for a very long time. I've seen this trend happening and the data supports it. So in 1970, we had 31 available care partners for every person needing care. In 2010, we had 7 to 1. By 2030, we expect 4 to 1. I can tell you in every role that I have been in, our entire system is built on the backs of care partners. If I'm discharging someone, it's because it's a care partner. If I'm working with someone through the REAP program, we're working with a care partner. We need to protect our care partners. Our system will not function without them. So thank you very much. If you have any questions, please let me know.
Are there any questions of the committee? Thank you very much. Amanda Carter.
Hi, how are you today? So it's hard to not cover the comments that have already been done. My name is Amanda Carter. I'm a kinship navigator at the River Center Peterborough, sorry, the River Center Family and Community Resource Center in Peterborough, New Hampshire. I have the privilege of working with kinship caregivers every day. I just had one crying on my couch in the office this morning because I was able, through the kinship navigation program, to help pay for her granddaughter's trip to Washington. That was really important for me. So I have the privilege of working with kinship caregivers every day. Grandparents, aunts, uncles, and other relative and non-relative caregivers who step up for children and loved ones when it matters most. These caregivers are doing something truly extraordinary. They open their homes, adjust their lives, and keep families together, often with very little notice. SB 608 is important because it recognizes and supports the people who are already doing this work. When caregivers feel supported, families are stronger, people are able to stay at home in their communities surrounded by the people who know and love them. That's good for families, and it's also a smart investment for the state because supporting caregivers costs far less than responding to a crisis later. Kinship caregivers are financially already juggling a lot, paying for haircuts, buying new clothes when kids grow, grocery shopping to ensure that they have enough food to fill their always hungry bellies. Eliminating the child care cost share helps ease one of those burdens so that they can focus on what we can all agree is most important, keeping kids feeling safe, loved, and cared for. What I appreciate most about this bill is that it focuses on prevention and support. It helps families early before stress turns into a crisis. It builds on what families are already doing well and gives them the tools they need to keep going. As a kinship navigator, I can tell you that policies like this have a real impact. SB 608 strengthens families, keeps children connected to the people they love, and supports the caregivers who are stepping up every day. One of the examples that I wanted to give is I have a kinship grandmother who is caring for 2 grandchildren. One granddaughter is, she has a lot of mental health challenges, but she's also helping to care for her husband who has Alzheimer's dementia. When she went for help, they told her that he has to become physically violent before they can help her. That's awful. But with the right training, she would have been able to know and have the tools to know that there's more resources than just wait till he hits you. Thank you.
Thank you.
Thank you. Are there any questions? Thank you very much. Megan Braybeck.
Good afternoon, members of the committee. My name is Megan Braybeck. I'm here with Save the Children Action Network, and I live in Newmarket, New Hampshire. I will keep my statements very brief because you've heard some fantastic first-person experiences about what it is for grandparents to take care of their grandchildren. We're in support of this bill. We really think it's important for kids whose families value it, want to be able to access early education and build that social emotional skills, all the things they need to do well when they do eventually start school. So even if the grandparents are able to be home, access to that preschool is really, really important. And this is such a huge door opening for those families. So we are in support. I'm happy to answer any questions.
Thank you. Are there any questions? Thank you very much. Lily Wellington.
Good afternoon, Chair and members of the committee. My name is Lily Wellington. I am the Executive Director for the State's Commission on Aging. So I will keep this very brief, and there's a handout that you will receive with some salient data points. But one of the things I wanted to share is the context for why this is a somewhat urgent conversation. When we think about the demographics of the state, I'm sure you are well aware that we are the second oldest median age when we look at states in the country. But I want to draw your attention to what that actually means when we look down the road to 2030, which is really not that far away. As somebody previously testified, we have a ratio of caregivers to folks who are over the age of 80. And when you look at the way the population, the trajectory of the population, we have an increasing number of individuals over 80 in the state. So the highest percentage of population growth when you look at 65 to 85 plus is in that 80 plus sector. When you think about the demands for care, they will increase as somebody is over the age of 80. So the ratio is really important to think about. In 2010, we had 7 caregivers for every individual over the age of 80. And in 2030, which is scary to think about, isn't really that far away, we're going to have 4. And so the number of population is going to increase, the needs will increase, and our ability to take care of folks naturally within our families or our friends, we will have less of a pool of those caregivers. So preserving what we have is really pennies on the dollar when we think about planning for where we're going to be as a state. So, thank you.
Thank you. Any questions? Thank you very much.
Thank you.
Judith Jones and Trina Engelfinger. It's been a long day.
Good afternoon. My name is Judith Jones, and I'm here on behalf of New Futures and the New Hampshire Alliance for Healthy Aging. And I'm Trina Engelfinger, also here on behalf of New Futures as its Early Care and Education Policy Director. And we will keep this very brief. There's nothing we could say that hasn't already been touched upon. I just want to point out that a system where retired caregivers have to go back to work or enroll in school, no matter their age, in order to qualify for the scholarship program is really untenable. This bill offers a quick fix. And in fact, the Child Care Scholarship is the only subsidy program in New Hampshire that doesn't have an age cap on its work requirement. I think that's an oversight. And one that we can easily fix through this bill. And happy to take questions, but I'll pass it on to Judith. With regard to the waiver program, you've heard that this bill would add support services to caregivers so that if they need support, counseling, education, peer support, they could get it. And it provides wide latitude to the department in how that's designed. This bill looks at a broad table of caregivers, and the message from the bill is that we want to keep caregivers caregiving. And in order to do that, we have to sustain the caregivers. The numbers show that 280,000 people in New Hampshire right now are caregivers, and they're dedicating roughly $208 billion annually. And the goal of the bill is, can we give a little bit to sustain the caregivers to keep them going?
Great, thank you. Are there any questions? Thank you very much. Catherine Dickey.
Good afternoon. I'm Kathy Dickey, and my husband and I are from Bow. My husband isn't here today because he's home taking care of 2 sick grandchildren. But I am speaking in support of SB 608. My husband and I are raising 4 grandchildren. They are 9, 6, 4, and 3. Our 9-year-old came to live with us when he was 10 months old. We were still working full-time then. And when we planned our retirement, he was part of our retirement, so we planned financially accordingly because we thought we would just have Emmett with us. We retired in 2018. I was a nurse for over 40 years, and John worked in insurance. I'm sorry, I'm a crier. I just can't help it, sorry. 5 years into our retirement, in February of 2023, DCYF brought our 3 younger grandchildren to us. At that time, they were 3, 2, and 5 months. They were all in diapers. The baby was still being bottle fed and up at night needing feedings. To say we were overwhelmed is an understatement. We certainly had the love for the children, but as a retired couple on a fixed income, we didn't know how we would give these precious children everything they needed: formula, diapers, food, clothes, and daycare. Fortunately, DCYF could cover the cost of daycares because they have legal custody of the children. And that was life-changing for us. The children have thrived. They've learned social skills. They've learned how to interact with other children. They have received speech therapy. They received occupational therapy. And they've gained a confidence in themselves that they didn't have. And it's just been a joy to see them blossom. Believe me, it takes a village to raise 4 grandchildren, and daycare is a big part of our village. The children's parents have lost their parental rights, so John and I are moving forward to gain legal custody of them, as we have of our oldest grandson. When we get legal custody, DCYF can no longer pay for daycare for us because they're our responsibility now. So John and I looked into any financial support we could get for daycare and discovered we're not eligible because we don't work. John will be 74 in March, and I'll be 71 in May. And in order to keep our grandchildren in daycare, we'd have to rejoin the workforce, which really isn't feasible for us right now. This bill would enable our grandchildren to stay in early education programs and continue to thrive. We are doing the very best we can, parenting the second time around, to provide our grandchildren with every opportunity to continue to develop their social and emotional skills and to build a foundation for them to become healthy and happy and successful adults. So I thank you for your consideration. I urge you to support this bill to help other families like ours. And we all thank you. I do, John, Emmett, Bella, Joshie, and TJ. Thank you.
Thank
There's
you.
a picture of our beautiful grandchildren here for you.
They are beautiful. Thank you.
Do you have any-
Hopefully they feel better.
Yes.
Are there any questions? No, thank you very much.
Thank you.
So that's all I have on the sign-up sheet to speak on 608. Is there anyone else that would like to speak on Senate Bill 608? And with that, I'll close the hearing.
All right.
You started yet?
Waiting for you.
Open the hearing on Senate Bill 615 relative to the use and regulation of EBD cards and SNAP eligibility. I'll ask Senator Sullivan to introduce her bill.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Senator Victoria Sullivan. I represent Senate District 18, which is Manchester wards 5 through 9 and the little town of Litchfield. SNAP stands for Supplemental Nutritional Assistance Program. The authorizing legislation states the program is intended to alleviate hunger and malnutrition by permitting low-income households to obtain a more nutritious diet through normal channels of trade. The program was first introduced in 1964 as a way to help supplement the nutritional needs of families. However, SNAP benefits are currently being used in some cases to purchase items with zero nutritional value, like soda and candy. When these benefits were being drafted, the House of Representatives version of the bill excluded these non-nutritional items, but the argument was made that families who relied on assistance would not waste them on such items, so the wording was not adopted. Today, we know that's not the case. According to the National Library of Medicine, the soda industry receives billions of dollars per year from taxpayer-funded SNAP benefits. A study from USDA indicated the #1 product purchased by SNAP benefits is sweetened beverages, comprising nearly 10% of SNAP benefits, and about 3/4 of all sugary drinks purchased with SNAP households were purchased using SNAP benefits versus out-of-pocket. Nearly 20% of all SNAP reimbursements. Now remember, this is supposed to be a nutritional supplementation. Nearly 20% of all SNAP reimbursements go to sugary drinks and junk food combined. Another USDA study also revealed that SNAP recipients compared to other low-income non-participants in the program drank more sugar-sweetened beverages and were more likely to be obese. Obesity prevalence among SNAP recipients was 40% versus 32% among low-income non-participants. According to the National Library of Medicine, sugar-sweetened beverages are a significant contributor to the obesity crisis. Per capita, calorie intake from caloric soda consumption quadrupled for American adults since 1965. Low-income American adults now consume nearly 2 sweetened beverage servings a day. For every 1 to 2 daily servings combined, the lifetime risk of developing diabetes increased by 30%. When Congress created the original program, severe undernutrition was a common problem for families living in poverty. The obesity rate stood at only 13.4%, but the obesity rate has soared, reaching 40.2%. If current trends in childhood obesity continue, more than 57% of today's children will be obese by age 35. In 2023 to 24, children in the lowest income group had the highest rates of obesity at 23.5%. In 2017, Dr. Ludwig, an advocate for improved nutrition at Boston Children's Hospital, said, and I quote, "We have more evidence for the harms of sugary beverages than for any other category of food, and yet it tops the list of reimbursed products in SNAP. No one is suggesting poor people can't choose what they want to eat, but we're saying let's not use government benefits to pay for foods that are demonstrably going to undermine public health," end quote. The cost to our system and subsequently the cost impacted by these health risks is far greater than the cost of implementing these guidelines. I have already faced some arguments against the bill. The soda industry will tell you that they have made great efforts to make soda healthier by removing sugar. However, multiple studies have shown that drinking diet soda regularly is linked to increased metabolic issues like type 2 diabetes, heart problems, weight gain, gut disruptions, and dental erosion. The bottom line is that there is no nutritional value in soda or candy. Most of us understand that there are folks in need. No one wants to see a child ever go hungry, but these benefits are better used for items that provide nutritional value. Let's look at the cost of soda versus water products that these same soda companies sell. At Walmart, a 12-pack of 12-ounce Cokes goes for $8.42. A 32-pack of 16.9-ounce bottles of Dasani goes for $6.47. A 12-pack of 12-ounce Pepsi is sold at $8.72, while a 32-pack of 16.9-ounce bottles of Aquafina is $6.98. Other states have started implementing similar criteria for SNAP. The point of sale systems are already updated regularly based on sale items, added or discontinued items. This is not a heavy lift for stores to implement. This would not go into effect until 2027, which provides grocers ample time to adjust to the changes. However, it's my firm belief that if New Hampshire joins the other 18 states that are implementing these changes, the federal government will join us, which alleviates much of the concerns that will be brought forth. Opponents have stated this denies children cake on their birthday. Nothing in this bill changes any regulation on purchasing a cake mix or the ingredients used to make a cake. The New Hampshire Democratic Party put out a graphic stating that this bill would deny parents the right to send candy into schools with their children for birthday parties. Well, in 2012, Michelle Obama created the new healthy food guidelines for schools, which did not allow for candy, baked goods, soda, or junk food at schools. Public schools across the country had to remove vending machines and cancel bake sales. There was no outcry from folks about this overreach at that time. That being said, this bill does nothing to put that kind of regulation in place. What this bill does not do is tell people what they can and cannot buy with their own money. It does put parameters on taxpayer-funded benefit whose intention is to provide nutritional supplementation. It will prohibit items that not only provide zero nutritional value, but contribute to significant health issues and reduce the quality of life. Opponents have framed this as an attempt to harm our most vulnerable. Nothing could be further from the truth. SB 615 actually strengthens SNAP in three key areas. One, by protecting the state budget from changes in federal law that are instituting new penalties for high SNAP payment error rates. Two, by ensuring benefits go to the truly needy granite staters first. And three, by ensuring that SNAP helps families buy real food with nutritional value. It is also a safeguard for our taxpayers. Beginning in 2028, states with SNAP error rates above 6% will have to cover the portion of the benefit costs. New Hampshire's most recent error rate was at about 7.5%. At that rate, it will cost the state nearly $8 million annually. But with even a slight increase in that error rate, the penalties double. Although these federal changes don't go into effect until 2028, the clock is ticking because it's based on this year's error rate. The steps we take now will determine the cost to New Hampshire taxpayers. SB 615 helps lower the error rate, which will in turn help New Hampshire to avoid those penalties. It protects those in need while also protecting the taxpayer, which ultimately protects the longevity of the program. SNAP is a supplemental nutrition assistance program designed to provide nutrition to American families in need. In its current form, we are not delivering nutrition, but delivering illness and disease. Let's instead work to provide our most vulnerable families, especially our children, with better nutritional choices so they may have healthier, happier, and longer lives, while also protecting the integrity of the program for families with the most need. Thank you.
Thank you, Senator. Are there any questions from the committee? Senator Prentice.
Thank you, and thank you, Senator Sullivan, for taking my question. So I want to talk about the point of sale, the retailers. So a couple of things, and I'll try to move this pretty quickly. Number one, have you talked to the grocers in this state to get an idea? Because we have small grocery stores, mom and pops, we have co-ops, and then we have large chains. And you said the point at, now maybe I didn't hear this correctly, a point of sale has already been updated, but there's at least one letter that we received so far, a concern about this, you know, that it could cost $1.6 billion up front. Like there could be upfront costs to these grocery stores to implement these changes across the entire, across the entire country. So let's just talk about the retailers first. Like, where are they in the conversation?
Thank you for the question, Senator. Yeah, so I did speak with the Grocers Association, but there are guidelines that are being set forth right now from different organizations to help with the point of sale changes because it's happening already in 18 other states. But point of sale is changed. You know, you probably get the same flyers that I do every week that say what the sale items are at the grocery store. And so they're changing point of sale items every single week for sales. They change the point of sale system when they delete an item or when they introduce a new item to the store. So these aren't systems that are stagnant. They change them all the time. And there may be people in the room with experience with this that could speak to it better than I. But from the research that I did do, because I did speak with the Grocers Association and the states that have already started implementing it, they haven't had any issues like this or a cost that they're saying that they expect to incur. It just hasn't happened.
Oh, thank you very much. So thank you. So it hasn't happened, but I mean, do we know what the cost will be on the grocery side, on the retail side, and how that downward pressure might impact? Like, you know, I'm a taxpayer, but I'm also a shopper. And right now I can't even buy a thing of, what is it? I like to bake chocolate chip cookies. But the price on one bag that used to cost me $2.59 is now, over $5. So it's gotten into my baking. Sorry, I'm just going to say. So I'm curious because there will be costs for the retailers to implement systems, whether small or large. Do we know what that downward pressure will be on the other side? Have other states, I think you started to get there, but just to clarify, had experience with this?
I think there may be people in the room that have dealt with those issues with other states. It's my understanding from talking to several people involved in this that they did have a seamless transition. They're not seeing the costs that people are anticipating. And, to be honest, the cost, this isn't supposed to be a program that benefits the grocers overall, and we never make changes to it. It's supposed to be a program that provides families with nutritional assistance and supplementation. There are already restrictions on this program. So when someone goes to bring something in that isn't on the program, that isn't already qualified for a SNAP purchase, the machine doesn't let it happen. They can't do it. So all they would have to go in is tweak that system. And I was online looking at some of these associations that help grocers with this, and they've outlined exactly how to do it. On those websites with those instructions, there was nothing about, this is going to be a crazy cost to you. It's going to be catastrophic. There was nothing like that. It seemed like it was a very easy thing for the system to be able to do. And these are people that basically own the point of sale systems that train people on how to use it.
Can I wrap up?
You can wrap up.
Thank you, Senator Sullivan. And I understand that, in the way that it's written in the fiscal note, well, I don't think we have an updated fiscal note yet. It's really focused on the state side. But the retailers, I know, I hear what you're saying about that, but ultimately we all go to the supermarket. So I am just trying to assess based on, the information that I have so far, that other side. So thank you very much. And as you know, I'm a proponent all along of, public health. So I understand what you're saying. I just want to explore this other piece.
Thank you, Senator. But I would reiterate on the other side of that, if we don't comply and we don't make changes here, we're facing an $8 million cost to the state because of the way that we're currently running the program and the error rate that we currently have. So I think that's more of what we should be looking at, because that is something that's absolutely coming home to roost if we don't make changes.
Thank you, Senator. I just want to comment, for the public, I don't want anything to get in the way of Senator Prentice and her baking, because her fellow senators generally benefit from that. So we want to make sure that's addressed. Senator Avard.
Thank you, and thank you for bringing this bill up, Senator. Just a question, on top of the $8 million a year, what are the health costs, whether nationally or even locally? What are we looking at, when we have children on that are diabetic, that are overweight, that are depressed, a host of other issues that go with the high sugar? What is if you have any numbers on that cost on top of the $8 million a year?
Right, so I think it's somewhere around 70% of the people that are on staff are also on like Medicaid or Medicare. So those costs are definitely handed down to the taxpayers that are paying for those benefits as well. And like I said, we're looking at these numbers, they're staggering for the health of our children. Obesity rates should never be like this for our kids. And as I stated, they're higher with kids whose families use SNAP than families of the same income bracket that aren't on the benefit. So there's, that's just showing that this is producing negative results that we don't want to have for kids. And there are so many other options that they could have, like seltzers and sugar drinks that don't have the sugar content in it that are much healthier for them. And I broke down the cost change, right? You can get 12 cans of soda for more money than 32 bottles of water. Right? So I think when it comes to our kids' health, you can't really put a price tag on that. I think we need to really look at the data that's here and change the system.
Thank you, Senator.
Thank you.
Any further questions? Thank you very much. So we have 2 pages of speakers lined up, so that's a pretty significant number of people. I am going to limit future comments. The senator has the privilege of speaking because it's her bill, but going forward, we're going to set a timer for 3 minutes. And just to make sure you get the most out of your time, if you've brought written statements, rather than read the written statement, just give it to our aide here and she'll get that to us and summarize your statement. Again, if something has been said already, don't repeat it. We want to make sure you maximize your time here. So we appreciate that. Christine Arsnow.
Good afternoon, committee. Thanks for hearing my testimony today. My name is Dr. Christine Arsnow. I am a board-certified pediatrician, and I'm also board-certified in obesity medicine. I oppose Senate Bill 615. I do agree with the author of the bill that whole foods should be prioritized for kids. However, restricting access to food for low-income children is not the way to do this. On the surface, this bill may seem reasonable. As I said, I encourage my families to eat fruits, vegetables, meats. However, this bill will have unintended consequences that would ultimately harm children by restricting families' access to SNAP. First of all, restrictions on allowable foods raise serious concerns about stigma for families. Senator Prentice mentioned her chocolate chips. I know my family, everyone has some M&Ms in the evening. That's kind of what we do for dessert. If you can imagine that if a family is purchasing their regular groceries, checking out, and something that they hadn't thought of as an unhealthy option stops the line, that feels shameful, that feels embarrassing, and that experience will lead a family to decline use of their SNAP in the future because of that stigma. There's such a gray area between what is healthy and unhealthy. Diet soda would be a great no calories, but it has lots of chemicals. Where does that fall? To make these determinations in a black and white is not a practical way to do this. Instead, we need to rely on educating families, supporting families, and trusting them to make the right decisions for their children. I also have heard I'm I am a partner at a private practice, so I'm not a grocer, but I am a small business owner. And I think that these things that seem like they may not be a big deal on the surface, when you have a small grocery store, a small, as you know, Senator Prentice mentioned, the mom and pop grocery store that maybe doesn't have those flyers with sales all the time, the things that will be felt are, you know, a lot more impactfully are those having to go through all of the new products and figure out if they fall into the healthy or the unhealthy bucket and where it, and as a result, many of those grocers may just stop accepting SNAP or EBT altogether, which would be a detriment to the children of our state. I'll close by repeating my sort of central statement, which is that anything that makes it harder for low-income kids to have access to food is a bad idea. And for these reasons, I urge you to oppose Senate Bill 615. Thank you.
Any questions? Nothing? Thank you very much.
Thank you.
Elsie Cipriani and Heidi Johnson.
Good afternoon, members of the Health and Human Services Committee. I'm Heidi Johnson. I'm the coordinator for the SNAP Outreach and Application Assistance Program at the New Hampshire Food Bank. Elsie Cipriani, our executive director, had to leave due to the time restraints. As the only food bank in our state, and as a 40-year program of Catholic Charities of New Hampshire, and as a Feeding America partner, we distributed 20 million pounds of food in 2025 through more than 400 partner agencies. Yet we still fell short of the need for food. According to the Feeding America's 2025 Map the Meal Gap, 1 in 9 Granite Staters, that's 1 in 7 of our children, are food insecure. I'd just like to point out that food insecurity is an official term used by the USDA. It's the limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. And I do want to say that we are against Senate Bill 615. This past November, when we served as a SNAP contingency plan for the state during the federal government shutdown, me and my team, we interacted with hundreds of individuals who were experiencing food insecurity. These are parents who were cutting back on their meals to feed their children. These are parents who were going out on DoorDash, taking up DoorDash just to get food on the table that night, not knowing where they were going to pay for the gas and the wear on their car tomorrow. The New Hampshire Food Bank uses nutrition programs as a means to help people move away from food insecurity. Not only do we help people apply for SNAP benefits and learn about SNAP benefits, but we teach our neighbors how to cook and eat meals, healthy meals, on a budget. We support food pantries in expanding nutritious options and purchasing locally grown foods. We provide thousands of healthy meals to children over the summer. We provide SNAP incentives, which doubles SNAP dollars for produce. So you can see that we are deeply committed to delivering healthy, nutritious meals for our neighbors who are experiencing food insecurity. However, we believe that Senate Bill 615's proposed restrictions would actually do more to harm than to help. As folks have already mentioned, bans alone on soda and candy yield mixed results, and they ignore the systemic barriers and can reduce participation. And this is an issue for business communities, for those small retailers throughout the North Country, Manchester, Nashua. You'll be hearing more about that today, no doubt. In addition, Senate Bill 615 would roll back the gross income limit from the current state-elected option of 200% of the federal poverty level to the federally required minimum of 130%. Rolling back the gross income.
And that was your 3-minute timer.
Okay, thank you.
Yeah, and if you've got written testimony, please leave it, and Sophie will make sure we get it to it. She gets it to us. Thank you. Karen and Brian, I'm sorry I missed you. I generally should have called you sooner, and I missed it. I'd like to have you guys come up and talk to us.
Do we each get 3 minutes?
I'm sorry, I
Do we
can't.
each get 3 minutes?
use your time wisely. That's all I'll say.
It's fine. Karen Heber, Director of the Division of Economic Stability.
Brian Clark, Counsel for the Division of Economic Stability. So we're here to testify about the impact on the department on Senate Bill 615 and what it would require. So SNAP is a supplemental nutrition assistance program. It's federally funded, state administered. So if the proposed legislation were enacted, we would be seeking what is called a healthy choice waiver from the Federal Nutrition Service, that is the federal agency that administers SNAP, to prohibit soda and candy from being purchased in New Hampshire with SNAP benefits. There would be substantial cost to our EBT vendor that we contract with. So apologies that a fiscal note hasn't been included yet unless one just went around. We did submit a fiscal note worksheet, and a fiscal note from the LBA should be on its way. In the first year of the healthy choice waiver, we would expect an increase of about 1.4 million. And that's largely, a big portion of that is to make the system changes that are necessary to implement the healthy choice waiver. And then ongoing costs would be providing support to retailers on how to implement, which would be about $540,000 in subsequent years, and which could decrease as time went on. Senator Sullivan mentioned that federal adoption of the soda and candy restriction would alleviate a lot of concerns. And regarding costs, that is true. We agree. If the federal government were going to adopt a soda and candy restriction, the costs would not fall on New Hampshire. The proposed legislation also makes some changes to the SNAP work requirements. So SNAP has work requirements for able-bodied adults without dependents, which are known as ABODs. ABODs have to meet a minimum work requirement. And if they don't, they can get up to 3 months of SNAP benefits, and then they would lose eligibility. So it does a couple things. In regards to the ABOD work requirements, it eliminates our discretionary exemptions, which is to say FNS gives us the ability to exempt at our discretion a limited amount of ABODs. New Hampshire does not regularly use our discretionary exemptions, and often it's used in times where we need additional time or training to get messaging across. So, for example, at the end of the public health emergency,
I'm going to defer that to Brian, if that's all right, so he can continue.
So, for example, at the end of the public health emergency, ABOD requirements had been suspended, but we needed additional time to get the messaging out to say, you need to report these work hours to us. And so we used our limited discretionary exemption in that one instance to give us more time, and that reduced potential error rates, which would, if we're able to use it in that manner in the future, it could reduce our error rates, which would lower potential future liabilities. Also, the ABOD requirements, it would prohibit us from using unemployment to make geographic waivers. We don't currently have a waiver. However, we have in the past had small carve-outs of new areas of New Hampshire with high unemployment where the ABOD requirements wouldn't apply. Notably, the proposed legislation does say these requirements are not allowed unless we receive legislative approval, but it doesn't define what legislative approval is. So it might be helpful to define that if it's going to a Health and Human Services Oversight Committee versus going to the full House and Senate. Additionally, it would repeal categorical eligibility for SNAP, which would lower the gross income test from 200% of the federal poverty guidelines to 130% of the federal poverty guidelines, which could impact about 7,000 families and approximately 15,000 individuals.
If I can just add on to that particular item, so the categorical eligibility, if that were to be eliminated, another impact that it certainly would have is on a program that's called the Nutritional Supplemental Food Program for Working Families. There are 873 individuals who receive this particular benefit. It is a financial benefit, a small amount, but those particular individuals would be impacted, which will impact our ability to meet TANF maintenance of effort, because those are general funds that are applied to TANF MOE. And it'll also put us at risk for fiscal penalty because we have to meet a particular work participation rate, and these individuals help the state meet that particular rate. I'm more than happy to provide more detail about this in writing for you.
Yeah, I was going to ask you that. If you can, I mean, we're hearing a lot of numbers come around here, and I would ask that you give that to us.
Yeah, there's a lot of content for this bill,
Yeah.
and we'd be happy to provide that in writing.
I've got some other questions too, unless you guys have more to say.
I have a couple more points.
Sure, go ahead.
So there are a couple data sharing cross-match requirements in the proposed legislation. Some of them are new and some of them are duplicative. So for example, corrections, new hires, earned income, vital records, we already do that. So there wouldn't be any changes there. Although if there were a federal requirement change, it could create a conflict between federal law and state law.
And that was Department of Corrections. What else?
New hire database,
Okay.
earned income, and vital records. I can provide a full comprehensive list in writing as well. It also required us to use the SAVE system, which is the Systematic Alien Verification for Entitlements. And the proposed legislation requires us to use it to verify citizenship and immigration status, and it's not used for verifying citizenship, and that's not a thing it would be able to do. We currently verify citizenship through birth certificate or naturalization papers. The SAVE system was specifically made for verifying alien eligibility for entitlements, thus the name. Additionally, the proposed legislation requires us to check monthly the SAVE system for each SNAP household, which would be a huge burden. Generally, we check at application and redetermination. And checking monthly alien eligibility status, immigration law doesn't move that quickly. So we haven't experienced a need to check it monthly. It would also create a lottery cross match. We don't currently have one, but one could be built. I would say that the number in the lottery cross match in the proposed legislation is $3,000, and it should instead just refer to the resource limit, which gets updated annually. That way there never becomes a conflict. And there were also some.
And that resource limit that's a federal.
Yeah, it's determined by federal rules. So currently the resource limit for households with a disabled or elderly household member is $4,500. And that is the amount of lottery winnings that would affect SNAP eligibility. So it doesn't really make sense to have a cross match to find out if someone won less than that.
Okay.
There are also a couple requirements in there that we're just not sure what they would be useful for. A cross match with the HUD, Housing and Urban Development. We're not sure what information would be helpful to determining SNAP eligibility. And there are a couple departments named that we weren't sure what they were. The Department of Economic Stability. Don't know what that is.
Okay.
There would also be a new system to check out-of-state purchases, where if a SNAP household purchased food exclusively out of state for 2 months, we would consider the residency of that household questionable and send a request for verification. And then if there wasn't a response, we would send a notice of denial.
So you're already doing?
So we don't automatically do it. We don't have a system to do it. We do get that information and we do review it. And there is nuance to our review that couldn't be done by an automated system. So for example, if someone lived on a border town and they did their grocery shopping in Massachusetts and they lived, near Massachusetts, we wouldn't consider that questionable. Also, sometimes people with disabilities will have rep payees. If the rep payee lives in Vermont, buys their groceries in Vermont and drives them to them in New Hampshire, we wouldn't consider that questionable either. And if we built an automated system, it wouldn't really be feasible to take into account that nuance.
Okay. I can see why we don't have a fiscal note yet. Very good. Thank you. I have a question for you.
Okay.
So, and you hit all of these things that I was, I've highlighted in preparation for this, but one of the questions that I have is I know there's been a lot of changes in SNAP and there's been a lot of, some changes in eligibility and work, there's been some stuff, let's just say it's been top down from Washington to here. And I think if you look at this bill, starting on line 17 of page 1 and go to the end, which is the stuff that you were just going through right now, what would be helpful to me is to, and you just did it, you summarized it verbally, get in writing, what are the things that are called out in the bill versus what are we doing now and what is mandated from the feds. I want to identify areas that we're doing now anyway. I want to identify things that maybe that deviate from federal guidelines, just to get a really better understanding on where this is. I mean, it's only a 3-page bill, but there's a lot in this. So that would be very helpful.
We can do that.
For that.
Not a problem.
Very good. Thank you. And then I know we talked about the, all the stuff that you summarized some of the stuff. I think there's probably even more. But what are we talking about as far as administrative staff changes to administer this? I mean, we talked about another program a couple hearings ago. It'd be 9 FTEs. Do we have any sense of what it would cost to administer this?
So we expected the additional requirements to everything taken as is to be about 5 FTEs.
Okay. And then, of course, the error rate. I mean, I think every one of us at this table has either been to a legislative conference or gotten updates from legislative conferences over the last several months. And the error rate is something that's really pressing, that where I think there's a lot of anxiety about error rate. And in talking to Henry, I know we're slightly higher than what we have to be. We're far better off than many states are, but we have some improvement to do there. I guess the question I have was, would this implementation improve our error rate, or could it find things that, would show that our error rate isn't as good as we think it is?
Possibly. Sorry.
Yeah.
So I think that there are a number of influencing factors that affect the error rate. The errors that happen are, in large part clerical, due to manual steps that are taken by staff or information even sometimes provided by the client. So the more manual work there is to do or reviews, the more risk I think we have at about seeing errors. So while New Hampshire is below the national average for errors, we certainly are at risk for the financial impact that could be coming in 2027. So I would want to be sure that if we're looking at impacts with respect to any type of policy change, that is a significant issue that we want to make sure that if there are going to be changes that will create manual work or there isn't an appropriate appropriation for system changes that could be made, then we do look at the potential for more risk of increasing the error rate, which we don't want to do. So there are concerns for that, but I think that it's tough to carve out which pieces of this may have more of an impact on the error rate than others.
Sure.
But we can do our best to try to
Yeah,
to
as
zero
much
in
as
on
you can
that.
do, that would be very, very helpful. I would appreciate that. I had another question, but it's been a long day and it escaped me, so I'll probably follow up with you, when it comes to me.
Yep.
Or if you're still here, I'll call you back.
That's fine, yeah.
All right, thank you.
Okay.
Any questions from the committee? Senator Avern.
Thank you. So is there any level of fraud in this system?
Is there any level of fraud?
In the system, have you uncovered any fraud in our SNAP system at all?
So I think, and I can get you specific numbers, perhaps in the last fiscal year, of the number of referrals that have gone to our special investigations unit, unless there's somebody here that could speak to that. I don't know.
Francesca Hennessy, you want to come answer that question?
Come on up.
Good afternoon. I'm the Fraud, Waste, and Abuse Administrator at DHHS. And so one of my units is the Special Investigations Unit, which investigates recipient fraud in all the programs that we administer. So I did bring some statistics for you in terms of the fraud we investigate and the outcomes for the past year. But I guess I want to know more specifically what you're looking for. Just SNAP cases?
Well, anything that this bill would affect, in this particular area of SNAP, yes. Is there fraud? Has there been fraud uncovered? Does this bill address fraud in any way, and would it reduce fraud?
The issue that I see here is that this focuses more on retailer fraud, which would be the retailer selling something that they shouldn't, and that's not something that our unit looks into. That's something the federal government looks into, and they investigate those. And we have an OIG, and we've referred cases to them. So I couldn't give you statistics on that because that's more of a federal benchmark. I can give you statistics on sort of the recipient SNAP fraud, but because this law isn't in effect yet, I don't know what the, yes, go ahead.
Yeah,
Give us what you got.
Yeah.
Okay,
Yeah.
thank you. So for total SNAP claims, just last year, we established around $286,000. For total claims in all our programs, it was about $319,000. And that would be for all overpayments, all intentional cases that went to court that were proved to be fraudulent. Some other numbers I have for you, and for just SNAP disqualifications. So where we disqualify people for a year, for 10 years, depending on the number of times they've affected the program. We've had a total of 28 disqualifications last year, but the claims associated with that were $174,000. I could break it down even further in terms of SNAP, simply SNAP claims cases in terms of money if you want to know there. But I gave you an overview of total amount of money and then disqualifications, where we tell people they are no longer eligible for the program because they have committed fraud. Thank you.
And just a reminder, what's the annual SNAP budget in New Hampshire?
That would be a director question, not able to answer that.
I do not know off the top of my head either.
If you have it, Karen, if not, you can.
So I'll have to look that up for you specifically because we're an integrated eligibility system. I would have to have somebody help break that down with respect to just SNAP alone.
Okay. If you can get that to me.
I can get that for you, yes.
Put it on the to-do list, right?
Yeah,
Thank
exactly.
you. Are there any other questions for the committee? Senator Prentice.
Thank you, Senator Rochford. And you already asked this in part, like what the department already does versus what they don't do that are in some of these eligibility checks. But I just wanted to circle back. I think, Brian, it was just something you said for each one of these, or maybe it wasn't all of them. Did you reference what 0.5 FTE or that amount of hours would be needed to get those checks done? Or did I have that wrong?
So the full-time equivalence was an estimate based on the entire increase to workload on looking at all the new checks we would have to do.
Yeah.
I think the bulk of it is the system, the save. Looking at it monthly would be a lot of a workload increase for the field staff.
I remembered my last question. So this bill, the work that DHHS would have to do on this, assuming it was passed in its present form today, would that workload impede on the workload that DHHS has to do to roll out the Go North Rural Health Transformation Grant?
But that is an excellent question. So I would say no. We've really dedicated very specific resources, including, with the partnerships with our stakeholders and other state partners to really focus on the initiatives for the rural health transformation. And there is more information about that specifically on our website. I can give you a link to that if you'd like. But I don't think that the programs, the eligibility programs such as SNAP would be impacted by those particular initiatives.
Great, thank you very much. Are there any further questions for the department? No, very good. Thank you very much.
Thank you.
Sharu Koda.
Good afternoon, and thank you for this opportunity to be here and talking to you guys. My name is Sharu Koda. I am a junior at Bedford High School, and I'm here today because I'm worried about what this bill would do to our community at Bedford, and I'm asking you to vote against this bill. Usually, people think of Bedford as an affluent town where nobody really struggles, but that is not the reality. Right now, nearly 500 people live below the poverty line. We have around 300 people relying on SNAP just to keep food in the fridge, and 160 people at my school who rely on free and reduced price meals. I see the impact of these programs every day. For a lot of my peers, school lunch isn't just a break in the day, it's their most reliable meal. When you're sitting in class and trying to focus on a math test or an essay, you can't do that if your stomach is growling. I've seen friends who look relieved when they get to the front of the lunch line because they know they are finally going to eat. If you pass SB 615, you aren't just changing a policy. You're making it harder for those same kids to qualify for school meals. You're essentially taking the food off their desks and out of their backpacks. With the cost of housing and groceries going up so fast, this bill feels like it's punishing families who are already doing their best to stay afloat. It also makes things unnecessarily complicated for our local grocery stores, who might just stop accepting SNAP altogether if the rules get too confusing. That hurts our local economy and makes it even harder for families to find food. SB 615 doesn't solve the problem of food insecurity. It just adds more stress and more hurdles for people who are already struggling. We should be looking for ways to help our citizens, not making it harder for them to survive. So I urge you to vote in opposition to SB 615. Thank you for listening to a student's perspective.
Thank you, Sharu. Is there any questions?
I do.
All right, Senator.
Thank you. Sure. Thank you very much for the courage of standing. It's hard to sit there. I hate it.
Thank you.
With regard to the bill, you made a statement that this is going to be taking food away from individuals. Can you show me where in this bill that it says that?
I just think that extra restrictions on this bill that could potentially hurt the way that some families put food on the table, which could definitely affect how kids at school, if they even have food to bring to school, or if they can even buy food at school, or essentially there could be some times where kids don't have anything to eat through the entire day. And personally, when I'm at school and I'm hungry and I don't have a snack on me, I find it very hard to focus. So just knowing that some kids don't have any food at all to eat when they're at school, and that they have to go through like 6 hours of sitting in class, taking tests, taking notes, doing assignments, things like that, it would be very hard for them to focus, which could definitely affect things like their grades, their engagement in class, or even like their health overall.
Thank you.
Any other questions? Thank you have you been sitting here all day?
No, I got here at 1.
So you got to get some school in today, right?
Yeah, I did. Don't
All
worry.
right. How many classes did you miss?
Just 1.
All right, I want you to tell your teacher whose class you missed that you did excellent today, and that you should get a free pass and full credit. I just thank you. So you did very well, and you even took a hard question from Senator Avard here. So thank you for coming in. You did great.
Thank you guys for your time.
Amanda Carter. Oh, I missed Kevin D. Good. I missed one. We'll go back after.
Good afternoon again. Good afternoon again. My name is Amanda Carter. I'm here to oppose Senate Bill 615. I spend the majority of my days helping people apply for SNAP. Good people, working parents who are already juggling multiple jobs, caregivers supporting disabled family members, seniors choosing between food and medication, people who are trying not trying to game the system, but simply trying to survive within it. I help them gather documents, chase down verifications, navigate portals that don't work. We call it New Hampshire complicated. And comply with requirements that are already confusing, time-consuming, and stressful. From that vantage point, from inside the system, I can say with confidence, SNAP is not too loose. It's already stretched to the breaking point. DHHS is underfunded and overworked. Tier 1 call centers have been outsourced, so families seeking help may not even reach someone in the same time zone. That matters. It matters when someone's confused, scared, and facing a deadline that could mean losing food. It erodes trust in the system and creates inconsistent guidance. And now, instead of addressing those structural failures, this bill proposes to add more rules, more scrutiny, more investigations, and more paperwork. This bill is built on a fundamental misunderstanding of how poverty and crisis actually work. Families don't experience hardship neatly or predictably. They survive in fragments. They lean on temporary help, borrowed stability, and whatever resources they can access in the moment. When my son was a toddler, he was critically ill and inpatient at the ICU at Shriners Burn Hospital in Boston. We did not have the luxury of planning ahead or budgeting. We shopped for food that was within walking distance of the hospital because that was the only realistic option. The hospital could cover 1 meal per day for 1 parent, not 2. We relied on SNAP to afford small snacks so we can supplement that single meal that we split, me and my husband. Under this bill, that reality, buying small amounts of food while living near a hospital during a medical crisis, could be treated as suspicious behavior. Ending categorical eligibility, increasing verification requirements, and policing grocery purchases will not reduce fraud in any meaningful way. What it will do is push eligible families off assistance due to paperwork errors, missed notices, or confusion. It will increase administrative costs, it will further overwhelm DHHS staff who are already drowning in caseloads, and it will create gaps where children, seniors, and disabled adults go hungry while the state congratulates itself on being tough. Fraud prevention does not look like this. This is cruelty disguised as oversight. I ask you to look closely at what SB 15 actually does in practice, not what it claims to do on paper. Ask who it burdens, who it excludes, and who it harms. Accountability should protect people, not punish them for surviving. Please vote no on SB 615.
Thank you. Are there any questions? Thank you very much.
Thank you.
Kevin Daigle.
Good afternoon, Mr. Chairman, members of the committee. For the record, my name is Kevin Daigle, President of the New Hampshire Grocers Association. For those of you not familiar with us, we represent both chain and independent grocery stores and convenience stores, all of whom operate on razor-thin margins. I passed out some testimony, and I'll try to keep my comments brief. I know you guys have had a long day. We appear here today in opposition. Our concerns with this bill focus on the costly compliance burdens for retailers, reduced food access, and the impact on cross-border sales. It's nothing to do with specific products in general. With these restrictions, retailers will be forced to overhaul systems for New Hampshire alone, with costly software changes, compliance upgrades, and employee retraining, with costs estimated in the thousands of dollars just for compliance. This is challenging for all, but even more so for the small independent grocer. This compliance is not a one-time issue. In fact, each time there's a new product introduced, repackaging, reformulation, this has to be all done again, introduced, deemed whether it's eligible, ineligible, good, bad. Time, man-hours just to do that. With these compliance burdens, retailers will have to decide if they're going to invest the time and money for compliance, just simply stop accepting SNAP. In those cases, with limited options, food deserts are going to appear, with recipients having to travel greater distances to find a retailer that accepts SNAP. A SNAP restriction also threatens sales. A New Hampshire resident who's having their benefit restricted here in the state can take that benefit card, go to a neighboring state, buy those same restricted items, and use their New Hampshire benefits for that. On the flip side, an out-of-state resident can buy specific products in their home state but not here. Why cross the border? When that happens, New Hampshire loses more than grocery sales. It loses the ripple effect of economic activity that follows. That's kind of the summary of my testimony, but I know Senator Sullivan brought up a couple of points, and I had Senator Prentice, you had a question, so I want to kind of address those as well. Senator Sullivan talked about obesity rate. This bill does nothing to measure health or obesity rates, whether prior to or after. So there's no measurement or gauge as to how healthy somebody would be or the obesity percentage. Starts in 2028. That's great. As of right now, there are no definitions that define what these products are. Just for giggles, I'm one of those that goes to the grocery store with my wife. I'm always hangry when we do it. Need to get out of there, but our shopping cart is filled to the hilt, right? We spend more than we have to. And I always grab something off the candy aisle. I'm going to ask you all a question. Looking at 3 items on that shelf, M&M's, Snickers, and Twix. Which one of those 3 is not a candy? Twix. It's made with flour. So dependent upon the definition of what candy is, everybody's rational brain is going to say Twix is a candy bar. It's not.
Yeah, I'm going to interrupt you here because you're out of time. So my turn to ask a question. One of the things that I've heard, and I've had a lot of people in my office talking about this, and I tend to be more on the healthy eating side. But I see some of the concerns. One of the concerns that you haven't been in my office, but other people have, but it's going to be a burden for software. And I've worked in my professional life, dealt with POS systems. I remember when the health savings account, the flex cards, we had to go back and reprogram everything. And it was a challenge initially. But as we went on, it was just a matter of business. So I'm assuming your members have also had to do that for other things like a health savings account, flex spending, things like that. So I guess the point is, does your software have the capability to do this? And I'm getting ahead of myself because you're right, there's not a definition yet. There hasn't been a defined what's a soft drink, what's candy, yada, yada, yada. But if we could just address that software.
So our discussions, a great question. In our discussions with our members, both large and small, for the small guy, They may have a very antiquated system if they have a system at all.
Okay.
So that's going to be man hours. A lot of times those are the man hours done by the owner. On the larger scale, there's no broad category in your POS system that just says magically click everything that's candy or everything that's soda.
Right.
And it doesn't. So now they have to go through, in a supermarket's case, you're looking at 10, 15, 20,000 different types of items. Now we have to categorically go through each and every single item to deem whether it's eligible or ineligible. So
it's more of a manpower, mostly a
It's
manpower issue,
correct.
you know, the larger
Yeah, I mean, the
outfits.
systems are set up now that you could go in there and check good, bad.
Sure. Yeah. Okay. So I imagine, and I'm thinking out loud here, and maybe I'm way ahead of myself, you know, if we do this, you've got DHHS makes their definition, they give you a SKU. For your folks that have a more sophisticated software, you can just download the SKUs in and be done with it. But the smaller outfits may not have that capability.
Well, where is that list coming from? There's no list now.
There's no list now. No, I'm saying, you know,
I don't think they have.
you know, they won't even be tasked with writing a list until this bill passes, and then they get the marching orders to go define that.
So if I could play off of that.
Yeah.
So January 1st, 2026, the first 5 states in the country that were granted the waivers actually had their implementation date start. USDA gave a 90-day grace period. So within 90 days to get your systems compliant before we start, you know, tacking on the penalties. The penalties, as I understand it, is 2 strikes, you're out, meaning they'll involuntarily take your license from you. And speaking to my counterparts in 3 of those 5 states, they're being told by some of their larger companies they're not going to be compliant on that 91st day. And it's not by choice, it's they can't get there. As much as we think we've got a long runway to get there, 2028 will be here before we know it. Definitions may or may not be ready. What are those products within that category? So you're going to be seeing similar instances as those initial states are seeing.
Sure. And I would like to hear from them, you know, the states that are doing this now, who are, as of January 1, I'd like to hear what their stories are, you know, their war stories, and see where the hiccups are, and just to better understand that. So, and Senator Abart has a question.
Yeah, thank you. So if we don't do anything, we've got an error rate that we have to deal with, and there's already an $8 million price tag on that.
Right.
If our error rate goes up, that goes exponentially. You did mention the fact that if we did implement this, people would cross the border. Of course, that means their error rate would skyrocket because they would get flagged by that. So my question is, do we do nothing and just take it on the chin? Or is this a vehicle that we should move forward with and wait for the data to come in to find out what is acceptable and what isn't? Because I fear doing nothing is not a good option.
And I'm counter to that. I say you do nothing. I understand that as by doing nothing means you're not going to implement restrictions and bans, correct? A lot of my understanding, and the folks at DHS can explain that better, most of the error rate is coming from the administrative portion of that. It's not coming from the retailers or the actual recipient. It's coming from the way they're inputting, receiving information, and documenting those information. It's not my transaction as a retailer. So I don't think you'll see any impact or very little in regards to the error rate. But I agree, the error rate is cause for concern.
Yeah, the error rate definitely, it is causing a little bit of concern. And I see in an analysis, if I may follow you, that, you know, it's a restriction of candy and soft drinks. You know, diabetes, overweightness is a serious issue. And we banned cigarettes, right? When I was 16, you were allowed to smoke cigarettes. They banned that because smoking in the boys' room wasn't a good idea, right? But, you know, when I look at sugar, there's some really serious long-term consequences with sugar. And by addressing some of those issues and maybe try to on the federal level, it seems as though they're trying to get people to actually use it for nutrition rather than things that are going to cause more medical problems with our society. Again, is that something we just don't do?
I think a restriction like this needs to come at the federal level.
But isn't that already in place with the big beautiful bill?
To restrict soda, sugar, processed foods? No. That's why it's being downshifted here. And again, our concern isn't so much product specific. It's and it's not so much has changed either. It's we have independent retailers who have stores in New Hampshire and Vermont, New Hampshire and Maine, New Hampshire and Massachusetts. If Vermont were to ban, let's say, processed foods and soda, and we ban soda and snack foods, but our definition of soda is different than their definition of soda, you've got a patchwork of ordinances that we're trying to comply with. So something like that needs to come from a federal level, not state by state.
Thank you.
You're welcome.
Are there any further questions? Senator Prentice.
Thank you, Chair Rochefort, and thank you for taking my question.
Definitely.
You kind of sort of led into it a little bit at the beginning because I had asked the bill sponsor, Senator Sullivan, about costs associated with the implementation and how they're say absorbed, and will they be passed? Is there any evidence that says they'll be passed on to the other people in the grocery store?
There will.
And Senator Sullivan's response was helpful, but I wanted to hear from her.
I had your comments here, but I hit my 3-minute mark. That was a great question. Thank you. Definitely costs will be downshifted to the consumer. Folks are working on anywhere from a 3 to 6% profit margin. We have recently been tasked from the tobacco liquor enforcement with mandated tobacco reporting on retailers. It is causing, and it's none of your cause or concern before your committee, but it's causing our folks at minimum 45 hours a month to go through their inventories and provide this information. That's something that's wasn't in the cost of those goods.
Okay.
We can't absorb that because it's man hours. The same with this, whether it's having your stock personnel go through the thousands of items in a larger grocery store, or it's a smaller local store where the owner, or he's going to task a manager to go through the items they have, there's going to be time allotted to that. And for him to do that, he's going to have to be laser focused on it. You're going to have somebody else in place. In some cases, some folks don't have a POS system. They have little stickers on the cans or the boxes. They may need to actually spend money and get something like this. So definitely these costs will be downshifted to the consumer.
And just quick follow-up. I know, but there's experience in the other states that have done this to evidence to back, I'm not doubting you. I just want to be able to link it to.
Yeah, I know that their implementation started 13, 14 days ago. So
Okay.
yeah, let me see what they've got for information. I can get that out to all of you.
That's helpful. Thank you.
Any other questions? Senator Long.
Thank you, Mr. Chairman. Yeah, just quickly, I just want to make sure I'm clear. You mentioned the possibility of retailers not administering to SNAP. Is that what you said?
Correct.
Okay, that it would be easier just not to.
If there are some that have told us that for them to go through and start trying to figure out which products are and aren't, and if I'm not compliant when they audit me, I'm going to have my license revoked or my ability to sell or accept SNAP revoked. I'm just not going to go through it. It's just going to take too much time and effort. And sadly, those places are in places that have very few resources already.
Senator Avard, yes.
All right, thank you. So, all right, we know you're not for this, but you did bring up another problem when it comes to compliance and the error rate. It's administrative. All right, what's your suggestion?
I passed my 3 minutes.
No. The chair can give you more time.
Sidebar.
All right, we'll let you go. Thank you very much. Megan Brayback.
Good afternoon again. I am still Megan Brayback with Save the Children Action Network. I live in Newmarket. I will keep this brief and not read my remarks, but we are opposed to this bill. I hope you all are familiar with, Save the Children's reputation. Globally, we are obviously very strongly in support of child nutrition and healthy food access for children. But this bill, while it aims to improve SNAP, in our view, it would actually make it harder for kids and family to access the food that they need due to provisions in there like stricter work requirements, eliminating categorical eligibility, and limiting DHHS discretion. These types of these aspects of the bill would make it really hard for vulnerable children to avoid hunger, especially kids who are in families facing temporary hardships. So things like illness, caregiving responsibilities, unexpected job loss. DHHS would lose their discretion in those situations. And so in our view, this bill it's not the step you want to take if you're trying to improve child nutrition. If that's your goal, there are tons of other programs that we could be supporting, enhancing. Myself and my friends at New Hampshire Hunger Solutions would be happy to talk to you about those other measures that would improve nutritional outcomes for kids in our state. So I will leave the rest of the remarks with you, but if you have questions.
Any questions from the committee? No, thank you very much.
Thank you.
Sam Hawkins.
Good afternoon. For the record, my name is Sam Hawkins. I'm here today representing NAMI New Hampshire in opposition to Senate Bill 615. I'm sure we are all aware and recognize food security as an essential social determinant of health. I'm here today to share that also extends to individuals' mental health. Research by the USDA has found that adults living with a mental health disability are up to 5 times more likely to live in a household that is food insecure. With this in mind, programs such as SNAP can help foster and support quality mental health, as additional research shows that SNAP benefits can significantly decrease psychological distress among participating households. In turn, we believe that this improved mental health can help those people continue in their recovery and address the factors that contribute to their poor mental health or their needs to be on the assistance program. As such, simply put, we stand in opposition to these policies that would limit access to assistance programs such as SNAP. We firmly believe that our policies should promote access and dignity for families in need of support so they can get well, stay well, and thrive. As such, we urge the committee to recommend inexpedient to legislate for Senate Bill 615. Happy to try and answer any questions, but I would defer more technical questions about the program to folks who have much more expertise behind me.
Thank you very much. Any questions? Oh,
Thanks so
thank
much.
you. Victoria Gullah.
Okay. Hi, Victoria Gullah from Spofford, New Hampshire, and I knew I was going to be next because on the couple of times I've come to testify, Senator Avard has always walked out of the room. I'm not kidding. So I am here to support this bill, and it's really sad to see the people who are not supporting the bill, especially the physician certified in obesity medicine. She should really be embarrassed for herself. I can make it a lot easier for you all. Carbohydrates are not essential elements in nutrition. If you eliminated carbohydrates completely and focused on what makes people healthy, which are meat, dairy, and seafood, you would then have a healthy population. It's quite simple. So I don't think this bill goes far enough on the elimination side of things. We need to protect taxpayers, and we also need to protect the people who are eating toxic poisons every day and getting sick. I get sick when I walk through Market Basket and I see the nasty piles of just garbage piled up there and people buying this. Your heart goes out to them. You see these people who are so sick, they're using the carts to get through compression stockings. People, it's not just, the fraud is one thing. And if you look at EBT of TikTok, you'll see people are proud of buying junk food and they show it for all the world to see. It's really heartbreaking to see the cost of the physical debilitation of these people and in schools. What are the costs? What's the Medicaid budget here in New Hampshire? Do you guys ever wrestle over that? Is that something the Senate ever looks at? Probably. It's one of the biggest chunks of the New Hampshire budget. What are the cost of prisons? Did you know that by people who have done a carnivore diet or an animal-based diet, and that's eliminating things like seed oils like canola and soy and all of the grains and carbohydrates out of their diet, they have not only healed metabolic diseases like diabetes, they also heal mental health illness, bipolar, schizophrenia. How much does that cost the state of New Hampshire? Not just in money, but in the human toll. How sad is it to see all of these homeless people? Yes, you can get psychosis from cannabis, so please don't vote for that either. But the mental health of these people actually gets reversed on a carnivore diet. And the cost in school of kids, my kids do ski racing, and the coaches always say to parents, please, no sugary snacks, because the kids fall apart, especially the young ones. What's it doing to the kids in school? What's it doing to the kids? Like, my kids don't get the sugary snacks. They're disrupting my kids' class. How many kids have ADHD? How many kids have special services? How many schools have to have different counselors? I never had aides in the classroom. So these are the costs. I understand that. These are the costs. I'm sorry for the Grocery Association, but, are they complaining about having to teach people how to card, for buying alcohol or cigarettes? It is a huge cost.
All right, thank you. Are there any questions? I just want to make a comment that the carnivore diet does dramatically change mental health and
Which
mental
one?
acuity. The carnivore diet.
Yes, it does.
You're absolutely right on that. So thank you for sharing that.
And just think about all the people with mental illness, what the cost is, the down cost on their children. What's it like to grow up in a house with someone with mental illness? What does that do to them? What does that do to them in the classroom? How does that affect the other kids in the classroom? How does that affect the teachers,
I
the
think
aides?
You're on to something
It's
there.
massive.
But this bill, it's a big bill. It's not focused on that per se, but I think, keep up the good work.
And think about expanding it, carbohydrates.
All right, thank you.
Thank you.
Peter Brennan. Good to see you again, sir.
Absolutely, Mr. Chair. Good afternoon. Chairman, through you to the committee, my name is Peter Brennan. I'm the Executive Director of the New England Convenience Store and Energy Marketers Association. We represent the 9,000 convenience stores throughout New England, about 1,000 here in New Hampshire. And in New Hampshire, I would say 85% of all convenience stores are located within 20 miles of the border. Now, why that's important? Because you can use an EBT card in any state. We know that we have a lot of people from Massachusetts that come to New Hampshire for their fresh, free air, for their taxes, for the products that you can't buy in Massachusetts. There are currently 75,000 people on SNAP benefits in New Hampshire. There are 1.1 million in Massachusetts. There are 66,000 in Vermont, 170,000 in Maine, a total of almost 1.4 million on the bordering states. So if those SNAP recipients are used to, say, going across the border to buy a delicious package bottle of New Hampshire maple syrup, they'll now be prohibited from doing so. This is, as Kevin explained earlier, it's an enormous burden to our retailers. It's an enormous cost. It's also going to be a net loss for the state if fewer people now travel across border to do their shopping because of these restrictions. If we get down to the logistics of, okay, what products are banned, how do we determine that? One of the other states, Oklahoma, that had sought a waiver to delay. I believe they go live in February. They recently put together a list of 18,000 products that are now going to be prohibited. The state of New Hampshire would have to do something similar to see what complies with this law if it's changed at all throughout the process. When I look at the products in our shelves, I couldn't tell you what is going to be allowed and what isn't. There are some maybe obvious examples, and then like a Twix bar, there's some really less obvious ones. There are now chips with protein in them. There is a flavored seltzer water a soda? Is it different than just a unflavored soda water? I don't know. So this is going to be kind of an enormous undertaking for all parties involved. There will be a big cost to our retailers. And if people aren't traveling across the border to purchase those items, then, or maybe they're traveling from New Hampshire to Massachusetts to make their purchases, our retailers don't just miss out on the sale of those prohibited items anymore. They miss out on the whole basket of goods, because if you can't get the product you're looking for at the store you usually go to, you go somewhere else. We see that all the time, especially in northern Massachusetts, where people very easily go across the border to New Hampshire, especially in, say, eastern Vermont, where they do the same thing, western Maine. So you're looking at fewer products that we can sell to a fewer, smaller group of people. Enormous burden on our retailers to comply with with this new law. And if you think about the rural areas that are sometimes served by only a general store, as Mr. Daigle mentioned, 2 strikes and you're out. If you lose eligibility in the SNAP,
I'm going to ask you to wrap it up. Or,
this is my last point. But so if a store that acts as kind of the town grocery store all of a sudden loses SNAP eligibility because they just can't comply with this vast new categorization of products that are eligible, ineligible, they get visited twice, they get their warning, they have a second one, they're out of the program. And then the people that are only buying, say, nutritional products as their regular grocery shopping, the milk, the eggs, they need to find somewhere else to go. And a lot of times in rural areas, that's impossible. So there are a lot of complications with this bill. We oppose Senate 615, and I'd be happy to take any questions.
Let me ask you this. Would your testimony change if instead of banning certain foods, we said your SNAP dollars are worth more to buy certain types of other foods?
So, I mean, is that a possibility? I don't even know.
I don't know.
I don't know either. I mean, I think it's better.
I'm having discussions with
I think it's certainly better than banning products,
now.
so we would certainly look more favorable upon that.
I mean,
approach.
we talk about the burden of complying, but what if the shoe was on the other foot and it's actually more advantageous for you to take SNAP than less advantageous?
I think that would still be a point of sale nightmare, but it's certainly, if you're talking about not banning products from the program, it would seem to be more beneficial to our retailers.
Thank you.
Thank you.
Carrie Duran.
Did you say Cary Grant?
No, that was last week.
Oh, that wasn't it?
Yes.
Good afternoon. Thank you so much for the opportunity to be here today. Thank you, Chairman Rochefort and the committee. My name is Carrie Duran. I'm from Wolfboro, New Hampshire, and I'm the legislative liaison for Lakes Region Community Services. We provide services with those with developmental and intellectual disabilities. But I'm in front of you today as a mom. And I just wanted to, there's been so much covered today, and there were 2 items that I just wanted to share with you. One that the department mentioned that was a nuance about going across the state lines with your EBT card. I'm a single mom of 3. I have a daughter with significant health issues. She was born with Down syndrome. We spent a lot of our time over the last decade in Boston, going to Boston Children's Hospital and Mass General Hospital. And many times as a single mom, when I'd make these appointments, I had to decide, how much money do I have to spend on lunch? How much money do I have to spend on gas to get to these appointments? And many times I had to take my available money to spend on gas, and then I would use the EBT card to get lunch for my family while we were down in Boston. And that would happen quite often. So I just wanted you to take that in consideration for the out-of-state purchases. I did that many times, and it wasn't by choice, it was out of necessity. So I just wanted you to consider that. The other, and I'll put my glasses on here to read, I just wanted to bring to your attention a potential unintended consequences is line 23. The grant categorically shall not give categorical eligibility under this for households. Many families like mine that are a single parent, low income household with a child with a developmental disability are burdened with paperwork, administrative paperwork. I have to actually sometimes take days off of work to go to appointments to make sure I'm gathering all the right paperwork that is needed. I'm happy to do it, of course. I appreciate the benefits that that help me care best for my daughter. But to categorically deny a household SNAP benefits under this section of the bill, it might be a definite food, taking away these benefits would take away security for families and their food benefit. And just, I'm not a subject matter expert on this. I just saw it and I was like, oh my goodness, that might affect some of our families who have children with developmental disabilities and adult caregivers who are taking care of their adult children with developmental disabilities. So perhaps more needs to be looked into it. I'm not sure of all the parameters, but I just, as a mom, wanted to bring it up just in case it was an unintended consequence to this bill. And right on time. Wow. I'm happy to take any questions.
Are there any questions from the committee? No, thank you very much.
Thank you so much. Have a great day.
You too. Let's see, Judith Jones.
Now we get to say good morning, good afternoon, and good evening. So I'm Judith Jones, and I'm from New Futures and also the New Hampshire Alliance for Healthy Aging, and wanted to talk a little bit about older adults and the impact of this bill. And in the fall, what we did is listening sessions, and we went to a rural community in New Hampshire, and we heard from older adults about their use of SNAP benefits, and they told us how they had to prioritize, and sometimes they had to pay for medication before food or fix the car before food. And they told us about how they use SNAP to get better, fighting cancer. We had someone with celiac disease, and someone else talked about being on SNAP with diabetes. The other thing we heard from these folks was that getting SNAP for them now was difficult. And when we asked these individuals, what would you have us tell lawmakers? What they said was, we don't really want to ask for this help. Please don't make it more burdensome, and please walk a mile in our shoes. The concern with some aspects of the bill, you're looking at categorical eligibility, and we heard from the department that is eliminating families from SNAP. One of the concerns with administrative costs, are you then taking away from benefits? Are you adding a burden to the department with really diminished return on investment? Older adults are stigmatized by using SNAP, and concerning additional barriers, they underutilize the benefits and concerned that they would then be less apt to use the benefits. We've heard about the harm to retailers, and some of the studies I've looked have showed that trying to use SNAP to change food consumption is ineffective. And so just the question, does this bill add more harm, more burden, and just diminished return on the goal of feeding more folks in New Hampshire? Thank you.
Are there any questions? I just want to my own clarification, the way it sounded to me is you're more concerned about the administrative aspects of the bill than, I mean, you did mention some issues about the food restrictions, but your biggest concern, it sounds like, is the administrative burdens.
The concern would be the burden on the department. What is the return on this huge investment with staff? The burden on applicants, and if we're limiting choice for folks, is that really effective? Are retailers going to drop out when studies show there are other ways to get folks healthy?
You would agree, though, that soda and candy are not healthy.
So I will say you're talking to a vegetarian, and I have.
So you probably didn't appreciate my carnivore comments a minute ago.
Look, I'm still here smiling, and I thought, I'm not going to say I'm a vegetarian, but now you opened the door. So,
That's all right.
Yeah.
God bless you. You don't know what you're missing. Thank you very much. Laura Milliken.
Laura was at a separate hearing, so I wanted to just be here to make it very brief, and she can answer any questions. My name is Riona Kaur. I'm her Deputy Director at New Hampshire Hunger Solutions.
All right.
And I'm Laura Milliken. I'm the Executive Director. We're a nonpartisan nonprofit who advocates to end food insecurity in our state. Oh, I'm sorry.
3 seconds.
3 seconds? We appreciate the opportunity. So New Hampshire Hunger Solutions stands in strong opposition to SB 615. The bill doesn't just add red tape, it significantly weakens our food safety net and will throw thousands of Granite Staters living with food insecurity off the program. The state is already absorbing a huge new administrative cost. An additional 25% of the administrative cost has been shifted from the federal government to the state. And so the single biggest thing that causes error rates is complexity in the program. And so adding complexity to the program is very likely to cause the error rates to shoot up. And as we know, error rates in the future will cause an additional penalty for the state of millions and millions of dollars. The bill negatively impacts the working poor and older adults. Removing categorical eligibility creates a benefit cliff where a small raise at work can actually leave a family poorer because they lose hundreds of dollars in food assistance. It's a disincentive to work because it punishes families who are working more hours but can't keep up with the cost of living. And I think other people have talked about that when a family loses SNAP, their children automatically lose eligibility for free and reduced meals. So the cost for children will be disproportionate.
The question for the student that was prior is that the direct certification for school meals from SNAP, majority of those individuals who are receiving free and reduced school meals, they are direct certified. So we do have data from one school in Somersworth, New Hampshire that has 495 students who are receiving free and reduced school meals. 395 roughly are direct certified through SNAP. There's only about 100 kids who are eligible through those free and reduced meal applications. So that's where her information from reduction in free and reduced meals came from. It is an indirect ripple effect from this bill.
So I think you've already heard a lot about the massive fiscal liability that this bill would bring to the state and to retailers. It also just criminalizes normal behavior. You heard Carrie Duran talk about, going to Boston and spending dollars there because she needed to be at medical appointments. New Hampshire is a state with a ton of border towns. People cross the border all the time for all kinds of reasons. So the idea that they would be criminalized for going out of state to purchase anything is really concerning. And then finally, I just would point out that healthy food is expensive. The studies show that restrictions don't change buying or improve health outcomes. What does improve health outcomes and healthy buying is SNAP incentives, giving people more dollars to be able to afford fresh fruits and vegetables. In New Hampshire, we have Granite State Market Match,
and double up food bucks that give people more dollars to buy fresh fruits and vegetables. Those programs exist and could be bolstered, and would be a much better way of ensuring that folks could eat healthy. Did you have other points?
Yes, so there was a question about the error rates. I do want to point out that New Hampshire error rate's around 7.57. 3% of that error rate is underpayment. If you look at the statistics across the nation, that is top 3 of the underpayment. If we take underpayment out of effect, that if we go and take majority of the others, it would be about 0.5%. We would be under that threshold of 5%. Yes. New Hampshire's error rate is 7.57%. That's not current, but that is what is posted. And correct, 2024. 3% is due to underpayment. SNAP.
So an error rate is caused when a household is either overpaid or underpaid. Both of those contribute to the error rate. So
New Hampshire lies in the top 3 most underpaid out of the nation. If you look at all the statistics underneath, around 0.5% to 1% is where other states are, and some lower. If we take underpayment more to that threshold, we would be under the 5% error rate. I don't know how to do that, but.
Well, it's certainly providing the department with more ability to train staff and more staff. The department is currently grossly understaffed, and adding complexity to their program would further burden them.
I just want to camp on this a minute. So 3% of that 7.5%. So take that away, we are 4.57%. 3% is underpayment.
Underpayment of SNAP
Why
benefits.
would we underpay?
Because
How does that happen?
An error rate has nothing to do with fraud. It's
No, I understand that. Yep,
Just a straight
errors across the board, but
so sometimes state workers make mistakes. Sometimes families make mistakes that cause there to be an incorrect calculation of how much benefit the family should get.
so
So
we could
when the
lose
family is
$8 million because we didn't pay enough.
Correct.
Oh,
So we need to be sure that DHHS has the staffing and the training to run this very complex program. The SNAP program is very, very complex already.
You mentioned Double Up Food Bucks.
Yes.
I tried to get in touch with that program in the fall, and I haven't.
It's through the food bank.
Can you-
I'm certain
I don't know
that
if you
they'd be
can
happy
put
to
them-
talk to you. They're not here
Yes.
anymore,
No,
but
they left. I realized that, but I just remembered that was a program.
yeah, no, I'm happy to
I was in
connect you with
DC
with
for
the
a
food
SNAP
bank.
conference, and they were talking about that, and I think we have it, and I'd like to get some more information about it.
Yep, so that is at Farmers Market.
So that's the
New Hampshire Food Bank,
food
correct.
bags. Okay.
They did just step out. And there is studies from other states who do health incentives that does help the overall general public's health. And this is also something, I do have a nutrition degree. I did go to schooling. I was the WIC director in Stratford County for 15 years. So I also have that under my belt. And I do want to say that children need calories. That is what they need to grow. And that is the BMI. I'm at a BMI over 25. That means I am actually obese. So when you look at BMI calculations, that is not an accurate way of health. Bodybuilders have a high BMI. So that is something that we do want to take in consideration of this bill, that BMI is not a great indicator of health outcomes.
Bodybuilders just leave me out of this bill.
Yeah. Any other questions from the committee?
No, I have some written testimony.
Yes, if you could leave that would be great.
Fact sheets.
Senator Prentice did ask about how much a small retailer would be spending additionally to these SNAP restrictions. And of course, there is a range, but it's about $1,000 to $8,000 per one retailer to implement the SNAP restrictions. Pardon me.
All right, thank you.
Thank you so much for your time.
You're welcome. Raymond Burke.
Good afternoon. My name is Raymond Burke. I'm an attorney with New Hampshire Legal Assistance. We are a statewide nonprofit law firm, represent low-income households throughout the state, including those low-income households who are having trouble accessing SNAP. I'm here today to oppose the bill. I'd like to say that we share a lot of the concerns that have already been raised by many others who oppose the bill, but I'm going to try to focus on things that haven't been said. And I'm going to pick up where we left off, just a word about the payment error rate to be clear. I can give you an example. As the folks just said, the payment error rate is made up of overpayments and underpayments. In 2023, the primary cause that the department had identified as causing underpayments was related to how they calculated what's called the standard utility allowance. So the program is very complicated. They do a budget that looks at household income and expenses, and certain expenses count, certain expenses, there's a dollar figure for them. And so in 2023, as a state, we were making errors in how we looked at those utility costs and those housing costs, and it led to errors, and that can contribute to an underpayment of SNAP benefits. We don't see this bill as primarily addressing the fundamental causes of error rates. The other thing I just want to clarify, I think it came up a little while ago, the part of the food choice part of this bill doesn't impact the payment error rate. The payment error rate is about how the state is determining a household's eligibility and calculating their monthly benefit about it. It doesn't factor in what types of foods are being purchased, or it doesn't factor in, to the extent there's retailer fraud that was spoken about earlier, that's not factored in. We actually see this bill as potentially increasing our payment error rate, and that primarily has to do with removing the state's ability to implement categorical eligibility. As you heard a moment ago, categorical eligibility does help working families by addressing the benefit cliff that happens when you earn a dollar over that federal poverty limit, that 130%, which today is $2,888 for a family of three. But the other thing that categorical eligibility does is reduce the complexity, streamline the eligibility process. It helps not only the household, but it helps the department, because as Ms. Hebert said, what can cause errors is when you have more manual work. Well, if you remove categorical eligibility, you're creating more manual work. There's more things that have to be verified. It's not just about what the income limit becomes. There's more, it can increase what we call churn. And so that is one of our biggest concerns with this bill, though we share others. And I'll just say, to also offer an assist to the young student who did a great job, the other way this bill takes food off of the tables of households is by removing categorical eligibility. As the department testified, there are 7,000 households, which would include, I believe, 6,000 children that would lose benefits as a result of that part of the bill removing categorical eligibility. So it not only impacts the free and reduced lunch, but we would be changing eligibility and eliminating some folks from the program. So thank you for the opportunity. I know it's been a long day, and I'm happy to take any questions.
Yes, thank you. And I have my questions here. It has been a long day, so if you repeat it, if you said this once, I apologize. So you said that the biggest contributor, in your opinion, to the underpayment is the utility allowance.
That was based on data. That's from, so you'd have to talk to the department what the current, but in the most recent I had access to, because I don't work at the department, is in 2023, one of the biggest contributors that they identified, the number one, was incorrectly calculating this utility deduction that goes into the SNAP budget.
Okay. And the other thing you said, that this reporting doesn't address the most common causes of errors.
Yeah, I don't see this bill. I mean, again, you can.
What is the most common cause of error in your?
So based on that data that I've reviewed, there were three things the department identified. It was problems around the utility deduction, and then it was, as Ms. Milliken just mentioned, just mistakes by the household and the department related to things like when a house obviously has to report their income. And so if the state miscalculates the income when they're doing the budget, that can lead to an error. If the household doesn't report a complete picture of their income, that can lead to an error. And that's not always fraud. Most of the mistakes are unintentional. So there was the reporting or calculation around income. And then I think the third was related to, if I'm remembering correctly, how the state was determining the certification period for the households, which, when people apply, the state has to first determine if they're eligible, and if they are, then they assign a period of eligibility. Usually it's 6 months or 12 months, and the people have to redetermine their eligibility every 6 or 12 months, whatever it is for their household. And my understanding was the state was not, based on, the federal statutes and regulations, was not properly assigning the certification periods, and that led to payment errors.
Okay, and the last thing you said is this new robust reporting requirement may actually increase our error rate.
Yeah, so categorical eligibility was designed to help working families and to streamline eligibility. So it reduces some of the, there's a couple of ways. You can look at information from other programs. So for example, if someone is receiving SSI, let's just take an easy example, single individual getting SSI, they are categorically eligible because we know SSI has a maximum amount. If you're getting SSI, it can only be up to a certain amount. And we know to receive SSI, you can only have as an individual up to $2,000 in countable assets. So by definition, you meet those income and asset tests of SNAP. And so there's no reason for the state to kind of do as big of a review as they might do for someone else who's not getting SSI, where we don't know what their assets are. We don't know, exactly what their income is unless they tell the state or the state sees it in one of its databases that it can access. The other part is, now SNAP, again, as we've heard, is very complicated. There are some assets that are countable assets, and there are some that are excluded. So for example, most retirement accounts don't count as assets for SNAP. Broad-based categorical eligibility sort of streamlines that process, so you don't have to look at assets in the level of detail that you look at if you're not using broad-based categorical eligibility. And those of us who support it, it makes sense. When you look at the data, most SNAP recipients have minimal resources. People who are applying are not millionaires. There was a 2019 Urban Institute study that found of the states that implemented broad-based categorical eligibility, SNAP recipients were more likely to have a bank account and have at least $500 in that bank account. So we're not talking, categorical eligibility doesn't, flood the rolls. As the department testified, this only affects 7,000 households. I think that's about, if I did the math right, 15 to 16% of our total SNAP recipient pool. So, but we're still concerned about those working families who would lose benefits as a result.
Great, thank you. Any further questions? Thank you very much.
Thank you.
Timothy Puglisi. Last one. Me too.
Thank you, Mr. Chair, members of the committee. My name's Tim Puglisi with FGA Action, here today in support of Senate Bill 615. We work in about 40 states to promote self-sufficiency and reduce government dependency. So before I address any concerns, I wanted to talk about this concept of categorical eligibility. We're not talking about traditional categorical eligibility where somebody is within the limits, the asset and income limits of the TANF program, making them categorically eligible for the SNAP program. We're talking about broad-based categorical eligibility. And the way this works is the state is allowed to administer what are considered non-monetary welfare benefits using TANF money, so non-monetary TANF benefits or maintenance of effort benefits. In New Hampshire's case, this is often a welfare brochure. Anybody can receive this brochure, and if they receive this brochure, the asset limit or the asset test is entirely waived. There's no limit on assets, essentially. That's the way it can be. Additionally, it raises the income limit that is set in federal law at 130% of the federal poverty level to 200% of the federal poverty level. Now, the reason I bring this up and why this is so important is despite claims today, there has been reports from the GAO, I believe, don't quote me on that. We have citations that I certainly can follow up with that reveal that households enrolled through this broad-based categorical eligibility loophole are 3 times as likely to receive payment errors, which obviously is a big concern with the payment error rate penalties looming. Additionally, these households that are enrolled through broad-based categorical eligibility have resulted in the fact that nationally we see that 1 in 5 food stamp enrollees or SNAP enrollees have more than $100,000 in liquid assets. Now, I want to talk about this broad-based categorical eligibility and federal asset limit and income limit tests. So the federal asset limit only looks at cash in the bank and other non-essential assets like second homes, second vehicles like ATVs, RTVs, and snowmobiles. It doesn't look at primary vehicles, primary homes, pension accounts, retirement accounts. And when talking about the income limits, when you are talking about a disabled or an elderly household, that income limit is counted when, after looking at shelter or housing costs for those that are elderly or disabled households, and after medical costs. So it's only the income that they're receiving maybe from their retirement account or Social Security, minus the medical and housing expenses that they might incur. Additionally, elderly and disabled households have higher asset limits than the traditional able-bodied household. So that's just something I wanted to address on broad-based categorical eligibility, which is what this bill is about. It's not about traditional categorical eligibility. On the topic of the soda and candy waiver,
You have to wrap it up.
okay, I just wanted to say
I'll let you finish that thought.
one sentence.
Yep.
The sentence is, we've talked about the cost retailers incur, but this is a taxpayer-funded benefit. Should it be going to products that are clearly linked to chronic diseases or to real food? So, thank you.
Thank you very much. And I think Senator Abart has a question for you.
Yeah, so basically, this whole broad-based category, you kind of lost me a little bit. Could you repeat the eligibility part of your testimony?
Yeah, broad-based categorical eligibility, BBCE is the acronym they use.
Yeah.
Essentially, if the state, the welfare agency, DHHS, can give out what are considered non-monetary TANF benefits. In the case of New Hampshire, this is a welfare brochure. And that welfare brochure makes it so that the state doesn't have to actually check their assets because they're considered categorically eligible because they received this TANF benefit, which is a non-monetary TANF benefit, if that makes sense.
Right. And you had mentioned about candy?
Yeah, my closing comment was about how the question I propose to you all on this committee is, should food stamp SNAP benefits be taxpayer-funded benefits be going to the purchase of soda and candy, which are directly linked? And I'm happy to follow up and share many studies that link soda consumption to chronic disease. Should I be going to these products that are linked to chronic disease and that you will pay for in your Medicaid and Medicare programs because treating these chronic diseases, or should these benefits be prioritized to real, healthy, nutritious foods? It's just a question.
Yeah, one more.
One more.
Yeah, I promise it'll be mine. So in other states where they've adopted this program, it seems to be the testimony was pretty sanguine about their results and people basically not complying. Are you seeing that as well?
On the soda and candy ban,
on the compliance end of it.
For the retailers?
Yeah.
So this has only been in effect for about 15 days. There has been no public information about retailers being in non-compliance. Again, there's a 90-day grace period for a reason. I know the folks at the welfare agency FSSA in Indiana, they're working closely with retailers to avoid having any compliance problems. FNS is too. They want this to succeed. They want to work with retailers. They are working with retailers to make sure these programs succeed. Looking at these waivers, states are finding ways to be nimble in investing to ensure that retailers have clear guidelines, posters, different documentation to share with retailers to ensure that they are enforcing these requirements soundly. And again, somebody mentioned earlier, and I appreciate them mentioning this, states are being very specific in telling retailers what to prohibit and not to prohibit. So once these definitions are formed, these state agencies are compiling concise, concise lists of what can and can't be considered soda and candy, ensuring that retailers can accurately update these systems that are updated every single day with countless different items, and they're subject to many different regulations, whether it be in the WIC program or in the SNAP program. SNAP has many items that are in these stores that are already prohibited, whether it be alcohol, tobacco, toilet paper, diapers, hot prepared foods. So again, it's just more items that are added to this list that are to be flagged in the POS system as not eligible with SNAP benefits.
Any other questions? Thank you very much.
Appreciate your time. Thank you.
All right. That's the end of our list. Is there anyone else that would like to speak on Senate Bill 615? Oh. All right. Well, I must have missed you. Come on up. Oh, Emily Lawrence? Okay.
Well, this is really low. Okay.
You can sit in the other one if you'd prefer.
No, it's okay. I'm here now. I was going to say good morning and then it was good afternoon, so good evening.
All blends together.
There's so much packed into this bill, so I really just picked the salient points for us, but I really want to thank the folks before me who have also looked at different parts of this. It's a complicated bill, and I feel like if you go all or nothing on this,
You
it's
could
going to be...
just state your name for the record.
Okay, sorry, Jane Goodman.
All right, I'm looking for your name here.
Probably can't read my chicken
Oh,
scratch.
you didn't check the speaking box.
Oh,
Oh, so
I didn't follow directions. Don't
my
start
bad
doing
on
that.
Emily, but
Okay.
next time. Check the
Sorry,
speaking box.
Geez, and I've done this before.
I know,
All right.
that's all right. It's a new year.
So, thank you for taking my testimony today. I am Jane Goodman. I'm the Executive Director at the Nashua Soup Kitchen and Shelter. A little bit about the Soup Kitchen. We've been serving the community for 45 years, providing hot meals and food pantry services with dignity to individuals and families in need. Over the past year, the need for our services has grown dramatically. From FY24 to FY25, we experienced a 32% increase in breakfast served and a 9% increase in dinners. In our pantry, food box and fresh food visits increased by 12%. These are our neighbors. These are working families. They are seniors, and they're people experiencing homelessness, people who simply cannot keep up with the rising cost of food and living. At NSKS, we see firsthand what happens when people lose access to SNAP. SB 615 would reduce eligibility and add administrative hurdles that would cause hundreds of Nashua residents, and I'm speaking for our region, including children and older adults, to lose reliable access to food. And when SNAP is weakened, people don't stop being hungry. They turn to emergency food programs such as ours, and we're already really stretched thin right now. We saw this clearly during the 2025 shutdown when SNAP became inaccessible. Luckily, it was only for 3 or 4 days. Our pantry enrollments increased immediately. People were scared. They didn't know where their next meal was going to come from. And we distributed over 400 emergency SNAP relief boxes along with fresh fruit to families in crisis. That relief was funded by the state of New Hampshire and signed by Governor Ayotte, underscored how essential SNAP is. SNAP is the first line of defense against hunger. For every 1 meal a pantry can provide, SNAP provides 9. SB 615 would also eliminate expanded categorical eligibility, and I don't want to beat a dead horse. You've heard enough about that today. But what does that do? In summary, it pushes working families, seniors, and people with disabilities off the program while increasing administrative costs for the state. This does not improve program integrity or health outcomes. It simply makes it harder for people to eat. From where I stand, serving meals every day, this bill would increase hunger, strain charitable food programs, burden DHHS, and hurt local economies. SNAP works, weakening it now is the wrong direction. I respectfully urge you to vote no on advancing this bill.
Thank you very much. And I asked the same question of the previous speaker. It sounds like your biggest objections is more to the administrative changes, and that would be a bigger effect on access to SNAP than soda and candy.
Well, yeah, I don't even want to deal with the soda and candy. Like, I could get into all the dignity pieces and the stigma and all of that, but my colleagues here have all done that.
Sure.
So the administrative, anytime you erect barriers for someone who is low income and already struggling, they're going to go off the program. You're limiting access. So yeah, I'm very concerned that you're going to throw up more barriers, make it harder for people to be eligible and to receive the benefits that they truly need.
Okay, thank you. Any other questions? All right, and we'll make sure we check that box next time.
Yes.
Yes.
Lesson learned.
All right, last one. So Emily Lawrence, and this was my oversight. I apologize. You signed up on the first page, and here we are. Got three pages later, and so
That's all right. It made my testimony shorter because other people already shared some of the things that I was going to say.
All right.
So, good afternoon, Chairman and committee members. My name is Emily Lawrence, and I'm the Advocacy Director with Waypoint, and I am here today to speak in opposition to Senate Bill 615. I just want to give a little bit of background about Waypoint so people know the work that Waypoint does. For over 175 years, Waypoint has been serving individuals, children, and families in our communities. We work both across the age spectrum from birth until to the aging population, as well as across the entire state. We provide therapeutic counseling, in-home services for families that are involved with DCYF, as well as for the Choices for Independence program, so individuals with disabilities and our aging population. We also work with families on early supports and services and provide various other family support programs. And we have a program that works with or a number of programs that work with homeless youth. We have 4 family resource centers across the state, and last year alone we served over 12,000 children, youth, and families. Because of this broad experience, we have firsthand understanding of how the SNAP policies can impact children and families, and I just want to focus primarily on the impacts that we are concerned about for children. I have written testimony, and so I'll rely upon that for most everything else, as well as providing some research for what I'm going to say today and what is in there. What I would like to do, you've heard a lot, and particularly in the last half, about the administrative burden that will be put on the department. Our staff work regularly with the department to ensure that individuals obtain and maintain their benefits. We often have staff in family resource centers who can help people determine eligibility and figure things out through the system. We see that this department is already overburdened. There are already delays in trying to get benefits. When those delays happen, people don't have food. It could take longer, or they could have gaps in their service. What we know is that when people experience food insecurity, it can lead to family instability. It leads to stress, and that stress can somehow come out in the form of families becoming involved in child welfare. And we see this both in terms of, we also see it in terms of healthcare coverage, but in terms of obtaining food and being able to put food on the table for your family. And so our concern is really that those burdens are just going to increase for the department. That's going to either limit or delay the ability of families to get food for their children. And that could lead to further harms and additional burdens on the system. We also know that if children don't have food, and we've talked about the options, healthy food options, they could get adverse health impacts. And so that will also impact both their well-being and our system. And so thank you very much.
Thank you very much. Thank you for your patience today. And again, I apologize.
Sure, no problem.
Is there any questions from the committee? Anyone else that would like to speak on Senate Bill 615? I'm going to close the hearing. So the business of the day is concluded. We will be back on Wednesday, 9 o'clock. All right, very good. Thank you.